Okay. So share screen should come, no? Can you see my presentation? Yeah, it's open now. Okay. How do I? Oh, okay. I should move. Where is it? On the top, is it? Where in the hell is that? Wait, minus on right at the bottom. English, where in the hell is that? Window, right hand side, which is at minus plus here. I can't see top to. It's right on the top only. It says slideshow. No, I put it on slideshow from beginning. Huh? Okay, how does that go? Where in the hell is that? Huh? Yeah. From beginning. Yeah, correct. Yeah, from beginning. Yeah. Okay. Yeah. Okay. Okay. Now, okay. Yeah, correct. Okay, fine. Yes. Yeah, I've got that. Yeah, fine. So I'm all set. Yeah, all set. Yeah, thanks. Thanks. Okay. Yeah, sure. Okay. 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 Yeah. Gauri, I can't hear you. Why? Yeah, I think so. But yesterday night it was on, and I mean I had done a webinar for ICANN yesterday. Wait, where? But how do I know that? How do I make a? Let me see. Remote auto not mute is not. I'm not muted. Chat news share pause. How do I more? Should I do something in more? How do I know if I'm not? Yeah. Should I minimize this and go back and see by any chance if I muted the? No, it didn't say anything. Should I try again? Okay. Okay. Yo, but now it's moved to go back. How do I go back? Yeah, it's not going. Why? Why is it not moving? Back arrows, your screen sharing live, but it's not moving my back. Okay. 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 Now I have to start from where in the. Okay, go back to slideshow. Is it new sharer? Why? Where in the hell? I can't see that again. New share, huh? No. Why new share? So where in the view help? Let me make, how do I maximize this? Okay, 1 minute. 1 minute. 1 minute. Okay, now I go back and slideshow and beginning. I have to start, no? From beginning. Yeah. Okay, fine. Yeah. 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 No, it's not bad. Okay. Can you hear me? Okay. Okay. But I can't. Okay. But okay. Admin. Okay. You tell me when to start and I'll start. It is ready. It's from the beginning. It's ready from the beginning. No, from here. For me, it is from the beginning. I've got from the beginning. Why? It's I'm the from here. Okay. What do I do for that? I've gone to resume share. Is it? Okay. Resume share, and then go from the beginning. Is it? From beginning. Is it okay now? Yeah. Is it okay? It's from the beginning. From my computer, it is showing from the beginning. You are sharing. It says you are sharing. You are screen sharing. It says, and then there is nothing else here. There's no top show anything. No new share. Nothing. It just says you are sharing. Live. Should I say stop sharing? And no, no, my connection. Yeah, why are you saying that? I don't understand. Yeah, because yeah, mine is full screen. It's showing from the development evaluation. First slide is on. Okay. Okay.
Recording in progress.
Yes, sir, nothing is happening here. Hey, have you started what? I'll ask her what's happened. Ask her what's wrong. Yeah. Hello. Hello. I'll see you later. You're going? Bye, beta. Hello. Okay. Oh, okay, fine. That's I don't have to worry. So you will call me when you're ready to start. Okay. Okay. So I just leave it here and yeah, you give me a call. Okay, dear. I was wondering if something is wrong. I didn't want to be the cause of delay. No, okay. Otherwise, I said I'll do it with the phone and you can do the projection. I thought, okay. Okay, 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 dear. Okay, thank you. Yeah. Hey, hi, Hanisha. Where? Yeah. 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 What is it? What, which one? Which? Yeah. 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 This, which, where in the top of the screen? I mean, I don't. Yes. This one. Yeah. 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 I can't. Yeah. I can't. Yeah. Yeah, Anisha. Huh.
Hi, ma'am.
Yeah. Where is on the top?
Ma'am, can you show me the laptop?
Yeah. You're talking somewhere here, no? Here.
I can't see the laptop, ma'am.
You can't see.
I cannot see the laptop.
Yeah. Can you see now?
No, I think you can switch the camera to the. No, I can't see.
Okay.
Can you
Now,
switch the camera to the opposite side?
what is that? Okay. What do you mean, like this?
No. In your phone, there is an option saying switch camera to opposite side.
Wait, let me see what in the heck is this here. I told her she
Just
can do the
tap on,
projection.
you can see a mute.
Yes, I can.
You can see the mute button.
Yes.
You can see the video call button.
Yes.
There is one more button which has the camera symbol. Press that.
Yeah. Okay. Then, okay, I pressed it. Then, can you see now?
Yes. Now show me your laptop. No, I can see. No, ma'am, I can't see the laptop. I can only see the.
Okay. Now, can you see the laptop? Now you can see the laptop.
Yes. So Yes.
Yeah.
Yes. On the top, can you see the dot?
That
which is
light.
the camera?
That light, no?
Yes.
Yeah, that
Yes.
light, is it? Where is it?
Yes. Can you move to the left and right?
The
There
light.
is a black thing covering that light.
It's not moving.
Ma'am, there is a black thing on top of that. Basically, that is the camera lens. Okay, so there is a black thing where you can close the lens, and if you slide it to the other side, the lens will open.
Is it okay now?
Can you see the camera?
Yeah,
Camera lens?
is it open? I can see myself. You should be able to see, you know, if I can.
That means your video is on.
Yeah.
Yes. If you can see yourself, which means the video is on now.
Yeah.
Yeah.
Okay. Yeah, now I have to go back to that. Okay. The whole thing again.
Now you can share screen, ma'am. Your video will be seen.
Now I have to, okay. Now is it okay?
No, I can't see this laptop.
You know, but I can see myself on the screen of where the admin is. So that means my camera. This thing, slideshow on, everything. So what is to be done now? Okay.
No, they should send you the link. I don't think the link is open yet, right?
They have. It's open.
Only when the meeting starts.
No, they opened the link. I can see Avinash Bhosle, Usha Reddy. I can see so many people there.
Have you started screen sharing?
No, they haven't asked me to do anything. The admin hasn't said anything.
Okay, then no need, ma'am.
Okay.
Okay, let them come. Let them make you the co-host.
Yeah.
Then you'll get share screen option.
Yeah. Okay. Okay.
Okay. Sure.
Thank you.
Okay,
You.
Bye.
Bye.
No problem. Bye.
Just leave my breakfast on the table. Oh, then I can.
Recording in progress.
Have it started? Hey, Hanisha. Hello. Have they started? Yeah, have they started the meeting? No. Acha, because nothing is happening in my computer or in this thing, you know. I think, oh, okay, that's all. Because I was wondering, 9 o'clock is supposed to start, it's already 9:30. I think they're having, okay, you are attending it, is it? The South Zone Conference? No. Okay. That's all. I just wanted to know, am I still something to be done from my end, you know, or I'm fine now? Okay. Okay. Thank you. Okay. Okay. Bye.
Hello. 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 Hello.
Hello?
Hello, madam. Can you hear me?
Yes, I can hear you.
Okay,
Not
madam.
very clear, but.
Okay, just some technical issues. We are about to start.
Okay.
Just give us few minutes.
Okay.
It's all done.
Sure. I'm okay. Yeah, fine. Okay. Yeah. Anjana.
Hello.
Yeah.
Madam, can you hear me?
Okay, that's all. Okay.
Madam,
Yeah.
can you hear
Yeah.
me?
Yes, I can hear you, Ravi. Yeah.
Okay, madam,
I
we're all set.
can.
Just few seconds.
Okay, fine. He's okay. Yeah, okay, bye. No, I will. I'll just put it properly. Is it okay now? Yeah. No, I will. I'll just turn it on. Okay, thanks. Bye.
Devika, can you use that link? Of the screen. Cut, Marna. Okay.
Hello?
Hi, madam. I'm just about to start. I'm just going to introduce you.
Okay.
You ready?
Are you going to give me share screen first before you start, or is it, I mean, it's all done?
We are already here.
Okay.
1 second, madam.
Are you going to make me the co-host to share screen, or it's...
Hold on, madam. If the host can share. Madam, you have already shared. Just
okay, fine. Sure, start.
Madam, just move the slide one down.
Yeah, it goes.
Yeah, that's
yeah, it's moving.
Okay, madam. Let's go back to
Fine.
the first slide,
Fine.
madam.
Yeah, sure. Thank you.
Hi, good morning, everyone. Welcome all. This is a very interesting start post-COVID. Probably this is the first time a physical conference is happening. Thank you, everyone, for coming. So briefly, let me introduce myself and my team here. I'm Dr. Ravi Kumar. I'm a consultant pediatric neurologist based in Aster CMI Hospital. My team of developmental physician, optometrist, physiotherapist, psychologist, special educator are here. And I see Dr. Swapna from Madanpalli, Dr. Venugopal from Shivamogga, and Madam yourself? Oh, Dr. Gayatri from Bangalore Medical College, sir. Oh, Dr. Balu from Kadapa is here. So we have elegant speakers today who are going to give us a good insight onto neurodevelopmental work, what we do, and what can be done by anyone else. So let me welcome by starting Dr. Nandini Mundukar. So it will be an underrating to state her as the guru of neurodevelopment especially in Karnataka. Most of the people who are practicing neurodevelopment in Karnataka are our students. So our students are elsewhere as well, but I'm sure she is the main main teacher for all of us, including me. So Dr. Nandini Mundukar has almost 4 decades of work in the field of autism and neurodevelopment. She runs 3 centers.
We can't hear you. Hello? Hello?
Can you hear me?
Yeah.
Can you hear me?
Yes, now yes.
As I mentioned, Dr. Nandini Mundukar was also instrumental in setting up the Aster Neurodevelopmental Center. So I welcome Dr. Nandini Mundukar to give an insight onto developmental evaluation. When and where does it start? Over to you, madam.
Yeah, thank you. Good morning, everyone. Can you all hear me? Am I audible? Hello?
Madam, we can hear
Hello,
you.
am I?
We can hear you.
Okay.
We can hear you.
Good. Yeah. Good morning, everyone. And it's always a great pleasure to share my little knowledge, what I have with everyone. And I'm extremely passionate about this subject. And today's topic of developmental evaluation, when and where to start. I want to say one thing. Any specialty you may be in pediatrics, but always remember you are a father or a grandfather or an uncle or a friend's looking after a friend's child, and you have every child of yours which comes to you needs, if you really want them to give a start in life, to give them the best, then a developmental evaluation for you is a must, because it's a must for everyone, because child development is important to each one of us who deal with the children, and every one of us in our life have a child. Now, nobody better than these 2 wonderful people have put up a model which in 2 slides tells us the whole thing about what developmental pediatrics is about. Is the Samaroff-Chandler model. It says we have to see the child and family in this dynamic period of its development, which is, what is the period of its development? In the first 5 years. You see, what does he say? At birth, we have a biological endowment that we are born with a sensory system, a motor system, and a neurological capacity, which can be intact. That is, if the child has not had any traumatic events during birth or after birth, or it can be impaired. For what? For organizing our experiences and interacting with the environment. So this neurological system which we have has only 2 functions to do. We have to organize our experiences, because that's what life is all about. You're organizing your experience and you're using the environment for your betterment. So what does the model assume? That the infant, the caregiver, and the environment determine the child development and behavior. So you have the parent, you have the child, and the environment, in which, of course, pediatrician is a part of the environment, because you're going to support. Supported by brain research and development shows that caregiving and social factors mediated by the sensory system as well as the genetic influence shape the developing architecture of the brain, associated with changes in development and behavior. So what does it say? That the sensory system, that social fabric, the social society which you're in, which the child develops, is so important, and the genetic which influences, and the environment. So when you have an enriched environment for growth and maintenance of the synaptic connection which happens in the brain in early years, this is, if you use it, you grow it. If you don't use it, you prune it, and this becomes an unused connection. So you can see how useful it is to stimulate a baby in the early years. Stressful experiences can result in neurochemical changes that can lead to even structural changes in the brain. If you stress the infant, you can cause damage enough to the brain for even that the fragile neurodevelopmental system or the synaptic connection can alter itself. This explains the whole thing, and this is the whole basis of the current epigenetics. And this, in the last 2 decades, child development has undergone so much transformation that this is what it is. So today we will see what is developmental evaluation. We'll have some predictors and we'll do some screening and we'll talk about the role of intervention and whom to refer to and the role of pediatrician. See, what is developmental evaluation? It is a process which provides information on all the streams of development. What are they? Gross motor, fine motor, language, communication, and social. So based on the normative data, they're called milestones that every child has to attain a particular developmental stage. And this is not a point, it's a range. And that which it attains is why is it important? Because it is predictable and it is sequential. And let me give you an example. All of you are very familiar with walking. A child can walk from 9 months to 18 months. That's the range. If it does something below that, it is abnormal. If it's above that, it's also abnormal. So, but this is sequential. That is, the child will first roll over, then sit, then turn, then stand without support, and then take the first step, then start. So this sequence is predictable and you can know on which stage. So the caregiver has to know, is the child developing age appropriate in the development in the 5 streams which I've told you. So you have an opportunity, if you know the range, if you follow milestones, if you follow screening, you have an opportunity to detect any delay or deviation in all these 5 streams. And remember, you have a huge number of population of 5 to 10% which have some form of disability or other. So what are the domains in development? Cognition. Cognition means intelligence. But you see, each one of these domains influence the other. They're not by themselves alone that, oh, language, I'll only do language, cognition, I'll only do. No. Then cognition definitely influences language. It's got a visuomotor, problem solving. Whereas social emotional is so important for communication and intelligence and adaptive. Motor, as you all know, is gross motor, fine motor. I think pediatricians definitely know about motor development. Speech and language is all about how you speak and how you understand and how you speak and how you communicate, whether it's words or whether it's written, all these things comes there. Now, this chart is, I think every one of you must take this and put it into your reception. So it tells you exactly at 3 months, 6 months, 9 months, 2 years and 3 years and 5 years, what are the milestones a child has to undergo. For example, you see, it says 3 years, what it's supposed to do, turns his head, it has a familiar, watches faces. By 6 months, the child starts responding to people's emotions. By 1 year, it starts walking and it starts saying, it says no. So these are all very, very important milestones, so this will take me a long time, within the half an hour, but it is self-explanatory. And if you have this, you had a chart. I think every pediatrician should put this out when the parents are waiting. You should say, go and see if your child is okay in the stages of development. If you have any concerns, do let me know, because some of you have very busy practice, so you don't really do any milestone screening or follow-up. So you see, they're all integrated across the domain, and sensory development has a very crucial role in the early development. Why? Because we see what is, when I say what is wrong in the society today, what I call is the diagnostic odyssey, is the pediatricians as well as parents do not monitor social and communication milestones because they're hidden. They don't show you like gross motor abnormal ways or anything. So if they think a child will just say a few words, yeah, language is good, but that social and communication milestone should be age appropriate. So you land up missing very, very important conditions like autism spectrum disorder, because the child will essentially look very normal to you, but maybe having only problem in social domain to start with. So please, it's essential. So you see the social emotional stages of development, which is so very important. And these 2 milestones, please monitor them, because you don't know them by heart. You can put them up in the chart, because it's if you don't have social connections, you cannot develop language and communication. If you don't have communication, your cognition, which you have in your brain, is not going to be told to others. So these 2 hidden milestones are so missed. So, and it is very unfortunate, doctor, that my child is not speaking or not responding to him, but they say no, he'll be all right, he's looking, see, he's running around, he's playing, why are you worried about it? No, any complaint by parents, please take it very seriously and do work on it. So what are the predictors of development? The
Hello, madam. Can you hear me? Hello? Madam, you have to unmute. Can you hear me? You have to unmute, madam. Yarappa, admin, no. Can you hear me, madam? Hello, who's the admin, sir? Please.
Yeah, is it okay now?
We can hear you, madam.
Hello?
Go back to the slide. Go back to a couple of
Yeah.
slides, please.
Okay.
One more back, please.
Okay. Here? From here?
Yeah. No.
Okay.
Okay.
Here?
Yeah. No,
Okay,
madam.
what I was telling you all is that the social and communication are the easily missed milestone by the pediatricians, because these are called hidden milestones, because the child may not show you obvious signs. You have to look for them, but they are most crucial, because social and communication lays the crux of your development later. It is not the gross motor. Your cognition can only work if your social and communications are fine. Otherwise, this condition, many of you who don't monitor this in the early years go on to miss conditions like autism spectrum disorder. So what are these two? The social emotional regulation is the child first aid. You should look, donkey, play hide and seek with them. Then there's a two-way purposeful communication. The child, your turn, my turn, Then the social goes on to imitating skills. That 2 years, the child will imitate you. After that, they'll start doing pretend play, like being a doctor or being. So these are the social skills. This is crucial, believe me, for your child. Any other thing you miss, you can. But if you miss social milestones, the development in jeopardy. So is receptive, and receptive is all about understanding. Expressive is all about communication. So this is very, very important for you all to understand. So let's see what are the predictors of development. Is first of all neuroplasticity, which you're all aware of, that the base of development. This is the fundamental you have laid now. If your first 5 years are not good, no matter, you are not giving the child a 100% chance for his total development. So if you see this child, that 90% of the brain development happens below 5 years. All the cerebral cortex are connected except the prefrontal. That takes a little longer. So if you see this, what happens first? Vision, auditory, language. You see attachment, that is a child's forming. Joint attention is when the child has sort of endorses you in his life as, yes, you are one of the partners whom I have to communicate, occurs very early. All others comes later. So you have to have a very clear understanding of how you manage these sensory systems and how you have handled them the early years. So what is the crucial nurturing factors which helps in growing? Warm and responsive parents, a good relationship, a safe environment, and a caregiver's competency. Caregiver's competency is something which you all develop as pediatricians may learn to build for the parents. So what is it? It says attachment bonding. That is when the child feels secure that, yes, I have somebody below me. They can take care of me. You have to build that security in the child. Sensory stimulation, which I told you, is all about all the vision, auditory, tactile. Sleep is so crucial. Nutrition, then activities for the brain. And if these, and you have to look for red flags, that is, then the brain is not developing. So this is what is nurturing all about, and today, and the basis of whole epigenetics, as I told you. Now, right now, I'm going to show you this because I got neonatologists there. This is the first sign of the stress in the child. Right, 27, 30 years, you go into NICU, the child will show you, I'm in stress, please help me. My sensory system is going all wrong. How does it show? You see this flaying of fingers, hand finger display, splay, and sitting in like as if, the posture like sitting in the air, foot splay, arching. These are the signs you have to look. Now, when I go to NICU, I was doing some round. They said, yeah, we do very good supportive care. I said, really? Morning, evening, night, we take rounds and we see the child and put them into containment or, I said, you don't do morning, evening, night. The nurse has to constantly look. The minute the child shows any of this, you have to immediately attend, because this is, you are giving the developmental delay to the child by not handling the stress. So don't do morning, evening, night. You have to stay in the NICU staff or everybody in NICU, so that immediately this is attended to. So now it comes down to what is developmental monitoring and what is developmental screening, and both. So monitoring is done by the parents. They watch out and come and tell the doctor, my child is not sitting, my child is not talking, or it's doing well or something. And so screening is what the parents come with a complaint, the doctors are supposed to do. You have to do it, if not every now, at least in the 9th month, 18th month, 24 months, and 30 months. Please, the health professions have to do with a validated screening tool, and then you can give a report on this. So what are the screening tools available to you? You have the DST, you have the Trivandrum scale, you have MCHAT, you have ASQ. Do whatever you're trained in, but you have to, preferably, if you do it on your well baby clinic, doing immunization, the 4th, 7th, 18th, 36 is ideal. Vision and hearing test is a must for every child. And ideally, you must screen all children. As I told you, autism is just not in high risk. It's for everybody, but high risk definitely. But for the IT savvy youngsters today, we thought, since they're not using the developmental school, we thought they would like to do something on their phone. So we have got a screening tool called Track and Act. If you all go to Google Play Store and download an app called TOTS Guide, and under that, you'll get a Track and Act. What does Track and Act tell you? It will give you milestones in all the 4 domains of social communication language. And it asks you key question. If you enter the name, date of birth, or the date of birth means when the child is full term, and it will ask you questions. Can your child turn around? Can he point? Can he say this? Can he stack the ball? Whatever. You all have to answer yes or no. Please answer yes if the child can do 70% of the time. Day before yesterday, he pointed once, the answer is no. He said, yeah, once or twice he looked at the name, the answer is no. If you can, you will get a score and you will know whether this child is developing normally or not. You can, and this can be kept on your phone. This is a cloud data. You may do it in 4th month and you feel the child is not so okay, repeat it in 7th month. And this is for you. And this easily done. You can carry it. It's an online screen and it is free and also available to you in Hindi, Tamil, Kannada, and English, 4 languages, So please use this liberally and screen your children. So then we come down to, after you tell us the screen and you send it to us, we have to now do into a very good, we have to draw, when you send a child, you have found something abnormal when you send it to people like developmental pediatricians, they like to do a full profile of the child in the 4 areas. What is it the child has got? And then of course we have our own scope profile, but we are not talking on that. So what next? After you find a detection, so what is the areas in which you have to have information performing an early intervention? You have to have all these areas because these are the ones which are affecting the growth of the child. Play, receptive language, expressive language, imitation, peer skill, motor skills, and intelligence. You have to know at every age, what is the stage of development in all these areas? Suppose a child is at 3 years and he's going only imitation skill till 18 months. His receptive language may be only 12 months. You have to know exactly, but his cognition may be better, or he maybe have fine motor at 2 years. So you have to know, if you want to do a good intervention program, because I told you development is sequential and it has to attain. You can't have imitation still at 18 years or 3 months of age and say, I'm going to send him off to school. You're not going to do anything. You're wasting time, effort, energy of parents and the money. So any child with developmental monitoring or screening who has a problem, and new risk, you have a newborn risk stratification where you have to send the child, and any red flags which is shown in the development, please send the child for a detailed assessment. So what is the role of the pediatrician? Is to make an early diagnosis and intervention. And if the parents have gone to a center for intervention, you have to know, is this intervention working for the child? Because you are the guiding thing. They come to you and ask, I'm going there, is my child progressing? Unless you know what to monitor and what to see, how will you tell them what to do? And of course, I told you, you have to use a neuroplastic brain to optimize the child, should be able to monitor progress, effectiveness of the intervention, and the medicine. You have to handle all the other medical concerns, like there may be hypothyroidism, there may be visual defects, there may be the other child may have some syndromic, you have to maybe have to do a genetic testing, you may have to do a neurological testing, you know, all the other things. So 50% of all developmental pediatricians work is pediatricians' work of developmental disorders is all about handling almost epilepsy, the child has seizures. You have to manage all this. And the most effective, you're the most effective above all, counselor to the family. Whatever the special educationists may say, whatever the others say, but they'll come and ask you, and it's your responsibility to guide them to the best. That's all I have to say in the talk which is given to me, that we have to work together to make a difference when it matters the most. When is it? The early years. My sincere request that I do know, if you look into the Indian pediatrics studies, not more than 10-12% of pediatricians monitor milestones, and that's unfair. We are letting a child not give his opportunity. We, as most compassionate, most empathetic professionals in medical field as pediatricians, if we have to bring that joy into the life of the parent to see that the child is maximized. I'm not just talking about developmentally disabled child. I'm even talking about normal children. Can you guide them to attain their maximum? Because if you do that in the first 5 years, you have laid a foundation for growing a very intelligent and a smart nation. Thank you very much. I'll stop scaring.
Hi, madam. Thank you very much, madam. Can you hear me?
Yeah, I'm done.
1 second, madam. Let me.
Yes.
Audience have any questions? So, anybody has any questions for Dr. Nandini? 1 second, madam. Dr. Swapna from Madanpalli, she has some.
Yeah, sure.
I think everybody has understood your talk.
I can't hear you, Dr. Ratna.
No, madam.
Hello?
No questions, madam. Sorry.
Okay.
Anybody else has any questions?
That's okay.
Okay, madam. Thank you very much for your time. I know it's been very early in the morning and you've been waiting for us. We are sorry for the technical glitches and thank you very much for joining us today. I hope
yeah,
you'll
pleasure is mine, and thank you very much, Ravi. And I enjoyed saying what I had to say to the general pediatricians.
Thank you. Next speaker. Okay. Okay, the next speaker is a very senior neonatologist working in Trivandrum. His name is Dr. Naveen Jain, a very eminent neonatologist, very well known for his work in the field of neurodevelopment, especially in the early premise. He has recorded his recorded his talk. After the talk is over, he will be live for any question and answers. Thank you.
As pediatricians looking after sick newborns, it is very common to have a situation when we suspect that the baby might have challenges with brain outcomes. Hardly a day passes in an NICU or a labor room when we have a baby being born who gives anxiety to the family and the neonatal unit regarding ultimate developmental outcomes. The situation may be an asphyxiated baby, an extreme preterm, antenatally detected malformation, a very high bilirubin value, an unexpected seizure, or sepsis with or without meningitis. The questions that the parents ask, will my baby be okay? And what the pediatrician wonders is, has the baby survived without any brain injury? The parents may still ask whether the injury is bad. Can it recover? Can we do something to make it better? And today, a very early answer is expected, not just to predict outcomes, but even to decide treatment plans. For example, to cool or not to cool depends upon the expected severity of brain injury. Let us see a situation when baby did not cry at birth. We know that every baby who is born in this world today has an indirect assessment of his neurological status in the form of an Apgar score. Low Apgars are a cause for concern and for many medico-legal cases. But one needs to see that early Apgar scores do not predict outcomes. In a very large population-based study, when they looked at 99 babies who had a very low Apgar of less than 3, that means the baby must have had just heartbeats and a gasping respiration with no tone, no movements, and no reaction at all. Such babies who had a low Apgar of less than 3, even at 10 minutes or more, if they survived, 80% of these survivors were normal when they were followed to school. This may justify the recent change in NRP practices where resuscitation must be continued beyond even 10 minutes and up to even 20 minutes in babies with a very low or zero Apgar also. Also, if we look at the expanded Apgar score sheet, which must be filled in every baby who requires resuscitation at birth, there are two important things the sheet does. One is it not only records the Apgar, it even looks at what resuscitation was going on in actual and reminds us to record the observations till at least 20 minutes. Probably a 20-minute Apgar is a better predictor than an early Apgar. Many of us would swear by very objective tools like a quad pH. And this again is very important because it might determine the outcome of not just the neonate, even the obstetrician. She may be in difficulty in the court if you do not interpret the quad pH correctly. Dr. Ravi, any technical glitch? I can't hear and see. Bonds. It is very common to have a situation when we suspect that the baby might have challenges with brain outcomes. Hardly a day passes in an NICU or a labor room when we have a baby being born who gives anxiety to the family and the neonatal unit regarding ultimate developmental outcomes. The situation may be an asphyxiated baby, an extreme preterm, antenatally detected malformation, a very high bilirubin value, an unexpected seizure, or sepsis with or without meningitis. The questions that the parents ask, will my baby be okay? And what the pediatrician wonders is, has the baby survived without any brain injury? The parents may still ask whether the injury is bad. Can it recover? Can we do something to make it better? And today, a very early answer is expected not just to predict outcomes, but even to decide treatment plans. For example, to cool or not to cool depends upon the expected severity of brain injury. Let us see a situation when baby did not cry at birth. We know that every baby who is born in this world today has an indirect assessment of his neurological status in the form of an Apgar score. Low Apgars are a cause for concern and for many medical legal cases. But one needs to see that early Apgar scores do not predict outcomes. In a very large population-based study, when they looked at 99 babies who had a very low Apgar of less than 3, that means the baby must have had just heartbeats and a gasping respiration with no tone, no movements, and no reaction at all. Such babies who had a low Apgar of less than 3, even at 10 minutes or more, if they survived, 80% of these survivors were normal when they were followed to school. This may justify the recent change in NRP practices where resuscitation must be continued beyond even 10 minutes and up to even 20 minutes in babies with a very low or zero Apgar also. Also, if we look at the expanded Apgar score sheet, which must be filled in every baby who requires resuscitation at birth, there are two important things the sheet does. One is it not only records the Apgar, it even looks at what resuscitation was going on in actual and reminds us to record the observations till at least 20 minutes. Probably a 20-minute Apgar which is low, less than 6, may be a better predictor of outcomes than an early Apgar measure. Many of us would swear by very objective tools like a cord pH. And this again is very important because might determine the outcome of not just the neonate, even the obstetrician. She may be in difficulty in the court if you do not interpret the cord pH correctly. For the same reason, a large British study which recorded all the cord pH and the base excess of babies born in the country found that mild decreases in pH below 7 were seldom associated with disability. 6.9 to 6.99, only 3% disability rate. This became exponentially more if the pH was very low, like 6.8. Similarly, the definitions used for treating with cooling would say base excess of less than -12, but only 0.5% of such babies were disabled eventually. Whereas if the base excess was as low as -20, then the disability rates were as high as 60%. Recently, blood gas machines would also give you a lactate value. And most people think a low lactate means severe hypoxia and ischemia. And again, a very large population-based study. Those babies who had a high lactate at birth, which continue to remain high even after 24 hours of life, were at increased risk of disability. But if you are born with a high lactate and the values return quickly within 24 hours to normal, then neurological disability was not higher than other babies who had a normal lactate at birth. So what we learned this far is when we suspect that a baby may have brain injury, based on the fact that he required extensive resuscitation in the labor room, had a very poor Apgar, or a bad cord pH, base excess, or very high lactate, this must never deter us from continuing best care in labor room. Most of these babies recover with a normal brain and a good outcome. Then how do we know which one will be a challenging one to the family? The baby's encephalopathy, the symptoms of brain affection, obviously are a stronger predictor than what happened in the labor room. If you look at what is popularly known as the mild, moderate, and severe encephalopathy classification, babies who had severe encephalopathy, we all know, either died or had disability. And those with moderate encephalopathy, 1/3 were affected, and this forms the basis of trying to pool them and reduce the disability rates. Among those with moderate encephalopathy, who had no obvious problems in infancy, when they were followed to school, most of them had even schooling problems, which means a moderate to severe encephalopathy is a very strong predictor, more than any of the Apgar or the cord pH, in predicting which babies would do poorly. One must not jump to conclusions in the first few hours of life. 70% babies who had a Thomson score of more than 7, indicating severe encephalopathy in the first hour of life, most of these babies became better. And by the end of 6th hour, only 20% babies had a bad Thomson score. The other 50% improved rapidly. And therefore, persistent encephalopathy, which remains in decision for cooling at the 6th hour, is probably a more appropriate marker for bad outcome than early encephalopathy. The same can be seen in Sarnard score also. Many of us remember only the items of Sarnard score which are on the uppermost rows. That is the tone, the reflexes, autonomic functions, but we may never have paid attention to the most important row, that is the last one. You call it stage 1 HIE if symptoms resolve within 24 hours, stage 2 if it lasted for 2 days to 2 weeks, and stage 3 only if symptoms lasted for more than 2 weeks. And you can remember this 2 weeks as a magical number. Even with neuro examination, EEG that returns to normal at the end of 2 weeks in a baby who had many seizures, a bad MRI in the first few days, if it looks much better at the end of 2 weeks, these babies would mostly be normal in follow-up to school. So it is not the first 24 hours of examination, but a examination or assessment at the time of discharge, that is 1 to 2 weeks, which predicts which babies with HIE may do poorly. Other than poor sensorium, a severe hypotonia or a prolonged seizure also predicts outcome, which is bad. Among these babies who had a severe hypotonia on the day 1, if hypotonia persists till discharge, or seizures still require medications at the time of discharge, 1 to 2 weeks of life, these babies may have major disability in follow-up. So summing up what we learned till now, is the key word severe and persistent encephalopathy, which decides which babies with HIE will have a bad outcome. Apgar being very low, less than 3 after 20 minutes, pH being less than 6.8, as severe as that, base excess severe -20, and severe encephalopathy in Levin's classification is a baby who can't breathe and therefore must be ventilated, or at the time of discharge has such difficult swallowing problem that baby still requires tube feeds or has continuous sounds due to poor swallowing. Persistent encephalopathy at the end of 3 to 6 hours should be used to decide on therapeutic hypothermia. While you prepare in the first 3 hours, if a baby required extensive resuscitation, so that you can start treatment in time, the decision must be made by assessing progress of the Thomson score over beyond 3 hours. Prolonged seizures, severe hypotonia that lasts, all of these, if they're persistent until discharge at 1 to 2 weeks, predicts a bad baby. Simple signs like sucking without choking, taking a breastfeed or a palada or a bottle feed that finishes within 5 to 10 minutes without holding up milk in the mouth are good signs. If the baby has pooling of secretions because he has poor swallow, it is a bad sign. Recently, a formal tool has been made based on this sucking evaluation. Similarly, sleep-wake cycling. If a family who had a baby with asphyxia comes to the OPD and says baby sleeps well in the day but disturbs all night, this is very normal, just like all babies do. If he cries, but if you ask the family, they say he cries when putting on bed, but is consoled on cuddling and taking and walking around. This baby is very intelligent. He knows the difference between being placed on a bed and between being cuddled by the mother. So this baby possibly has a good brain function. When it comes to head circumference, importance of it would be noted at 3 times in the baby's case. What is the head circumference at birth? A baby who has a very low head circumference at birth has probably a fetal origin of the problem, and the reason for bad outcome eventually is not perinatal care. It may be a neuronal migration disorder, it may be a perinatal infection. A baby who has poor head growth in the NICU, that means from the birth head circumference till discharge, is at high risk of developmental problems. It's called head growth failure in NICU. And among these babies, some of them catch up their head circumference as they grow out of the illness and are followed up in the infancy. They will do better than those babies whose head circumference still remains poor. Although we have been talking cooling for last 2 weeks or 3 weeks, and the controversies of whether cooling should be done in India or not, we continuously forget very, very simple things that can be done in an asphyxiated baby to help the baby's outcomes. Ensure good perfusion. I won't be discussing what we can do, but the right use of fluid volume, inotropes, and not using diuretics can help baby's cerebral perfusion to be good. Ensure that baby sugars remain in safe ranges. Prevention of new infections and meningitis. A severe hypoglycemia. All these can affect the baby's outcome. Again, an underrated therapy, where it is discussed only in conferences, but never practiced with that much passion as should be, is the use of breast milk. There can't be a better healer for neuroplasticity than use of early and maximum breast milk. Very clear association was there between the myelin content that develops in the brain and number of breast milk feeding days. Also, when breast milk was given in animal studies, the estrogen that was there in breast milk crossed the blood-brain barrier and caused transcription of the oxytocin gene. This oxytocin gene improves the neural responses of the babies to the mother, and you can see that in this picture. In the insula area, those babies who are getting breastfeed responded better than those who are receiving formula feed. A very recent innovative study was done by our friend Dr. Mangala Bharati, where they used what is called as resuscitation with intact placental circulation. This concept has been there for last 2 decades, where we are considering delayed cord clamping and allowing more stem cells from the mother to go to the baby. But this was not encouraged in babies who needed resuscitation, where we would say cut the cord immediately and then resuscitate. Maybe it is these babies who need the stem cells most, and animal studies have shown that when stem cells were allowed into the baby, then the seizures stopped much faster than those babies who were having a immediate cord clamping. In the recent innovative device made by Mangala's team, it was possible to do stem cell banking, or rather giving to the baby, by using an innovative warmer which will allow you to resuscitate the baby with the cord still connected to the baby and the mother. Early intervention in the NICU, it itself is a topic, and will be discussed later in the workshop today. But some of the simple things that can be done is to apply milk to the mouth of a baby before you start an OG feed. We all get sense of smell, taste, and our hormones in the gut are improved, feed tolerance improves, and even the brain gets accustomed to milk. Stimulating of the cheek, either with a gloved finger applied in milk or by the mother herself. When mothers and fathers talk to the baby adult words, Later in childhood, the children showed better language development, and therefore they must be there in the NICU to talk to the baby. A very important concept called love towel is being used in many of the countries, where the parents rub a towel onto their body so that the sweat is left behind in the incubator and the baby feels the parents are still there. Now, previous speaker has talked about general movement assessment, and the gold standard still available world over is Bailey scale of infant development. These are very good tools, but then why still use DDST? The DDST is something that is very easy to do. It will happen in all the centers in the country. Both BSID and GMA take a lot of training to use correctly. And it may take several hundred babies before you use the test before you can actually interpret it. The DDST just involves a picture like this, where if the milestone indicated on the bar is a social smile, and if it is on the left side of the age bar that you draw, then the 95% children should do it. That is all you need to do. You need to look at the bars on the left side of the age line and mark as pass or fail and assess in 4 different domains. The power of this tool is in simple research methodology that if 2 signs are present in any situation, then the specificity of the outcome is very high. So if you go back to this age line, and in the gross motor domain, if 2 items have failed on the left of the age line, then the positive predictive value is very high. Most such children will have developmental problems. And persistent signs, like we discussed earlier, also predict bad outcomes. If you draw an age line this month and do a DDST, call the baby for follow-up after 2 months. One of the 2 situations might have happened. Either the sign or the milestone which the child couldn't do in the last visit has been performed this time. Or a child with bad outcome may not pass even this time. A child who has persistent signs will surely have a poorer outcome. And therefore, a simple graphic tool like this can guide both an untrained neurologist, a pediatrician, and parents in deciding which child is improving to therapy and who is destined to have poor outcomes. Another great word that has to be extracted not only from DDST, from any tool, is the concept of dissociation. If a child has very bad gross motor and fine motor milestones with reasonably good personal, social, and language, this might point to cerebral palsy. Similarly, a bad language development may indicate the need to look for hearing problems. So in the first prototype case of an asphyxiated baby, what we looked at is how can I know whether this baby is brain injured or not? More powerful than the UPGAR, the pH, and the lactate is whether the neonate has severe encephalopathy, needs to be ventilated, needs to be tube fed, or has persistent encephalopathy. If nearing the end of 5 to 6 hours, these signs are there, he may be candidate for cooling. If these signs are still present at the time of discharge at 1 to 2 weeks, this baby may have a bad outcome. A poorly growing head may indicate problems in the NICU, and one which does not recover after discharge from hospital has even more severe predictor of outcome. Now, if we extend the same concept to a preterm baby, we must remember that most often, fortunately, preterm babies are not brain injured. They're just dysmature. That means if you look at this picture, a lot of things still need to happen in the brain when the baby is born, which are now going to happen in a world or environment which is not natural, which lacks the growth factors, the nutrition, and the safe environment which the baby was enjoying inside. And therefore, maturity is not going to happen in the same way. For this reason, babies who do not have any evident injury as a preterm baby are also at risk of developmental problems. We need to know which of these babies are at poorer or higher risk. If you look at this risk stratification model we have used, Suppose we look at a baby who is born at less than 26 weeks, had to be delivered urgently, no antenatal steroids or Maxil were given. Baby had a shock or a symptomatic PDA which required treatment, had symptomatic hypoglycemia. This baby is at higher risk. Whereas another baby, which gave the time to the obstetric team, antenatal steroids could be completed. Baby was delivered and had no perfusion problems later, and sugars could be controlled in a good perinatal ICU. This baby would be better than the previous 26-weeker. And this kind of a risk recording or listing will help units to know who are at higher risk of developmental problems. A repetition of the growth chart that I showed you in the term asphyxiated baby, you can see that a baby who has his length going all right in the graph above, and weight is also catching up after discharge. But if the head is not catching up, this baby has more risk of developmental problems. Obviously, the head is not growing well. In preterm babies, screening ultrasounds may show either ventriculomegaly or periventricular leukomalacia. Both of these indicate loss of brain matter. A baby born at less than 32 weeks, if he is discharged and the ultrasound brain looks normal, he still has 4% risk of cerebral palsy. That means 40 out of 1,000. In contrast to 1 per 1,000 or 2 per 1,000 in general population. But if the baby has this kind of an ultrasound with ventriculomegaly or PVL, the risk increases to 50%, 500 out of 1,000. And therefore, this simple ultrasound, which can be done in every center, is probably the best tool for predicting outcomes of preterm babies in terms of cerebral palsy. Recently, we validated and published that the Hammersmith tool that was discussed in the previous session can be done even earlier than what most authors have described previously. Till date, it was recommended that preterm babies have a Hammersmith assessment done at 40 weeks. In a country like India, most babies get discharged early due to financial constraints. Doing a Hammersmith in an OP basis may not find the baby in the right state to be assessed. It is not easy to complete, and some of them may never come back for an assessment. And therefore, what we have coined as Hammersmith newborn neurological examination performed early, when we did at 36 weeks of discharge or a discharge, has a reasonable predictor, almost as good at 40 weeks HNNE. There are certain insurance factors described by Dr. Illingworth. A baby who is very keen, alert, looking around, looking at the mother, and looking at the environment, searching for things in the room, is probably going to be okay if you do not have a formal developmental tool available on that day. Very beautifully described, if the baby tries to catch a ball with his eyes, not with hands alone, may even assess the baby's health as early as 2 to 3 months of age. In preterm babies, we need to remember to correct for prematurity. Both parents and pediatricians sometimes forget that the baby was born 3 months ahead and get worried that the baby is not smiling still. We always advise the parents to celebrate 2 birthdays. One is a developmental birthday, which is the one of the expected date. This would constantly remind them that they need to count milestone checks from this date and not from the day baby was actually born. A very, very important concept is called as reciprocal development stimulation. If the baby is not active, not interested, dull, then the parents lose energy. And similarly, if the parents are not happy, if they're not touching the baby, if they're not talking to the baby, then who is the baby going to respond back to? We don't expect a nurse or a doctor in the NICU to cuddle, love, and affectionately speak to the baby, at least not as much as parents do. So if the parents must develop into healthy parents and the baby into a healthy baby, then reciprocal developmental stimulation must start very early right when the baby is born, and this requires parents to be present, at least for a baby who we suspect may be having a suspected brain injury.
Hello, Dr. Naveen.
Yes, good morning and thank you for playing the video from your end.
Good morning, sir. Thank you very much. Sorry, I think there was some glitch in the beginning. So we are catching up with now. Light on. Where is the cameraman? Light on. Any questions for Dr. Naveen Jain? Is joined from KIMS in Trivandrum. Any questions? Okay, one question for you, sir.
Sir.
Dr. Swapna Madanpalli, she's a neonatologist working in Madanpalli, sir.
Good morning, sir.
Good morning.
Sir, please tell when to do cooling. Suppose if there is bad pH and the parents want to continue, whether to do cooling or not. Bad pH means in the sense now you told even less than 6.99 also is okay, you are telling me, sir. Previously, we used to think less than 7, we are counseling them as bad pH and we were leaving them. We are referring them to government hospitals because of bad prognosis. Whether to wait for 6 hours and then to start or what exactly?
Dr. Swapna, I think there are two answers to the questions you have asked. Number one is a low pH does not indicate that the baby is very bad, because it really indicates the baby had asphyxia. And therefore, these are the candidates to select for cooling. Babies who have a pH more than 7, one has to ask yourself, does he require cooling at all? Did he have severe asphyxia at all? Normal pH of a fetus itself is around up to 7.1 to 7.15 because of maternal labor and maternal acidosis. And that is the reason for keeping the level at 7 to say that there was asphyxia. So I think if the pH is more than 7, one must doubt the diagnosis of asphyxia itself. Now, second point which I tried to make in the presentation was that it should not be decided based on a pH value alone, because it only reflects the cardiovascular status of the baby and the fetus at birth. And in the first hour, any baby who had a bad perinatal support would be acidotic. But many of these babies who look encephalopathic and poor in the first 1 hour may show a dramatic improvement in the next 2-3 hours. So what will be ideal is, if you have the cooling facility with you, keep everything ready, prepare the family, but make a decision only after watching for 3 to 4 hours. Although there would be people who are cooling supporters and may not agree with me and will say that early cooling is better for brain outcome, I will agree with them fully. But at the same time, you will land up cooling more babies than who deserve a cooling. Many babies who would not fit into moderate encephalopathy if you waited for a few hours. Did I answer your question, Dr. Swapna?
Yes, sir. But suppose the baby, there is clear-cut asphyxia, everything history is 100%. Baby did not cry immediately after birth. No doctor was available during resuscitation. Then
Yes.
exactly it is birth asphyxia.
True. If you had severe asphyxia, then also make your decision to not treat or withdraw support, if that is your question, based on the baby's progress in the first few hours. Do not take decision in the labor room. Do not take decision in the first 1 hour. Give maximum intensive care, support the baby, bring to an ICU. If there is even a heartbeat of 70, 80, completely flaccid, then also give support for first few hours and see how the baby's progress is. At the end of 3 to 4 hours, if the baby is having severe encephalopathy, not moderate, then these babies may not benefit from cooling. That is what the world experience is. But don't take the decision in the first 2-3 hours.
Okay, I got the point, sir.
Yeah.
Okay. Sir, and if there are seizures, you are telling no more than 7 pH, whether to do cooling is, I doubt you are saying no, sir. more than 7 pH.
Yes, I would definitely try to look at the whole picture than to go with seizure as the cause of or as a result of HIE alone. Because if a baby has had severe enough perinatal hypoxia ischemia to cause brain injury and seizures, then there would be shock, there would be gut injury, there would be renal injury, because multi-organ damage would be often there. And there would be an antenatal reason also to find the same. We have had babies who had multiple seizures and had no other organ injury. And on follow-up, we found out that it was a very bad meningitis or a very bad malformation of the brain. So if there is absence of a bad pH and multi-organ injury, we must consciously look out for other causes before labeling it as HIE. And that would be the determinant for cooling or no cooling.
Metabolic, you are saying, like sugars, those you mean to say?
CNS malformations, IU infections, meningitis, they will also not cry at birth, neuromuscular disorders. So if there is an absence of very bad pH, less than 7, and no other multi-organ damage, one must review the other differential diagnosis also.
Okay.
Yeah.
Sir, Miracridil is okay for cooling, sir? Miracridil?
I have no direct experience on using one devices versus another device, but surely when we used ice gel packs, we found that the fluctuation of temperatures are quite significant and they can go below even 31, 32, even after removing the ice pack also. So I would recommend that if you really want to cool a baby who is very sick and his brain and body organ outcome is critical, then I would suggest we must either use a servo device or refer the baby to a center early where a servo cooling device is available.
Thank you.
Thank you very much, Dr. Jain. There are two questions from Dr. Avinash Bhosle. He's from Jalgaon. Can you see the question, sir? Please take it.
You asked where to get the details of DDST, how to document stage of HIE on the discharge card depending on the Sarnat scoring, and does smell of milk and love towel affect outcome significantly, how to actually practice. I think the first one is easy. The DDST, right now what happened is the Denver, which was making the tool, has taken the product out of the commercial market. So you will not find the Denver tool on a website as an official to be available, but it is a very easy to use manual. We have the old manual with us still. So as an individual person, I can say if you mail to me, I will send you the manual that is still with us. It is very easy to use, extremely easy to use. It just requires half an hour of training. And the second part on the love towel and on the breast milk part, the breast milk part, what we practice in the unit, any baby who is admitted to NICU, any baby, after we finish the first communication, we ask them to buy a breast pump, whether the baby's mother is in KIMS or she is in another hospital. And we insist on getting milk as early as possible. The love towel part, we have not implemented it. I just read this interesting study, but it shouldn't be difficult at all. And whether it is hard evidence, I guess many things would be common sense and should be done even without having to have a systematic review. One would never have a possibility to do a trial and measure the effect of many multiple factors like this. So positive things like reducing noise, reducing light should be practiced even if we cannot demonstrate benefit. How to document the stage of HIE? I guess very important to record how long the neurological symptoms lasted, because the stage of HIE is an evolving one. You may call it stage 3 because he was ventilated initially and then eventually he changes. So at the time of discharge, what is most important is to, in the summary, if you're making a diagnosis, we must record the highest stage of HIE, whatever you have seen. But for prognosis, what is most important is how long the neurological symptoms lasted. If they are completely neurologically intact within 1 to 2 weeks, prognosis may be better.
Thank you, sir. Thank you, Dr. Naveen. Can you please send the DDST manual? I'll share it with.
Yes, surely I can. Surely.
Send it to my email. I'll share it with all the participants.
Sure.
Further question. Any questions? Thank you, Dr. Naveen. Thank you for joining us in your busy schedule. We are very grateful for your presence. Thank you very much.
Have a great workshop today.
Yeah, thank you.
Thanks.
The next speaker is Dr. Usha Devi. Just finished. 10 minutes, so shall I ask Dr. Venugopal to follow? Sorry? Okay, okay.
Good morning, everyone. Am I audible to everyone? My name is Dr. Venugopal, and presently I'm working in Shimoga Institute of Medical Science. And I thank for the organizing team to give an opportunity to talk about general body movements. I think general body movements for the graduates, like postgraduates or the fellowship people who are doing, maybe a new thing for them to understand. And what is general body movements? I will be going in glance because general body movements is a workshop itself. It contains around its a duration is around 3 days to 5 days. Workshop is there that I have to complete it within matter of 1 hour. So I will try to understand what is general body movements and what are the things we are going to see in the general body movements. What are abnormal, what are normal, and what is the importance, what is the validity factor, what is the sensitivity, and how it is done. Okay, fine. Not working. Change marker. Yeah. So my scope in 1 hour, I will be defining with definitions, where it arises, normal, abnormal, do and don'ts in assessment, what all we have to do, and what all we have to avoid doing it, and interference when we are doing it, and reliability and validity, as well as clinical approach, how important it is. Madam, next slide, please. Yeah. So the background is like survival of extremely preterm has increased over a period of time. Now, previously, less than 1 kg or less than 1.5 kg, it was very difficult for us to survive. Now, less than 1 kg, less than 750 grams. Now, I think 250 grams it has started now. Means survival of 250 grams, it has been there in Japan as well as in German. So, survival of extremely preterm is there, neonate, but neurodevelopment outcome and its future outcome, how far it is good, we really don't know. And early prediction and intervention, already 2 session has been over, like early intervention is more important than the survival of the baby, because we always, all the parents or a treating doctor always think about its neurodevelopmental outcome rather than just a survival. So early prediction and intervention. So if we know this baby is going to have some problem in the future, then we can think about this baby intervention can be done very early, so that the projectile will fall around 70 to 80% improvement rather than around 30 to 40%. And shortcoming of classical neurological examination. Yeah, neurological examination is there. MRI, CT, break volume, all sorts of things are there, very voluminous, but finally it will never give any outcome like this baby will have or this baby don't have a neurological abnormal. So that will never give a final decision yet, but definitely we cannot, the general body movement is not a replacement for a neurological examination or an MRI. So definition and origin. What is general body movement? First we'll understand what is general body movements, where it arises. It is just a movement, a spontaneously originated movement without any provocation. The baby will keep on doing some movements here and there, proximal part, distal part, the finger parts will be moving. Spontaneously movement. How it is generated? We can't tell it is from the cortical because cortical is totally immature. We can't from the spinal part. It is originating from the bineurons. Spontaneously it triggers just like a action potential, like in SA nodes. Continuously triggering will be there. That causes rhythmic and consistency. The baby will be moving like this. Like the movement, what is the difference between this movement and the preterm movements and the term movements will be, I'll be telling it in the future slides. So generated by a neuronal network in early life, that is not called central pattern generator. It appears at 10 weeks, in the 10 weeks, 9 to 10 weeks of fetal life and continues up to 5 months postnatally. Okay, am I clear? What is general body movements? It is a spontaneous movement generated. Really don't know where the origin is. It's neither in the cortex, not in the spine, above the supraspinal region. Spontaneously originating, just like a action potential SA nodes where the continuous rhythmic movement signals are generating. And these signals will be generating the spontaneous movement. It may be harsh, it is low, high amplitude, low amplitude, fast frequency, low frequency, depends upon it. So general body movement involves the whole body in a variable sequence of arms, leg, trunk, and movements. The wax and veins increases or it decreases. Rotation of long limbs slightly changes in direction, movements, frequency, all these things varies. Okay, I already told these slides where it starts from around 9 to 10 weeks, then slowly fetal preterm movements, it changes to rhythmic movements. We all know, like in a neonatal, I mean, in the NICU, where the movements of the preterm will be very high, with the high frequency will be there. Like it moves like this one, then it stops. Then slowly the rhythmic movements comes. Rhythmic movements is that there will be elegant, very smooth movements. Then it comes to a fidgety movement, still more finer, elegant movements. Slowly it refines the movement from a preterm movements to rhythmic movements to fidgety movement. Then the anti-gravity voluntary movements comes. Then at that time, general body movements disappears. So I already told general body movements of a preterm is general body movements in preterms may occasionally have a larger amplitude and a faster speed. And the term rhythmic movements starts from 37 weeks to around 8 weeks of postnatal age. General movements with a moderate amplitude and moderate speed. And fine movements with the slow acceleration involving all the direction, and it will be absent in crying, during crying. I will be going a bit faster because this is a very wider slide. I mean, a lot of slides are there and bit videos are there. If any issues are there, please stop me there, sir. Okay. Video of a preterm where the amplitude is high and frequency is also there. The amplitude at the moment is very just like a JCB when it working rather than fine robo. A JCB how it works, just like it reflects the same thing with the preterm babies. Refinement is not there. Amplitude in the term babies, how it occurs in the term babies, the amplitude is small to moderate towards the body, speed is slow to moderate, rotate along limbs not fully, and it's bit fluent and elegant is there. Now when you are comparing to a preterm with a term baby, you see the bit refinement of movements is there. So this movement will be changed over to a fidgety movement that around 8 to 9 weeks of gestation postnatally. The fine, still more refined movement will be there, that rather than the proximal movement, it will be more of a distal fine movements will be there. Oh, sorry for the video got rotated. You can rotate it. Okay, play it, it's okay, no issue. The fingers, the movement in the fingers. Can you repeat it, please? Movement is there in all the directions, in all the limbs. Fine rhythmic movement is there in the fingers. Limbs, you cannot predict the next type of movement it is. It is not monotonous. We can never predict the movement, which movement will occur next. So that is called a fidgety movement, occurs at around 8 to 9 weeks, then disappears by around 5 months. So how to differentiate? See, the thing is that amplitude is very high in the preterm babies. The amplitude decreases and almost refined movement is there in the fidgety movement. That is the maturity in the general body movements. So what is abnormal? Now we know what is normal. Always we should learn what is normal rather than an abnormal. Now we have already learned what is normal. Now we have to see what is abnormal. So we know only 2 normal movements, that is term rhythmic movements and fidgety movements in the later part. So that are 2 normal movements and 5 abnormal movements. If you know 2 normal and 5 abnormal, general body movement is finished. So what is abnormal movements? That is the poor repetitor, means to say monotonously doing the same thing repeatedly. So then cramp synchronized. I will be showing the videos in the future slides, and chaotic movements and fidgety movement, absent fidgety movements and abnormal fidgety movements. Please show. At the age of around 8 months, you not have this much amplitude, right? A fine movement has to be there. Now it appears to be just like a preterm baby, which is having a high amplitude. Abnormal. Larger amplitude. For this occurs at this co-repertoire, we're repeatedly doing the same thing, monotonous.
This ex-preterm is only very
At the age of fidgety movement, this is having co-repertoire means very repeated. You can predict the next movement. We can predict the right upper limb will go next, the left lower limb will go next, or 3 or 4 movements which is on repeating. You can see the limbs where repeated same movements is going on. Fine. Absent of fidgety movements, the movement itself is not there. Baby is almost blank, blind, lying down. The fine rhythm movement that has to be there in the fingers is not there, and you can predict the next movement which movement is baby is going to have it, and their baby is almost not having in contact with the environment properly, seeing one side, but the vision is good with this baby. We can compare this movement of a fidgety movement can be compared with the previous one, normal fidgety movement with this abnormal fidgety movement. Cramp synchronized. Cramp synchronized means to say the baby will have a contraction of the upper limb as well as the lower limb simultaneously. Suddenly, baby will start crying. That we have seen routinely. This
characteristic picture of cramp synchronized general movement
80 to
can be clearly seen in this
cramp
case.
synchronized. Now the baby will have
Legs and arms contract almost
suddenly baby starts
simultaneously.
crying.
A few seconds after onset of each movement, the infant starts crying, which is a characteristic feature in these infants.
Yeah. Okay, we'll go for the next slide. Yeah. So I have told about abnormal movements, that is co-repertoire and cramp synchronized, absent fidgety movements, abnormal fidgety movements. Abnormal fidgety movement, absent fidgety movements are bit difference.
The characteristic picture of cramp synchronized general
fine movements will be
can be clearly
or
seen
there
in
will be a
this
larger
case.
amplitude.
Legs and arms contract
Now
almost
we have seen
simultaneously.
normal
A
fidgety
few
movements.
seconds after onset of each
Now
movement,
are
the
we able
infant
to
starts
diagnose
crying,
fidgety movement?
which is a characteristic feature in these infants.
So to diagnose it, after a prolonged period of training, you can do by seeing the baby itself, we can tell this is a normal or this is an abnormal. But in the initial part, better to record it and to discuss it with the experienced person. So over a period of time, we'll refine ourselves. because there will be always an interpretation difference will be there. The one what you are feeling it is an abnormal, maybe normal for me, for mine abnormal, maybe abnormal for you, or normal for you. So better to do a recording before in the initial part to tell it is as a normal or abnormal. But while recording, what are the precautions has to be taken? So to avoid, the camera should be placed in near the infant so that the baby should not concentrate on the baby, camera itself. The second point is variated objectives should be avoided, like a doll, a red doll. So it will keep on saying that rather than the movements itself will decrease. Then we'll think about it's an abnormal rather than a normal thing. Where to examine? Depending upon the age, it can be done in the incubator, it can be done on the mattress, on the floor, on the table, wherever it is possible. Caregiver presence, better to avoid a caregiver presence because it keeps on staring at the mother or the parents. Make sure that the baby is not crying, otherwise they will think it is an abnormal movement. Baby, even it is normal, will interpret it as an abnormal movements. Nappy, whenever we tie a nappy, a tight nappy should not be tied. Otherwise, the restriction of movements will be there. Room temperature should be comfortable, and practical stage of awareness, where at stage 4 is better than stage 1 or 2. If the baby is drowsy, then definitely there is no movements itself. Then prolonged episode of hiccups should be assessed. Mirror, definitely we keeps on like at the room which is having a mirror, definitely keeps on doing an abnormal larger amplitude, then we'll take it as an abnormal fidgety movements rather than a normal thing. And not to record first 3 days after birth. First 3 days after birth, why to not to record or to predict as a general body movements? Because there is a lot of physiological changes that keeps on occurring in the first 3 days. So better not to record in the first 3 days. And not to do it for the prolonged period of time, around 45 minutes to 1 hour or 2 hours. Definitely all normal things becomes abnormal, right? We are fatigued, babies also fatigued. So better not to do it for a prolonged period of time. So what are the things which interfere? Like if the baby is, see, the main important thing is that a general body movements, we can start predicting this baby will go for a normal or abnormal, will have a CP, will have a diplegia, monoplegia, double diplegia. All these things can be done in the neonatal period, that too in nursery. That's more important rather than no, I will wait for till 3 months, 4 months or 5 months. We'll see. See, rather than telling to the parents, we'll see, rather than that one, we can predict it in the neonatal period. But what are the hurdles is that the baby is intubated or the baby is sedated, barbiturates, indomethacin been given for the PDA closure, or baby is having severe sepsis, definitely abnormal movements. General body movements will be turned to abnormal movements. So these are the hurdles will be there: indomethacin, dexamethasone, septicemia, anticonvulsant therapy, or barbiturates. So how to record? So we know what is general body movements, what are normal general body movements, what are abnormal general body movements till now. Now how to record it? We know how to record video, then how to interpret it. So here there is a chart like practical general body movements where normal, poor repeater, normal, abnormal, poor repeater, chaotic movements, absent fidgety movement. So with the gestation wise, like how keeps on, it will varies. So with the gestation below, you can keep on ticking. Abnormal is there, normal is there. This is a general way of doing it. And another way of doing is that with the semi-quantitative method also we can do it. Amplitude, this is the amplitude variable range is there, predominantly small range is there, predominantly very large range is there, amplitude, sequence, frequency is there. With the fine tuning, we can have a semi-quantitative assessment also. So we have 2 ways. One is with the proforma, we can tell abnormal movements or normal movements, or in the finer tune, we can have an amplitude or frequency, how it is. Am I fine till now? Or it got monotonous, just like general body movements, getting bored of? So it's not working once again. Next slide, please. Yeah, it's the same performance which is done at 3 to 5 months. Okay, multiple things are there. I think it's not clear. You can go with the fidgety movement is there, like a swinging movements, like wiggling movements is there, normal. Now we keep on ticking it, and you will have a fine tuning. Fine marks is there, total marks, and scoring what score is going to happen for the final one. So how to predict the future outcome? There is general body movement and later outcome. That's the main important thing. Overall, the workshop of a general body movement is the same thing, like whether this general body movements, what future it predicts. So if it is having a cramp synchronized or pure repeatorial or a normal thing almost goes into a normal thing, and it will be having a normal itself. A cramp synchronized in the initial part, which is having a cramp synchronized, change over to absent of fidgety movement or abnormal fidgety movement to a normal movement. Absent to abnormal to normal movements. Or cramp synchronized can go directly to a CP itself. Right? Or pure repeatorial can change over to a normal. Doesn't mean like in the initial part, if the baby is having a pure repeatorial, doesn't mean that it will be having a CP. It can change over to a normal, or it can change over to a absent fidgety movement. Fine. A normal always definitely will go to normal. A pure repeatorial always can have two things, and absent fidgety movements can have a mild neurodevelopment effect, or it can change over to a normal. But here the thing is that cramp synchronized almost 90% or 95% change to a absent fidgety movement to a CP, and changes towards an absent fidgety movement to a normal is less likely. So over a period of time, if the baby in the initial part, if it is having a cramp synchronized, then definitely this baby, we can predict this baby 80 to 90% will have a future cerebral palsy. Fine. So objective reliability is there, like, so there are many studies around almost around 101 observer with 466 infants. Number of infants observed on, for example, to say curate study, that is around 66 with the 2 observer. So inter-observed variability is around 90%. So 88 to 90% inter-observed variability is definitely it is there. So we cannot tell like a general body movement for you it is abnormal, will be abnormal to me. 80 to 90% we will go together, and 10% there will be always a difference of opinion. The same with a different, for example, if you tell a pretal stage where the sensitivity here, the previous slide is specificity obtained where specificity is less, 58% and 57%. Rhythm movements for a preterm movements is 58%, for a rhythm movement is 70%, for a fidgety movement is 85%. And if you come for a sensitivity is a bit higher. It's around 91%, 100% and 100%. So it is more of sensitive and less of specificity. Slides not getting changed. So chaotic movements in the general movements, a fast, abruptive, and jerky tremors with a larger amplitude, cramp synchronized. Almost these two as will go into a spastic CP. That is a take home. So we have a predictive value for ultrasound, MRI, and general body movements and neurological examination. How far it is a sensitive and specificity when we compare it to a general body movements. A neurological examination is having a sensitivity around 55%, a specificity around 65% with Levelock et al. Study. And ultrasound is around 28% with a 95%, a Ferrix et al. Study. And MRI, which is having 65 to 75%, and a specificity around 99%. And diffuse MRI around 80% and 66%. Okay, these are the very value. When you compare this one to a general body movements with 1,358 6 studies, which is having a sensitivity of 98% and specificity of 91%. That is more important when you compare it to an invasive method or prolonged neurological examination, right? A simple observation, like you see the movements, how it will progresses, and how it what outcome it is. Where we can have a sensitivity around 98 and specificity around 91% is much more a good tool comparing to a neurological examination or an MRI. But never think that MRI can replace a general body movement. MRI is the one which will tell the structural abnormality of the brain, where the physiological abnormality, the movements where also the physiological abnormality cannot be detected by the MRI, right? So MRI terms, 3 studies, 86 to 100%, it is 89 to 97%. Ultrasound, 10 studies, 74%, and it is 97%. Neurological examination, 88% and 87%. When you compare all those things, general body movements also contributes to the maximum part itself. So comparing to cost effective, it is very less cost effective just by seeing it tactile stage or traditional neurological examination or MRI. When you compare these three things, time consuming few minutes, 3 minutes to 5 minutes for inexperienced person and 1 minute for the experienced person. And for time for a lengthy hours for invasive as well as lengthy hours for MRI, right? When you compare these things, a manual touch is not required, here touch is required, expertise is not required, just 1 to 2 days of training is more than enough. Here it is totally required. Traditional neurological examination, neurologist is required. Here to MRI, full radiologist is required. And prediction, how early? Less than 32 weeks, even at 26 weeks of just post-menstrual age also we can predict. But here we have to keep on waiting. Sensitivity is very high and poor in the neonatal period and 100% fine in the later part. Predictive value, objective, feasibility, reliability, all are good in general body movements comparing to a neurological examination as well as MRI or invasive method. Take home message is practical general body movement is excellent diagnosis tool. It can be used along with other traditional neurological examination. There is a good scope for research as there is no publication in India. Any questions? This general body movements workshop will be for 3 days by Krista. Dr. Krista will be doing, and the next workshop dates are also there. You can go ahead with those things. If at all anyone is interested, you can go ahead with the 2 to 3 days or 5 days workshop. Second, you can do it. Any questions? Or shall I jump to HNNE? Okay, I will finish up my HNNE, then together I will take the questions. That I told. The next 2 slides I showed. The training is there for 2, 3 days and 5 days. It will be done in a different place. I have shown the timetable. We can register there and we can get the training done. Yeah. Hammersmith neonatal neurological examination, neonatal and infant. There are 2 examinations that will be done for the neonate as well as for the infant. The neonatal examination is done on the term babies as well as on the preterm babies. But the preterm babies examination is done at the term, not at the preterm age. At the term, we are going to do it. So neurological examinations in the preterm and the term are different. What is the importance of Hammersmith neonatal examination? What is the important? My scope will be how to administer HNNE, what score it is, how to interpret the score, what is the raw score, what is the fine score. After doing all sorts of examination for 2 to 3 hours, what message we can give to parents? That's the main important thing. Right? Doing all sorts of things, then how fine we can tell this baby is normal or this baby is abnormal. When can I predict a CP in this baby or abnormality in this baby, or do I have to repeat the same thing once again after 2 months, 3 months, 3 weeks? So this is what we'll be telling in another few minutes. What is it? It is just an update version of Dubovit's neurological examination of 1981. Dubovit's classification neurological examination is there. The same thing, examination will be done in 1991, which has been done. A performance there, that will we are going to continue the same thing. So based on the LT preterm, where it is all the data has come from the LT preterm from 37 to 42 weeks of gestation. All the examination are done. They are interpreted that thing. This is normal at this age. This is abnormal at this age. So all these things are done on a normal preterm. And we see this comparing this to an abnormal preterms or abnormal terms. Okay. So it's in the initial 48 hours of life consists of 34 items. It consists of 34 items, and the details of examination will be done in the afternoon session. So I won't go a detailed examination. I will be just glimpsing the neonatal examination, how to interpret. Okay. I'm not going in depth of these things. It will be done in detail in the afternoon session, or on 2 sessions are there, the neonatal examination. So how to interpret the neonatal examination, what we can take home, that just a glimpse I will be telling. So consists of 34 items grouped in 6 categories. That is tone, tone pattern, reflex, movements, abnormal signs and pattern, orientation and behavior. Fine. So different category. There are 6 categories, 34 items, 34 neurological examinations done under 6 categories. Okay, this is the proforma. I have considered a comprehensive proforma done in a single slide. I think it is bit of episode. I'm sorry for this slide. So where we have a date of birth, head circumference, all in details, and we have an examination with 34 items. All 34 items are been put in this slide itself. Like, okay. Arriving to optimality score. So finally, a posture is there, our arm recoil is there. We'll have in a different posture at a different gestation. But when we do at a 37 to 44 weeks of gestation, 42 weeks of gestation, we have a different tones or different reflexes or different pattern. We'll have a scores for this. I will go for the next slide, so it will be easy. Yeah, we'll have a scores. For example, 34 scores. Each will be having a one marks, or one score. Score will be there. So around 0 to 5 or 1 to 5 scoring will be given for individual examination. 34 examination, 6 categories. Under 6 categories, individual. 34 means first, second, third to 34. One individual will be having a scoring system. A scoring system will be having 1 to 5. So means to say 35 into 5 will be the maximum score, right? Sorry, 34 into 5 will be the maximum score, but we don't have 34 into 4 as the maximum score. We will be having a maximum score of 34 itself. So means to say each examination should be either awarded as 0.5, 1 or 0. But in the raw score, we'll have 1, 2, 3, 4, 5. Am I clear? Audience are a bit lost, exhausted. Okay, 34 examination, different types of examination, tone pattern, and those things is there. Individual will be having a individual scoring, that is a raw scoring, that will be scored around 1 to 5. This individual raw score will be refined to a refined optimal score. That is, either we can, these 5 scores can be put into a 0 score, 0.5 score, or 1 score. So that is the next slides what I am having. Each 35 items is assigned a score, that is a raw score. Each score is scored 1 to 5. One second. Yeah. And if the item falls between the 2 columns, it is called as 0.5. It's not nice. Yeah. For eye, auditory, orientation, visual. So where the score is around 3 or 4, 3, 2, it is scored as 1. That is normal. The score 0.5, high for 0.5 is also taken as 1. Or irritability 3 is taken as 0.5 and cry is taken as 2 as 0.5. And eye 2 or more than 3, it is taken as 0, less than 2. So individual performer, if you see the individual performer, will come to know about it, what is normal, what is abnormal for that age. So over a fine, they will be having maximum 34 because 34 examination we are doing it. Why 34 means to say, see, always a tallest person in our class is not a normal person. A shortest person is not taken as a normal one. The 90th percentile, which is lying in between, and extreme person who is on the both the sides are taken as abnormal thing. So in the same thing appears here, where the 90th percentile, the 3, 4, the score which is there, that is taken as 1. The 95th is taken as 5, and 1 and 2 is taken as 0. So that's why the raw score is changed to optimal score, and sum of optimal score, total optimal score will be given. Okay. Now the point arises is, if my baby is born at 26 weeks of gestation, it is term equivalent age. If the term equivalent age, whether the term equivalent, anyway, we know that the baby which is born preterm cannot cope up with the term baby till 2 years, right? But our examination is at the initial term around 37 to 40 weeks of gestation. So when we do a preterm baby examination at the term equivalent age, is it a normal thing? Will it have a abnormal? Because the tone will be low, hypotonia will be there. Flexibility will be less, flexibility will be there in a preterm. So what are the things occurs a preterm with a term equivalent age and with a term baby when you compare these things? More hyperexcitable, right? We are seen in the general body momentum, more hyperexcitable, less flexor tone in the limbs, less extensor tone in the limbs. That is because due to not exposed to intra-arterial pressure, not well flexed, right? Larger the amniotic fluid, smaller the baby, aram se baby will be there. So it is not flexed. As the baby term goes to a term, means to say I'm lower the amniotic fluid and the lesser the space and the bigger the baby, definitely all the things will be universal fluxion will be there. So it will be having a universal fluxion. Here the tone is hyperexcitable, lesser flexor tone. Here because not exposed to intra-arterial pressure and not well flexed. Lie extended and confined. Nursing in a supine position is almost done for a preterm baby. So that's why there is always a difference will be there. So when you examine neurological examination, is it a normal? The score for a term baby, is it normal applied to a preterm baby? That's the point, main important, right? We are worried about the preterm babies rather than term babies. Term babies we know, but the preterm babies we are worried about it. Do preterm scores the same on the optimal scoring as the term infant? Our question is now to be answered. Term optimality score is 30.5. Term optimality score is 30.5. If the same thing applies to preterm, it will be mean optimality score is 26.4. So now the point arises whether 26.4 is taken as an abnormal or it is taken as a normal thing. See, in the proforma, a posture, arm recoil, and the arm traction, when you take the thing, for the baby of 25.7 weeks of gestation, the range arises from, for if we are taken it as a 900, total 100. Out of 100 people, if we examine, 60 people will have a score around 3. 0.5, 3.5 is 9. So 4 score is around 60. 12 members will be having a 4 score, and 2 neonate will be having 9 score. So there is a wider range. As the baby matures, a full term will be having around a 4 score on 90. But a preterm will be having a wider range. The same thing applies with the arm recoil. 3 for around 44 babies have scored only for 3 and 4 and 23. But the full term when you compare it is around 67. As the babies are extremely preterm, the scoring will fall low. But now the interpretation arises whether to interpret this one as a normal thing or abnormal thing. The presence of suboptimal global score does not necessarily mean that an infant is neurologically abnormal, but only identify the infants who needs to be reassessed again. It doesn't mean that it is an abnormal, it has to be reassessed again. Optimality score more than 34 is used as normal cutoff. So, who are the babies preterm neonatally, who are the babies has to be reassessed once again. It is the number of items falling outside the 90% that was a better predictor for severity of outcome of a global ophthalmology. All the infants with a normal outcome had a fewer items less than 7 falling. The items less than 7 falling outside is normal. If it is falling more than 7 is definitely an abnormal thing. Abnormal thing doesn't mean that if baby will be having a CP, it has to be reassessed. The next class is a HINE class will be taken in the afternoon. That will be dealt in depth with how to examine, when to predict, how we can predict at the 5 months, can we predict a CP, what is the maximum score in the infantile examination, MS with infant. It is a neonatal examination, infant examination, how to examine. Examination is almost holds good the same thing, bit difference is there. But I can't go in depth with the neonatal examination because of my shortage of time. Yeah, these slides will be taken in the afternoon. Thank you. Any doubts? Five months when the baby is having anti-gravity movements or the voluntary movements, fidelity movements will go. 5 months. It starts around 8 to 9 weeks postnatally at around 5 months. After 5 months, we can know like fine motor, grass motor movements are there. So it's our neurologically principle is there. Whenever the subcortical movements are there, When it wants to have a cortical movements, when the cortical development will develop automatically, subcortical, all the reflexes will keep on disappearing. These are all not a voluntarily, it is automatically, it is generated by neurons. So this has to disappear when after 5 months or 6 months, we'll be having a voluntary movement starts coming, or anti-gravity muscles, anti-gravity movement starts coming, this will disappear. That's the normal thing. Fidgety movements, when we take a fidgety movement as abnormal fidgety movement, absent fidgety movement. As shown as slides, a absent fidgety movement can have a normal in the future or can go into a CP. But a cramp synchronized, a chaotic movements will go maximum, will have a CP, then an absent fidgety movement or abnormal movements. The slides which I have shown the previous, where that slides was going, the two arrows was going. A fidgety movement, absent fidgety movements can have a normal thing, can go into a CP. But the predictive value for a cramp synchronized having a higher value comparing to absent fidgety movement. Yeah, thank you. Thank you very much.
Hi, I know we all are keen or desperate to have a cup of coffee or tea. It's on its way. It will be served here. We'll start off with the next speaker, Dr. Usha Devi. She's from Chennai. She's a practicing neonatologist. She's going to give you about stratification, risk stratification of babies. She's waiting for us to get her online. So let me start off with Dr. Usha Devi next.
Sir, can you see my slides, sir?
Yeah, madam. I think you've shared it, is it?
Yes, sir. I shared it. Can you see the slides, sir?
Yes, madam. 1 second. Adu illi pop up madಬೇಕು. 1 second, madam. Illi. Yeah. Sir, can you close the chat box? Okay. Madam, I think you're all set. 1 second. Just hold on.
Yeah.
Yeah. Yeah. Speaker. Okay, madam. We can see you now, madam. The stage for you, madam. Please take over.
Thank you. So, very good morning to one and all present there. Let me start with my talk, organization of follow-up services, including risk stratification. So in the coming 1 hour, we'll be seeing about why follow-up services are needed, what is the need and extent of problems that are necessitating these follow-up services, and who are to be followed up. How do we go about risk stratification of the newborn babies, and what are the prerequisites for setting up of this follow-up services, and then do we do this follow-up, and where do we do this follow-up? And under follow, we'll be seeing shortly about nutrition, growth monitoring, immunization, hearing, and eye care, neurological and developmental assessment, and other disabilities. So what is the importance of early intervention? So why at all this neonatal follow-up is so important? This is because with advance in neonatal services, we have more and more preterm babies, 16 preterm babies, even 24-weekers surviving, and even term babies who are sick are surviving. So there are higher chances of handicap in these babies, and early identification of any delays in these babies and early intervention is of utmost importance for better outcomes in these babies. So very low birth weight babies, around 15% of them have some neurological problem, 4% around can have cerebral palsy, and around 20% requires special education as the babies grow. Even if we see extreme preterm across the world, even in Western setup or in developing nations, everywhere there are a substantial proportion of babies who are landing up in disabilities and require long-term support. Even the EPICO study, which was from UK, and EPIVE study from France, all those studies showed that these babies tend to have disabilities. These preterm babies tend to have disabilities as they grow. So this PQ study 2, which was done in 2006, showed that yes, survival of the babies have improved when compared to the cohort in 1995. And survival without disability is also there. It is around 34% in babies born between 22 to 26 weeks gestation. Around 34% of the babies survive without disability, and cerebral palsy is present in 14% of these babies. And when compared to the cohort study which was done in France, here severe or moderate neurodevelopmental disability was present in 28% of the babies who were born between 24 to 26 weeks. Even in the babies who were born between 32 to 34 weeks, 12% of the babies landed up in severe and moderate neurodevelopmental disabilities. It is not only cerebral palsy as such, they have other disabilities too, like learning disabilities requiring developmental intervention. So around 26% of the babies born between 32 to 34 weeks required some form of developmental intervention, and parents were also concerned about the behavioral issues. So this was a meta-analysis which was discussing on survival and impairment of extremely premature infants. So when the babies were born at 27 to 28 weeks, the severe disability was around 2 to 3%, whereas for the babies who were born at 24 weeks, the disability ranged till 25%, severe disability. So this review was specifically done in developing nations like ours. Here, the neurodevelopmental impairment or cerebral palsy of any severity at 1.5 years to 2 years of age was present in 17% of the babies born below 1 kg birth weight. And all the morbidities, short-term, long-term morbidities, were higher when compared to those in developing nations. So less than 1 kg, not only various comorbidities have influence on the developmental outcome, like what is the nutrition provided during the neonatal stay, and what is the nutrition after discharge of these preterm babies, and whether the baby has other morbidities like bronchopulmonary dysplasia, whether the babies were operated for necrotizing enterocolitis, all have a role in predicting the future developmental outcome of these babies. And even this retinopathy of prematurity, any stage retinopathy of prematurity was present in around 50% of the CLPW babies, and severe ROP was present in 25% of these babies. This means that they will have an say on the visual outcome of these babies as well. So now that we have understood that many iris babies tend to have adverse outcome on follow-up at 3 years or at 6 years, we know the importance of the follow-up services, and goals of the follow-up of this iris neonate should be early detection of any deviation from normal child development and starting an early intervention, and providing adequate family education and support throughout the follow-up even during the intervention, and training the medical professionals who are going to deal with these babies. And also it is also undertaken as a part of research. So who are the candidates for this follow-up? Yes, follow-up of all the newborns born in the hospital will be ideal, but it is always not feasible due to the resource limitation. So we have to prioritize follow-up of at-risk newborns who are at a higher risk of developing adverse outcomes. So this is a risk stratification given in the NNF guidelines, where it is stratifying them into high risk, moderate risk, and low risk. High risk babies are those born below 1 kg birth weight, less than 28 weeks, who have, I'll just mention a few for want of time. So who have comorbidities like chronic lung disease, IVH, grade 2 or grade 3 periventricular leukomalacia, severe perinatal asphyxia, and those who are operated for surgical conditions like diaphragmatic hernia, TEF, and hypoglycemia with seizures, meningitis, shock requiring inotropic support, bilirubin-induced neurological damage, and major malformations and inborn error of metabolism, abnormal neurological examination at discharge. So babies with the weight 1 to 1.5 kg will be falling under moderate risk, and twins and triplets moderate HAE hypoglycemia without any seizures, sepsis, hyperbilirubinemia, but without any neurological dysfunction, intraventricular hemorrhage grade 2, suboptimal home environment. All these babies will be following under moderate risk. Mild risk babies are those between birth weight of 1.5 kg to 2.5 kg, HIE grade 1, transient hypoglycemia, suspected sepsis, neonatal jaundice requiring phototherapy, and IVH grade 1. So prerequisites should be the planning should be done well before discharge of the babies, and counseling also should be done well before discharge of the babies.
Can you hear me? Okay. So, sorry for the interruption and all the technical glitches. I think Dr. Usha Devi is held up in an emergency. She's going to join us later. So meanwhile, we'll start off with the next talk from Professor Aditya Goel. So before I introduce him, can I ask you how many of you see babies with CVI, corticovisual impairment, in your clinic? You all see? Okay. So good. So you've identified. So next is what to do. So that is what Professor Aditya is going to speak about. Corticovisual impairment is hugely unrecognized. There are a huge number of children with CVI, even though they may not have classical CP, especially those with hypoglycemic insult. As we all know, it insults, it acts as an impact on the occipital cortex and invariably affects the vision to some extent. They may not be really blind. In the old terminology, we would use it as cortical blindness. So there's not really a blindness, it is more of an impairment. This impairment can vary to different degrees. Somebody having just a field restriction, somebody having issues with the contrast, or just a severe squint. So it's first step is to recognize, and obviously the next step is to guide them where they can get the appropriate help. Professor Aditya is a trained optometrist. He's on various boards, faculties of international organizations, and he also sets a setup and running the visual rehabilitation at Shankara Eye Foundation, which is also in Whitefield. So he also works in Aster CMI Hospital and runs the CVI department with us. So I'll request Dr. Aditya to take over the stage. Sir.
Thank you, Dr. Ravi. Thank you very much for the introduction, Dr. Ravi. Now, like you said, I'll be talking about cortical visual impairment. I've spoken in a number of live conferences, a few virtual conferences. This is the first time talking in a hybrid conference. So I don't know if it's going to become a normal, but then pretty interesting to speak over here where I'm talking over here as well as some people are listening. I don't know how many of you are interested in this. I'll be speaking about an organ which occupies probably about 1% of the human body, and that's the kind of interest that people have in the organ which occupies 1% of the human body. That's the kind of space we are given in a multi-speciality hospital also, maybe not even 1% of the space. But like Dr. Naveen mentioned in one of the phrases, catch with the eyes. Catching with the eyes is one very important thing. And we don't realize how important it is till the time we close our eyes and try to do things. Well, a few disclosures. I have no financial or funding disclosures in this talk. Only thing, I have used a few images which are from a good friend of mine, Dr. Dominic Meno, who is a professor in Illinois College of Optometry. So I would like to thank him for that. Well, this is how your vision is in cortical visual impairment. Like a good friend of mine, he put it across, it's not idiopathic. We know it is not idiopathic, but then here it is something like the patient doesn't know anything and the doctor doesn't know anything. We are in a world where it just goes like something like what we came through, a tunnel. And you're looking deep into it without understanding, without knowing what exactly is happening. A few examples. Case number 1, 4-month-old ischemic changes in the cortex with both white and deep gray matter, diffuse abnormalities, CP spastic quadriplegic, seizures since birth, infantile spasms, has poor vision. Case number 2, 5-month-old female picks up toys, increased facial expressions. They have very vague facial expressions. You really can't make out what they're trying to say. They smile, but then it's all very blank. You don't know what is happening. No change in mobility, feeding improving, eye health unremarkable. Exotropia onset after head trauma, all milestones delayed, shaken baby syndrome, retinal signs resolved with seizures. I don't know if we really see shaken baby syndrome over here in India, or they're hidden. People don't talk about it. It is very considerably common in Western world where there are nannies who are looking after the babies and the child does not stop crying and they shake the baby vigorously and that can, or maybe throw the baby and it happens. I have personally seen a patient over here, a small baby over here who had shaken baby syndrome, but then the parents were not prepared to accept it. So we live in a denial that it is not happening because of that, but then I think it is quite prevalent here also. Case number 3, 11-year, 6-month-old female baby, child, vision problems noted at 8 months of age, optic nerve hypoplasia, nystagmus, VEP, all results were delayed, peak poorly formed but consistent with optic nerve hypoplasia, nystagmus intermittent, seizures, poor hand-eye coordination. Now, these are the kind of cases that we come across. We do not actually know what to do with them. Nystagmus is considered to be extraocular muscle problem. It is not. When they're not able to see properly, what do? Check all the aspects of the eyes and say everything is fine. Do we really relate that? Now, the poor eye-hand coordination, do we relate that to something that we can work on? That's what we need to see. Now, CVI, like Dr. Ravi mentioned, it used to be called cortical blindness. We have had plenty of terminologies. We have had cortical visual impairment, cerebral visual impairment. We have talked about delayed visual maturation. We have talked about pediatric cortical visual impairment, pediatric cerebral visual impairment, blindness, etc., etc. Plenty of terminology, but then this is what we talk about today. I don't know what's going to happen in future. So CVA is a decreased visual response due to a neurological problem affecting the visual part of the brain. Very simple, straightforward definition, maybe a layman kind of definition. Typically, a child with CVA has normal eye exam and has an eye condition that cannot account for an abnormal visual behavior. I specifically use the terminology visual behavior. It's not vision alone. And when I say vision, it is not seeing. I think we need to understand that, because whenever we are talking of vision, it is not seeing, it is a whole lot of things. We've been talking about the gross motor movements and general movements, etc. So vision ultimately, or seeing ultimately, has to result in a movement. Unless that movement occurs, your seeing is of absolutely no use. It is something like a paralytic person, able to see but not able to make any movements or convey anything through that movement. They display characteristic visual behaviors, like I talked about smiling, a lot of facial movements. It is something like a blank stare, a blank look at you. They are looking at the light. You don't really know that some of them, they look at the light. You don't know they're really looking at the light or what they're doing. And unfortunately, we do not know. That is a tunnel that we go into. We don't know because they are not able to tell us what they really are feeling. They don't, obviously, they cannot communicate with us. One of the most frequent causes of visual impairment in children from developed countries. We are seeing a lot of it in India also, but then reporting is not there. We are talking more about other things rather than 1% of the organ, which possibly does not make much sense. Diagnosis of CVA is indicated for children showing abnormal visual responses that cannot be attributed to the eye themselves. We see the eye health, mostly eye health is perfectly normal. Absolutely nothing in the eyes. You relate it to the visual pathway, probably nothing over there. We look at the fields, nothing over there. Where's the problem? The child is not able to see. The child is not able to visually communicate with anyone. So where the problem is, obviously somewhere here. Brain dysfunction must explain the abnormal visual responses as abnormal ocular structures, abnormal eye movements, and refractive error do not. Everything else looks normal. There's nothing wrong with the refraction. There's nothing wrong with the eye structure. There's nothing wrong with the pathway. Fixation and following. The first thing if I have to do, if I have to look at somebody over here, first I need to fixate at that person. For example, in nystagmus, why is the person's visual acuity poor? Because that person is not, the child is not able to fixate at the object. So obviously when the fixation is not there, he's not able to recognize, and obviously the visual acuity is going to be poor. So fixation and following, even to intense stimulation, may be poor and does not respond to people's faces. A blank stare, they look at you, but then you don't really know if they are really looking at you. You make all the monkey faces, the child does not respond to that. Social smile, when we talk of, they are possibly not even able to recognize what you're doing. Visual regard and reaching towards the object is absent. They are not able to, you show them objects, they're not able to reach out to it. We talk about the general movements. You have to reach out to the object of regard, whatever visually we are showing, but then they are unable to do that. Now the causes of CVI. What are the possible causes? Hypoxic ischemic encephalopathy, periventricular leukemalacia, traumatic brain injury due to shaken baby syndromes, neonatal hypoglycemia, like Dr. Ravi mentioned, infections, metabolic disorders. Others may be antenatal use of drugs by the mother. Very highly prevalent in foreign society. Cardiac arrest, twin pregnancy, central nervous system developmental defects, and accompanying features of CVI, including cerebral palsy and developmental delays. Now, these are the possible causes. There may be plenty more, but these are the main causes for CVI. Now, what do the parents come and talk about, or what do we see? Whenever we evaluate a child, we look at abnormal light response. Either it is light gazing or photophobia. They tend to move away from the light, or they keep looking at the light. We don't really know if they're looking at the light, observing anything, not observing anything. We don't know. But then the parents come and tell you the child is looking at the light. We don't know. No response even to strong light. Number of times you show a very strong light, you can take an indirect ophthalmoscope, you can take your mobile phones and show the torchlight, probably no response at all. Blunted or avoiding social gaze. You think they're looking at you, the parents say they look at me. We don't know. Are they really looking at it, at the parent? We don't know. They claim that they are, and we have to accept it. Brief fixations, intermittent following. The parents say that the child looks at the object, intermittently look at it and follow the object. We have to see, but that intermittent looking or brief fixation does not form visualization. It has to be prolonged. No problem. You know, I thought something was wrong, but then the boundary. Thank you. When we look at the visual field loss, I mean, if a child is able to see, we are looking at some amount of inferior altitudinal defects. They are not able to see in this area. So that's the reason why you always find them looking all over above. Possibly they're not able to see below, the objects below. Behaviors reported by parents, teachers, and low vision specialists. Variable or inconsistent visual responses to the same stimuli. You show them a light, sometimes they look, sometimes they don't. They look away from the light. One day you feel that they have been looking at some object, you show them some toy, okay, you have gained it. Tomorrow, he's not going to look at that object at all. Day after tomorrow, he's going to again start looking at it, but briefly. Then they start crying. We don't know. So it's inconsistent. Better responses to familiar than novel stimuli. They're quite okay with familiar, but you show them something different, they may not. They don't like it. Fatiguing from visual tasks. They get fatigued. They don't like it to be, you start therapy. After some time, oh, I don't want it. Peripheral vision dominates when reaching. This is one thing very interesting. The parents come and tell you, my child is able to move all over the house. And you tell that he is not able to see. He has a cortical visual impairment. They say, my child moves all over the house and does everything. Ask them if in unfamiliar situations, is he able to do that? If you take the child outside to somebody else's house or some other place, is the child able to navigate? They may not be able to say yes to that. So peripheral vision dominates. It's over here, but then here it's not there. So they are somewhere here. Colored stimuli elicit better responses than black and white stimuli. Visual attention for moving stimuli is better than static stimuli. Try to show moving stimuli, but not like this. It should be slow movement, but they are not able to understand static stimuli. If the thing is not moving, if your object is not moving, they are not good at it. Vision for navigation is unexpectedly good. Like I said, they're able to move around. Even today, we cannot answer why, how they're able to do that. In our terminology, older days, we used to say something called blind sight. I don't know how they're able to do that, but then they're able to navigate. Difficulty seeing an object or image in crowded array or busy background. In this background, they'll be totally messed up. We call it figure ground perception. They'll be totally messed up. You give them a huge load of toys, they may not be able to find out anything. But then you give them one toy, he may be able to reach out to it. You give them multiple, they miss out on it. Reduce responses to visual stimuli when music, voices, and other sounds are present, and often when the child is touched. They get confused. A lot of sensation is happening. You have your sound, you have multiple people, you have visual stimulations, whole lot of stimulations. They miss out on that. So they need to be stimulated in one single manner. So what happens is your sound, your vision, your other touch, etc., etc. Then the vision takes a back seat and they're not able to follow that. I think we are in an evolution stage, evolving to the hybrid mode. So earlier, when it was a single mode, it was very easy. We could, good. Like we said, we don't know why it's happening and we don't know why it is happening. It just stops on its own, starts on its own. Anyway, so these are, I talked about delayed visual maturation. There are different categories of delayed visual maturation. Type 1 is visually impaired infants, improved visual ability by age of 6 months, often without treatment. They start improving on their own. Again, we don't know why. They were poor, they start improving on their own. Type 2, attention problems associated with neurological or learning abnormalities. Improvement takes longer. Type 3, children have nystagmus, albinism, etc. Vision improves later, can improve to low normal levels. Nystagmus, one thing, we are not treating our children properly. Unfortunately, we try to work on the extraocular muscles. Personally, I feel it's very, very wrong, because nystagmus is a supracortical area problem. We need to work on that rather than work on the muscles. You may be able to stop the muscles. You may be able to stop the eye movements. You can put your super glue in the eye, stop the eye movement. Visual acuity is not going to improve. Vision is not going to improve. You got to work neurologically, and then you will be able to work much better with the child. DVM4 associated with retinal, optic nerve, macular anomalies. Outcome is pretty poor, because unfortunately, for the genetic problems, for these kind of problems, we still do not have any. I do not know with the stem cell therapy what is going to happen, but then currently we do not have much. So the outcome, visual outcome in the DVM type 4 is pretty poor. Now, which areas are damaged? We are talking of the dorsal stream and the ventral stream. Ventral stream, also known as the what pathway? Slow, pretty slow. If I'm looking over here, this is my ventral stream. But then if I look at her, this is my dorsal stream where it stops me. Power cellular pathway stops me, focuses, and I'm able to find out what. I look at this purse, I'm able to find out what. I will not be able to find out what it is. That is where Visual activity, measure visual activity in children. Two different bodies, they are not born with learning. Practical, objective practical. No child is going to tell you this is better than that. Reminds me of a good joke that happened in US. Person also must get right, and people is like, get that up. You're on the death bed. And you want to see doctor, what do you give him? Because I want to see him. Something is happening. I diabetes. Right? All doctor the same over. People spend one or two. So we asked him those questions. One is better, two is better. So he wanted to know which was better because he was totally confused and he wanted to diabetes. First we tell you which was better. One was better or two was better. And the child wanted to come up with which was better, one or two. So the fact of it is a totally objective measurement that we do, and it is not a subjective clarity that we do. Functional vision assessment, as we talked about it, and anterior and posterior segment, the logical fingers, anything at all, it is talking about. And these are some of the tools that we use for visual activity. But Tina has done a lot of work on this, wherein she is not an ophthalmologist, not an ophthalmologist, but she has done, she's more of a psychology person. Psychology, she has worked in patterns, idea patterns, fellow psychology are differential and simple work with, because she understands, that there are a lot of research in what a child understands. So the four basic symbols that a child understands: a square, a heart, apple, and a circle. So all the tests are when child see and recognize. These are the four symbols that she uses. Otherwise, if you see over here, the spatial frequency of it. What we do is we show this and a blank one. Depending upon what the child looks at, you understand that it's abstraction. Next, lower spatial frequency. And continue till the time the child is able to look at one particular panel. Once the child is unable to look at or keep fluctuating, that is a visual activity that we assume that the child has. Similarly, the examiner looks to a small hole, one different pattern. This is something very interesting. So we know that this problem. Idea is that the child should be able to look at these sprites, and then he's able to look at the sprite, follow the sprite, and then goes back. So you will see a method movement in the child's eyes. He's able to see. So we perform reducing the thickness of the sprite, basically the spatial frequency, and based on that, we are able to understand if the child is able to or not. If you don't have these terms, use it. Stop. You can make a strip of paper or cloth or whatever and run it across the child. So there's a set in a set point, you know for sure that the child is not, then it's not. So when you clarity of the you're looking at two things, very important. They talk everything what is happening in the place. A movement of the people, corresponding to a direct response, a sensual response. Direct is when you back the child are kind of like one eye, and the people constricts. And sensual is shine in the side, and look at the other. Then I also look at afferent pupillary defect. Jumping the light between the two eyes and see which pupil constricts or dilates. So we are looking at the pupils and they talk about everything what is happening in the brain. There's a pupil reaction sluggish. So as clinicians, probably that will be a first thing that you should be looking at least for referral, where you look at the pupillary reaction and that the pupillary reaction is not good, please refer. Possibly something can be done. We look at contrast sensitivity. Contrast is very, very important. A child may be able to look at the darkest black against whitest white. But if you reduce the contrast, he or she may not be able to see. Now, if you look at my dress over here, it's a gray and a light brown or whatever. If I wear a dark trousers or pure white shirt, then the contrast is going to be much better and you'll be able to recognize. So if a background is pure white versus pure black, then the contrast is better and the recognition is much better. So we are considerably interested in contrast sensitivity, how sensitive your eye is to contrast. I'll be showing you a few slides how we check that. Color vision, obviously it has a lot of importance. Oculomotor ability. How is the eye able to move around? Normally what we see, up, down, right, left, and different gazes. What are we interested in? We are interested in tracking eye movements. We are interested in jump eye movements, because that is going to talk to you about the stability of the neural system rather than just the muscles. Accommodation. Is the child able to accommodate? Focus. Is the child able to focus? We talked about the parvocellular system. So accommodation talks about the parvocellular system. Binocularity, obviously both eyes working together. So we have to look at if both the eyes are working together or not. Very, very important from depth perception. If both eyes are not working together, obviously there's not going to be any depth perception. We look at this simple test called Bruckner's test. Any child, you shine a light into and you look at the reflex from both the eyes. If the reflex is equal, perfectly good. If the reflex is not equal, the brighter reflex is going to show a problematic eye. Now, in this case, if you see, this girl has a slight squint. If you see over here, this white area, the scleral show is more as compared to this. Now, if you see, the right eye is brighter as compared to the left. The same over here. If you see the reflex in the pupil, the right eye is brighter as compared to the left. So you don't need to be an optometrist or ophthalmologist to visualize all these things. You can very easily check that. And if you're able to see the Bruckner's problem, refer. So these are the ways we work with a child. We can't force a child to do anything. I talked about the contrast sensitivity. Now this is high contrast and you see low contrast. Again, a regular contrast versus low contrast. The contrast progressively reducing. If the child has a problem, contrast sensitivity is an issue, we got to work on it. These are the ways we check. Now these are, it's called hiding. Again, a play kind of thing where we show a high contrast versus a low contrast and see what contrast the child is able to look at. So you have different charts, you have different gratings, etc. for checking the contrast sensitivity. What else do we do? Eye health. We look at the anterior segment, we look at the posterior segment, and obviously electrodiagnostic equipment like electrooculogram, VPs, BR, all those things, because these will tell you how the light which is going in is reacting. We would, I would like to take it a little further and talk about pattern VP so that we are able to see if the child is able to really see a smaller object or not and keep on reducing that and what happens to that. So We can't force a child, so we have to work along. Now, this is the way we evaluate a child. Mother is the best person to evaluate. So have mother hold the child and then evaluate him. We use handheld equipment rather than our funny equipment that we have in the office. So handheld equipment work a lot better with the child. This is something which I will contraindicate for a pediatric evaluation. Handheld equipment work much better. So we look at uncorrected refractive error. If the child has a huge refractive error, please provide that. Provide a good refractive, do a good refraction, and any high refractive error, if the child has, provide glasses. If there's a constant strabismus, squint, please look at it. Oculomotor dysfunction, binocular vision dysfunction, accommodative dysfunction. Look at the attention the child is paying to something. So look at all these things and then start working on the child. This is binocularity, the depth perception. Apart from evaluating the vision, we also look at the perception, where we are looking at the non-motor perception as well as the motor perception. So these are some of the non-motor perceptions. We also look at the auditory perception and processing. Now, once you have evaluated, you find that your child has a problem. What best can you do? If they cannot come to you for therapy, if you cannot do anything, the first thing you should tell the mother is start talking to the child. Not talking to the child lying down. Hold the baby like this. Look into the baby's eyes. The child may not be able to see, that's okay. Start talking. That's the best medicine that we have always found, and culturally sensitive. But then we ask the mother to have a big bindi, bright color bindi, and hold the baby like this and keep talking. We have seen a lot of changes with that. In fact, to most of my patients, or rather all my patients, even if we find the child is just not able to see anything, still do that, and we start seeing a lot of changes. So this is one of the best therapy. Even if you're not able to refer the child to any of us, perfectly fine, but please teach the mother, and nobody else on earth can do except mother. Fathers are useless. Fathers will not be able to do this. Mothers are most abled people to do this. Obviously, prescribe the glasses, whatever required. If it is not really required, small prescriptions or certain things which are normal kind of thing, which are obviously not going to make any difference, don't bother. Now, this is something which I personally follow with almost about 2.5 decades of work with these kids. This is something which I have developed. So it actually depends on the stage at which you're seeing the child. I cannot say that you start from level 1 to level 20. Look at the stage at which you are seeing the child and proceed from there. I'm sure lots of other places, lots of other people have different protocols, but this is something what we follow, very simple, straightforward thing. First of all, look at photopic stimulation, simple light. Not look at any flashing light. If you have seizure disorders, if the child has seizure disorders, absolutely contraindicated. Work with a neurologist, ask a neurologist if it's okay to use that, go ahead and do it. To continue until some semblance of perception is seen, constant amount of visualization you see. Once you see that, move to something which is rotating, show a light on that, and see if the child is able to follow. Increase the speed if the child is able to follow that light. Introduce light emitting toys. Don't have the ones which make sound. Have only light emitting, do not have sound in that. Move them very slowly in front of the child. See how the child is able to maintain the fixation. Introduce patterns in black print on white background. I'll just show you some of the prints that we use. use pretty bold ones. Don't go for finer ones. As it improves, go for finer. As black and white improves, go to color. Introduce red, green colors. Two primary colors. Basically, the reason is they form two end of the spectrum. So a lot of science, you're looking at this part of the spectrum and that part of the visual spectrum. So introduce red and green colors. And if you do not have colored objects, not a problem. Put colored filters, whatever market you get all those color papers, cellophane papers, you can use that. Now, these are the kind of patterns that we use. So start with possibly something like this, then go on to something more fine, then go on to red and black, go on to red and green. Introduce rotation of colored objects seen through red, green anaglyphs. Anaglyphs are red, green glasses, nothing else. Introduce slow moving videos. Our kids are born with videos nowadays, with mobile phones. Slow moving, start showing, see how the movement is, see if the child is getting interested. Move your mobile phone slowly. You can possibly start using a tablet and then go over to the mobile phone. Slow moving videos, again, no sound. I prefer using no sound. Once the fixation is definite, introduce slow movements followed by slow rotatory movements. So it should be linear movements and then go on to rotatory movements. Increase the speed of the movements, looking for gaze fixation. Is the child able to fixate the gaze or not? Look for that. Then you introduce complex movements as much as possible. Go on making it more and more complex. So these are some of the rotatory things, pegboards. Make the child put, they'll do trial and error sessions. Go ahead and do it. Then they will be able to learn over a period of time. Introduce big toys with no light and encourage. So earlier we had toys with the light. Now remove the light. Introduce bigger toys, make them smaller and smaller over a period of time. Introduce movement and look for accuracy of fixation. Make the movements more intricate with the child fixating and reaching accurately. Induce a child to reach out to the toy. Make him look at it, grab it. Introduce rotator and objects on computerized programs. So you have computerized programs which rotate, which are touch enabled, etc. So you can make the child touch these, and when it disappears, they feel very happy about it if they are able to see, once they start seeing. Start working once you have achieved this, start working on both eyes working together. Introduce binasal patches. I will show you what binasal patches. Please do not use opaque occlusion. A lot of places they just patch the eye like that. Please do not do that. Use translucent occlusion. A good objective refraction. So you want to prescribe glasses, prescribe a good objectively, not subjective prescription. And glasses can be prescribed binasal patches to encourage peripheral fusion. I talked about the periphery. So you have to get a binasal patch which improves peripheral fusion. And this is how, if you see this child over here, this is a child with a binasal patch, and that does wonders, absolute wonders when you introduce these binasal patches. A number of, is one of the simplest things that you can do, does not cost you anything at all. Just take a normal tape and stick it up in the nasal area. Questions? That's how we work on a child with cortical visual impairment. We have seen good results, good improvements with the procedures that I've just mentioned. And I would not be able to put the percentage to it, but then we will be able to do certain amount of justice to what we are doing, because when we work with different professionals, a multidisciplinary team, it makes a lot of sense to work together along with a physiotherapist, along with an OT. When we work together and we complement each other, the results are much, much, much better. Okay, is there no questions?
One of the common problems is in tier 2 cities or villages. The family, they're very dedicated, but unfortunately, they cannot compromise their livelihood and come to Bangalore for doing the therapy. So what is that a pediatrician sitting in a level in a village or a taluk level can advise to the best of their abilities? This a family anyway would not come because it's a
It's perfectly fine. So, like I told you, mother talking to the child. That doesn't require any equipment, that doesn't require us. So teach them how to do that and tell them that they have to do it regularly. Secondly, once the child starts some semblance of fixation, some semblance of looking, then start with those simple patterns. You can always give those patterns on a paper. So they just need to do that and look at the visual movements, look at the fixation, and over a period of time, possibly they can, if they can come once in a month, once in 2 months or something, see what has and change the thing over a period of time. So that works very well. And if they have mobiles, then we can provide all those things on mobile. So we can always provide those simple programs which can work on mobiles. Mobile can be connected to TV because most of the people are mobile and TV enabled nowadays. So we can always do that. And even evaluation can be done on online basis. So COVID has taught us a lot of things. One of them is online evaluation and online monitoring of the patient. We can definitely do that.
Thank you, sir. Any questions from the audience? Okay.
Thank you.
Thank you very much, Professor Aditya. The next speaker is Dr. Kirtika Rajaraman. She's a developmental pediatrician, very dynamic, very bright lady and protege of Dr. Nandini Mundukar. She also works at the Motherhood Hospital in Indiranagar and runs the Child Development Center there. Can you hear us, Kirtika?
Yes, sir. I'm hearing. Hope you are hearing me.
Yes, yes, Kirtika, we can hear you.
Yeah.
A very bright lady. You can please start your slide, share slide. Ma.
Yeah, I'll share my slide. Good afternoon, everyone. I'm just holding you all during your lunch time. I'll stick on to the time. Let me share my screen. Hope you all can see my screen. Can you see my screen?
We can. Kirtika,
yes. Let me go to slideshow.
Slideshow.
Okay.
You well and hear you well. Go on, please.
So the topic is think quick, act quick. So a nice topic. Let's go ahead. So what is the need for early identification? Worldwide, there are around 200 million children under 5 years of age who do not reach their developmental potential. And India is among the top ranked countries for largest number of children with disabilities. WHO says that early identification is our priority. Why it is important? Because neuroplasticity, as we all know, if the children are identified early, then we can start their early intervention, and it works great in the early years, first 3 years of age, when the neuroplasticity is its maximum. So we can make a difference in the child's life, in the child's functioning, child's independence, and the parental well-being also. So who can make a difference? We all can make a difference if we are going to identify these children early. So my presentation would be a case scenario based presentation, and then we will have a discussion. So the first case study is a child A, who is 2.4-year-old child. And the concerns of the parents was, we want to confirm his development, whether his development or on track or not, doctor. Our pediatrician said there might be some concerns. The concerns, when we asked in detail about the history, they told like he doesn't follow instruction mostly, but he knows those things. When he wants to change the TV, he gets a remote to us. But when we say take remote or take glass, he might not do it. Sometimes he doesn't respond to his name call. Sometimes he responds, but mostly when he's with his toy, he doesn't respond to his name call. When we asked about his expressive language, the parents were very proud. He can sing rhymes, doctor. He can identify alphabets, numbers. He can say many fruits name, animals name, vegetables name. But it depends upon his mood. When we ask him, not all the time the child will say it. But for his needs, the child doesn't talk or use gestures like pointing or nodding head. But when the parents, but he will pull the parents and push their hands to reach for the toy. He doesn't mingle much with his peers, but the parents also says that, doctor, it's COVID for almost for 1 year. We didn't take the child out. Now only we are taking him out. So mostly I think he's playing aloof because of that. And the child doesn't copy a bye, doesn't wave hands for bye or shake hands or do some social gestures like high five. And with respect to rhymes, though the child can sing rhymes when someone is doing rhymes with action, he doesn't imitate those actions. When it comes to his play skills, the child is very interested in animals. He always holds an animal in his hand. He also lines them up, but he doesn't engage in any type of pretend play or making an animal sound and moving them. With this brief, I think everyone would have guessed the possible diagnosis or the suspect. We would suspect autism spectrum disorder in this child. So what is autism spectrum disorder? According to DSM-5, if there is a deficit in social communication, then it is one of the criteria for fitting into ASD. So what do we mean by deficit in social communication? Before going for communication, the child doesn't have an appropriate, age-appropriate receptive language. The child doesn't follow simple commands. So receptive language also depends upon the age. If so, we are looking at a 1.5-year-old child, then we can ask our parents whether the child can follow simple instruction like pick up a spoon means with the child go to kitchen and get a spoon and come. If so, we are seeing a 2.5 to 3-year-old child, then the receptive language of the child is much more elaborate, that the child can follow a 2-step instruction also, and also an instruction with proposition. If you say to a child like keep this book under the chair without even pointing to under the chair, can the child follow or not? In autism spectrum disorder, they might have a huge deficit in their receptive language itself. Second, they can have a complete lack of spoken language. They might not utter a word also. Always it is like or some sound they make, that's all, no spoken language. Or they may have delay in developing a pragmatic spoken language. When we say as this is basically a functional communication. As we discussed in the previous child, this child could label a lot of things. He can label animal name, fruits name, alphabet, sing rhymes. But when it comes to his need, when the child needs a car or a water, the child just pulls the parent's hand and take the parent's hand there. So this child has expressive communication, but when it comes to his functional communication for his need, the child doesn't have that pragmatic spoken language. And not only it is a spoken language, we human beings use both gestures and spoken language equally. Sometimes we use gestures more than the spoken language. So these children will have lack of non-speech behaviors, like they can't make gestures like pointing, nodding their head for no, or doing gestures like come, give. All these functional gestures might be deficient in these children, and they also don't do the social gestures like bye, high five, shaking hands. They might have deficit in their facial expression and also importantly, eye contact. Whereas there can be deficit in autism spectrum disorder, they can have a deficit in social interaction. What do we mean by social interaction? They don't respond adequately to others. And 1.5-year-old child might not share a play space with his peers. A 2-year-old child might not engage in a parallel play. When we say parallel play, the child has to sit next to the other child and try to copy his play action or his physical movement. If the other child is running, this child has to run along with the child, not just be next to the child. If the child is playing with the sand, this child has to observe and try to copy. If it is an older child, some 3.5-year-old, responding to other peers, we expect the child to have a cooperative play, join together and play something like a pretend play. So if the responding to others is not age appropriate also, we have to think whether it is autism spectrum disorder. For example, if a 3-year-old child coming to us, and if the child just shares a play space, like if other children are playing, he might stay in the part. Sometimes if he likes the slide, he might join other child in the slide, but sitting next to a child and doing a parallel play or a cooperative play doesn't happen. That also considered as reduced responding to others. These children lack spontaneous seeking for sharing interest or seeking appreciation from others. For example, generally, a child less than 2 to 3 years of age, all the time they are attention seekers. When they see a new toy, they want to show it to their parents. Mama, look, even if they're not talking, they just do it by gesture. They show the toy, look at the parents, smile at them, and share their interest with their parents. Might be they see a bird, they just, or an airplane, they point up, look at that, and look back at the parents to share their interest. Whatever they do, they seek appreciation. It's not that they enjoy appreciation, they seek appreciation. For example, if they finish some task, or if they just slide down a slide, they look at the parent, they smile as if they have done an achievement, and they want the parents to clap. There's a difference between seeking appreciation and enjoying appreciation. Enjoying appreciation is when a parent claps for the child smiles. Seeking appreciation is a child does something and then look back at the parents and wants that appreciation, is seeking appreciation. Generally, a child who is at risk for autism or an autism spectrum disorder lack the spontaneous seeking and the seeking appreciation. They lack interest in peer group and they have difficulty in imitating others. So they might not join in social imitative play, like a parallel play or a cooperative play. They don't join, or in a circle time, they don't join because of their difficulty in their imitation skills. What else an autism child can have? They will have rigid and repetitive behavior. These repetitive behavior can be a motor behavior like a flapping a hand or spinning or rocking. It can be a motor behavior, or it can be a repetitive use of an object. Like all the time they spin the wheel or they lie down and look at the moving wheel. This all can be a repetitive motor behavior or a repetitive use of objects. It can also be a restricted and fixed interest. Just a second. So restricted and fixed interest is these children might be fixed to one toy all the time, not engaging with other toy. For example, the child we discussed was very interested in animals, and all the time the child holds the animals, play only with the animals. So it could be a restricted and fixated interest. For some older children, they might talk when they have a talking skill. They might all the time talk only about cars, their interest, but not about others. It can be a sensory integration issue. These children are hypo or hyper reactive to their sensory inputs. For example, a small smell, normal smell can make them vomit, or a sound of a cooker might make them shut their ears and scream and cry. Minimal haircut can make them panicked. So some children might need a lot of hugging and a lot of tug and war type of play. So they might be hyporeactive or hyperreactive to their sensory input. And even a small change can cause an extreme distress in these children. So these are the characteristic of a DSM-5 characteristic of a child in the autism spectrum. Now the question is, if so, we are seeing a child, will they have all these features to characterize them as ASD? All these characters will develop for a child after 3 to 4 years of age, but ASD can be diagnosed with accuracy as early as 18 months to 2 years of age. Then if we look for all these characteristics might not be available, there might be few characteristics, but not all the characteristics as expected at 3 years of age. So what should we pediatricians do? We have to identify these children. We can make a difference when they are identified at 18 months to 2 years, not at 3 to 4 years of age, where a part of neuroplasticity itself is lost. How can we identify these children? One is using a screening tool, MChat, that would be discussed in later after your lunchtime. But as clinician, if we know few early core features, and if we are going to look for that is joint attention, in our clinical practice, these children can be picked up as early as 18 months and referred to developmental pediatrician or pediatric neurologist. So what should there's a saying, eye sees only what our mind knows. So what should our mind knows so that our eyes start seeing in these children? One is eye contact. When any child comes to your OPD, is a child making an eye contact? Is the eye contact just a brief, or it's a consistent eye contact the child makes? The second important feature is responding to name. A child can start responding to name as early as 10 months, and it becomes a subconscious behavior of a human being. Even in your sleep, if someone is calling your name, you react to it. So responding to name should not be something like only when they are free they respond, not when they are playing they don't respond. A child has to be consistently responding to name call. The child should be able to follow pointing. When a parent is pointing at a book, the child should look at the picture what they are pointing, or when the parent is pointing something at a distance like a bird or like a moon or like a dog at a distance, the child should not only look in the direction, the child should be able to understand that the mom or dad is pointing to that dog and look at the dog. So you can ask a question like, how difficult is for you to get the child? So if so, the parent feels like, no, doctor, it's very difficult to get my child's attention when I point to something, then there could be less joint attention. There could be a risk for autism spectrum disorder. The child should be able to understand what you speak. The child should be able to use gesture for So can you mute yourself, please? So is a child using gesture for communication? For example, if the child is not talking also, around 12 to 18 months, the child should be able to point for their needs. The child should be able to use gestures like give, come, no. These gestures, whether the child is using or not. Is a child able to indicate gestures? If someone is going to say bye, is a child is able to say bye or not? If someone is giving a high five, is a child able to do high five or not? Excuse me, can you mute yourself, please?
Hi, can you please mute yourself? Okay.
So,
go on, Kirtika. Thank you.
So the next one is social referencing. So what is social referencing? Eye contact is not only when the child needs something, come and make an eye contact with you. The child should be able to communicate through eye contact. If a child sees something interesting, is a child picking it up and looking at the parents and sharing their interest. If the child sees something which is very new to it, is a child looking at the parents and confirming whether it is safe or not to approach it. These all we call it as social referencing. So in your normal OPD, if you can see whether the child can do all this, and if you feel if something is inconsistent or if something is missing, then you can suspect the child is at risk for autism and the child is fit to be referred to a developmental pediatrician. Now let's look at the video. Can you all see the video?
Although he looks at the man's pointed finger, he does not follow the direction of the man's gesture to locate the object of the man's attention.
So now when you look at this...
Kirtika, we can't see the video. Probably
okay, then I will go ahead with my presentation.
What you could do is you can minimize the slides and show the video separately. Do you have it on your desktop?
Later I would show, sir.
Okay, thank you.
I'll continue with my presentation.
Please go ahead. Please go ahead.
So we discussed upon these 6 features of joint attention. Is a child responding to name call? Is a child understanding your simple commands? Is a child pointing for his needs or using gesture for communication? Is a child following your near pointing in a book or far pointing? Is a child using eye contact for social referencing? Now the question is, if some children doesn't do this, and now in this COVID time, we get a lot of referral where the child doesn't do this. Now the question is it risk for autism spectrum disorder? The parent asks, my child is not exposed to social opportunity at all, doctor. That could be a reason for this lack of language delay and a social delay. Yes, agreeable, social opportunity is very much needed for the development to happen, but something are inherent. If a child is born and brought up in some house and the mother tongue is being spoken in the house, even if it is 2 family members, mother and father, the child learns the language, grasps the language by observing, by listening. So understanding language comes inherently to the child. So if a child's receptive language is very low, then it cannot be due to lack of social opportunity. Second is joint attention is also inherent. The child doesn't need someone like many peers to interact to develop joint attention. Joint attention develops naturally for the child. If a child is not able to follow the pointing, if the child is not responding to name call, we can't put the blame on the COVID situation. If the child doesn't play with other children, because of lack of exposure, the child feels anxious, the child takes time to go and mingle with other children, then that is okay. We can consider it as lack of social opportunity. But if the child doesn't even have joint attention, doesn't understand basic commands, then it cannot be due to COVID situation. The second question is, in this COVID, we have exposed a lot of screen time, doctor. Is screen time causing this delay? Yes, screen time can cause delay because screen is a passive medium, whereas human beings are active responders. Now, if a screen is playing some rhymes, it doesn't expect the child to imitate that action. It doesn't expect the child to fill in that rhymes. Whereas if a parent is singing a rhyme to a child, the parent will stop at right time, want the child to clap or want the child to do some gestures. So screen time can obviously bring down a little bit of delay in social and communication. But if it is due to screen time, if the child is stimulated and the screen is stopped, the child has to pick up faster. So when a child has deficit in all the features of joint attention, then it can be due to autism spectrum disorder. If the child has inconsistent features, then rather than labeling the child as risk for ASD, we can give a diagnosis as social communication delay and we can start stimulating the child. So if there is a child with suspicion, what has to be done? Immediately the child has to be referred for early intervention. The early intervention doesn't mean the child has to be given a diagnosis as ASD or at risk for ASD. If the child has many features, then based on the diagnostic tools, we give a diagnosis. For some children where few features are there, few features are not there, we can just put it as social communication and we can go ahead with the early intervention. Can you please mute yourself? So, can you please mute yourself, Dr. Anil? So what is the impact of early intervention? If a child is put on early intervention, 75% of the children are able to reach the mainstream school for English. They are able to pick up in their language. They are able to understand language. They are able to express. They are able to conquer their cognition, academic skills also. So, can you please mute yourself? If these children are followed up till adulthood, almost 38% of the children can be leading an independent life as adults. So if you are going to pick up these children early and refer, and if early intervention is started, there is going to be a huge difference in this child's life. Now moving ahead, we are going to case study 2. This is child B. He's 7.2 years. The main concern of the parents is behavioral issues. So when we ask in detail, they say like, ma'am, he doesn't listen to our commands. He's so inattentive. Sometimes he forget what we told him. He's always on the move. He's very hyperactive. He wants to jump. He wants to climb. He fidgets and he breaks the toy. Whatever toy we buy for him, maximum it lasts for 1 week, not more than that. And he also attempts dangerous activity. Recently, he was lying on his balcony parapet wall and he was calling his granny and he was showing him, see what I'm doing. And in the play area, he pushes other children or he lie down on the corridor so that he seeks unwanted attention. Sometimes he knowingly screams during office calls of his parents so that he gets attention of his parents. And after this, if the parents scold him or punish him, he understands the consequences. He says to them, yes, I shouldn't do this. He mentions what would be the consequences, but next time, again, he repeats the same mistake. And mother mainly came because she had a lot of difficulty in making him write. He was extremely distracted during his writing task. Even a minimal sound will make him distracted from the homework activity. But generally, mother feels he is above average in all his oral-based tasks. And even in the online class, unless and otherwise the teacher asks him something, he might be sitting and answering. Otherwise, he doesn't have much of sitting tolerance. Otherwise, if he sits, he starts asking a lot of questions to his mother, or he might unmute himself and start disrupting the class. He argues with adults in the home. Sometimes he might become aggressive also with his grandma and dad if they are not giving something. So what could this be? Is it a normal naughtiness or hyperactivity of a 7.2-year-old child? Should we reassure the parents, or should we think it as ADHD? Now, what is a normal? In a normal development, children less than 6 years of age have high motor activity. That is normal for their development. And in this COVID time, when they are more restricted and they don't get an opportunity to go out because of the fear of the parents, or the school is not there, they don't have a play time with their PT time with their peers in the school. So high motor activity is normal. But if it is so disruptive, then it is not normal. And with age, this motor activity should start decreasing. For example, if a child was very high motor activity at 3 years of age, the parent should feel like, okay, by 5 years, the motor activity is decreasing. By 6 years, the sitting tolerance and attention span is increasing. Similarly, impulsive behavior is quite common, and it starts decreasing by 7 to 11 years of age. Because a child starts developing concrete operational thinking, they know that, okay, if I do this, this would be the consequences. So before any action, the child will think and operate. And by 11 years of age, the child becomes like a mini adult where they can think and make a decision. If so, then it becomes a problem. If the child is so motoric, so impulsive that it disrupts the relation with others, with his peers. For example, this child, his main way of playing with other children is pushing them or seeking bad attention from them by lying on the corridor. So it disrupts his relationship with others. He's not able to play with his peers. It affects the acquisition of age-appropriate skill. For example, for this child, his online class or during writing homework, it was very difficult for the mom to make him learn age-appropriate skills. Her worry is academically, oral base he picks up, but when he goes to the next year, I'm so worried, doctor, he might not write anything at all. So if the problem is so severe that it affects the acquisition of age-appropriate skills, then we can't reassure the parents saying like, okay, small kids would be hyperactive, it would settle over time. And when it is accompanied by negative emotional behaviors or aggressive and oppositional behaviors, then the action should be taken. So what is ADHD? ADHD is not just hyperactivity and inattention. ADHD is a neuronal connection between the frontal lobe, the executive functions of the brain, and other part of the brain is deficit, and this results in ADHD. So it's not just impulsivity and hyperactivity. So to say in simple words, the brain lacks the executive functions or the brake system. Because of that, the child's working memory is also affected. So in a way, if working memory is affected, the child doesn't have a concept of time. Time management would be a big problem. We all get distracted. Might be we are doing some work and a calling bell rings. We all get distracted. We all just look and immediately we come back to our task. But in an ADHD brain, because its working memory is deficit, when they get distracted, they completely forget about on task, and this creates a lot of problem. The second one is self-regulation of affect, motivation, and arousal. When we get angry, our brain has a brake system which talks about the consequences of our severity of anger, and based on that, we limit our anger. But in ADHD brain, since this brake system is not there, the child might become aggressive, the child might talk a lot, and that creates a lot of problem for the child. And the second thing is motivation is some inherent skill where we have something called hindsight and forethought. Based on that, we take our action. For example, if I have to study for my exam, I should know that every day I should read small chunk. And at the end of 1 week or 1 month, I would be giving my exam. And if I do my exam well, my parents will get something for me. This is a normal thing a child should develop around 8 years or so. If a child doesn't have this concept of forethought, foresight, then the child might not do his action. He might be procrastinating all his work, and he might have a lot of incomplete work. The motivation becomes a problem. So ADHD is not just inattention and hyperactivity. ADHD children have a lot of executive function deficits like time management, motivating themselves, arousing themselves to start an activity, managing their emotions and problem solving. So if you find some children where they are hyperactive and at the same time it is affecting their development, rather than reassuring them, we can refer them early to a developmental pediatrician where the actions are taken. What are the actions? It could be drug, or it could be a behavioral management based on the severity. For children less than 6 years, the first action would be behavioral management, followed by medication. If the severity is more, then they might be started on medication earlier too, before 6 years of age too. And why early intervention is required in ADHD? ADHD is always associated with many comorbidities. If they are referred earlier, these comorbidities can be picked up earlier. And another one is there are some comorbidities which arises because of not managing ADHD properly. If they are not managed properly, the child might become very anxious, depressed as they go higher up. Around 10, 11 years, they might become more anxious and depressed. If so, intervention is started early, we can prevent this too. Last case study. This is a child C who is 5.2-year-old. He recently joined in UKG and the mother's concern was mainly academic concern. He has a very good attention span when he does his art and craft, but completely avoids academic learning. He doesn't come for his homework time at all, or he doesn't concentrate in his online classes. He has a consistent confusion in identifying few colors. He can identify uppercase and lowercase alphabets, but few alphabet, he has a consistent confusion. He can't differentiate between M and W, M and N, P and Q, D and B. If it is 12, he might read it as 21. And he can't read the 3-letter words. If CAT, cat, bat is written, he is not able to read it as cat, bat. He has difficulty in writing. In writing, the main issue is sometimes he reverses his letters. Like he might write P as B. And while writing, he mixes uppercase and lowercase alphabets. So the main concern in his academic things. Now, with this, we can suspect it could be risk for specific learning disability. So what are the early signs of specific learning disability? They might have difficulty in verbal communication also. These children might forget words. They might be always searching for words, or they might replace a word while talking. For example, for door, they might say window. They might have difficulty in remembering and following multi-step instruction. Working memory, executive function is also a problem in specific learning disability. So when you say the multi-step instruction, they might get confused. If you say them like, go to bedroom and get a red ball and a big blanket, they might get confused. They might have trouble remembering the order of alphabets. If they are singing alphabet rhymes, they might sing, but when you ask them what comes after K, they might not be able to say. Similarly, they might have trouble remembering numbers and days of the week. Any order they can't remember. And if they can't remember an order, if they can't remember a sequence, then their mathematical abilities might be affected. They might not be able to say before, after number. They have a problem in connecting between letter and sound, a phonetic connection. If so, the child has to blend and read a word like cat. The child should know C says ka, A says a. The child might not be able to identify that C says ka, or he might not be able to blend, and this results in a lot of confusion in reading. They might recognize individual letters or numbers, but when it comes to combining together and reading, or letters or numbers which look similar, they might have trouble in differentiating. They might have trouble in identifying colors, shapes, visually discriminating sizes, right leg confusion. If all these features are seen, then the child is at risk for specific learning disability. Any child who is less than 7 years of age, we will say like risk for specific learning disability, not specific learning disability. If so, only 1 or 2 features are seen, can we name it as SLD, or is it parental anxiety because of this online schooling? See, every child go through a process of learning. If 1 or 2 features alone is seen, and it is seen for a very short period of time, for 6 months, and the child improves, then we can't call it as risk for specific learning disability. Might be it is parental anxiety. If so, any child comes to you with only 1 feature, like he reverses the letters, or he has minimal confusion in identifying 1 or 2 alphabets. He's struggling to read, but he knows the alphabet and sound connection. Then we can't deem the child a specific learning disability. We should also reassure the parents how learning happens. Now, most of the learning is online. No direct learning is happening. There is a huge difference between direct learning and online learning. In online learning, the multisensorial part of learning is not happening. It's morely visual, and the child is expected, or the parent is expected to do with the child the multisensorial learning. If it is not happening, then the child might have difficulty in picking up the concept. For example, as simple as if a child has to write a number 6, might be in the school, the child is made to trace 6 in a sand, then the child is made to trace 6 on the board with his finger, then trace over the 6 with a chalk piece, and as they are writing, they are also made to say like C go in 6, C go in 6. So there is a tactile learning, there is a visual learning, there is an auditory learning. If the learning is not supported multisensorial, the child would pick up, but the child would pick up gradually. And the child needs consistent practice for learning any concept. When we say consistent practice, for writing, consistent practice is very much essential. Just by writing one time, the child will not learn. But in a school, this consistent practice, direct learning, consistent practice happen. But in online learning, the parents are not getting enough time to do this consistent practice. This can also show some inconsistent features in the child's learning, which looks like specific learning disability, risk for specific learning disability, but as such, it is not specific learning disability. The next one is concept strengthen over time. Now the parent is sitting next to the child and the teacher is talking and the parent is expecting the child to grasp the concept immediately. But generally learning doesn't happen that way. It needs time for the child to strengthen the concept. Sometimes it can be parental anxiety also. And attention span and executive functions are developing in these children. If the parent expects a lot of attention span, for example, if the parent feels like, okay, I have 1 hour time in the evening to do the homework with the child, and within the time the child has to complete, the child, a 6-year-old child or a 7-year-old child might not have that much of attention span to complete within that 1 hour. So these difficulties, if all the difficulties are seen or many difficulties are seen, then it could be early risk for specific learning disabilities. If only few are seen, it could be just an anxiety of parents where these opportunities are not happening in online learning, and that results in the deficit. To differentiate that, the child needs a detailed evaluation. So the child has to be referred to a developmental pediatrician, where the pediatrician decides whether it is just a concept where the child is taking a little more time to learn because of online schooling, or really there is a deficit. If there is a deficit, then the child is given a diagnosis of risk for specific learning disability, and the child is started on remedial education, so that before the 3rd standard, the child picks up most of the concept, because till 3rd grade, the child is expected to learn to read. After 3rd standard, he should use his reading skills, or he should use his mathematical skills to apply and learn. They read to learn after 3rd grade. So any child, if they are picked up early by 6 years, then they have sufficient time, 6 to 9 years, to build this concept through remedial education, so that their overall final academic skills are not affected. So let's all make a difference in every child's life. Early identification creates a lot of difference in the child's life, make the child an independent person, make the child a confident person. So making a difference, we can start doing it by identifying these children early. Thank you. Any doubts? It's open for discussion. Let me check in the chat box.
What about the videos, Dr. Kirtika?
Just a second. Let me check whether I can play it.
Nothing in the chat box. So anybody here having any questions for Dr. Kirtika?
Although he looks at the...
Is the video seen now?
No, maybe I think you have to put down minimize your slides and
I did it. I'm just sharing it directly also. Okay, I'll go ahead with the questions. Basically, you're going to discuss MChat. It's basically few things from MChat only. So might be they can learn in your sessions.
Yes, hopefully.
So it's videos from MChat only, following pointing and sharing interest.
Okay. So I think there's one question in the chat box.
Okay, let me just a second. Oh, can you read the chat box for me?
Yes.
How cognitive function affects executive function? Okay. See, if a child's IQ is low, one of the component of IQ is executive function also. If a child's IQ is low, obviously the child's executive function is going to be low. Executive function is something which starts developing around 4 to 5 years of age, and it keeps on improving. And by 11 to 12 years of age, the child acquires the executive function as equal to an adult. So it's an ongoing process. If the child's cognitive function is low, then the executive functions are obviously going to be low only. So in SLD child and mild ID child, what is the difference? In SLD child, obviously the executive functions is going to be different, but the cognition is going to be normal. The IQ will be in the normal range. In mild ID child, the IQ is going to be less than 70. So because of this low IQ, obviously they are going to have low executive functions also, which is going to affect their learning. So if a child has cognitive deficit, mild ID child will suffer a lot rather than an SLD child, because IQ is better, the child can compensate in other areas. Hope I am clear.
Okay. So anybody here have any questions? No. Okay. So questions from here. Thank you, Dr. Kirtika.
Yeah.
For that. Okay. So now I would like to welcome back Dr. Usha Devi to continue her presentation. So I hand over to you.
Can you see the slides, ma'am?
Yes, we can see the slide.
Okay. Thank you.
And we can hear you nice and clear.
Thank you. Okay, so we had seen how do we stratify babies into high risk, moderate risk, and mild risk based on the comorbidities what they have and development, the neurological assessment at discharge and weight of the baby, gestation of the baby, and other morbidities. So now the prerequisites of follow-up services, one of it is discharge planning. We all know that discharge planning is very important for high-risk baby, and even before discharge, certain things should be satisfied to discharge the baby. Like baby had to, if it is a preterm baby had to cross the birth weight and should be having a consistent weight gain. And for the past days, baby should have had some 15 to 20 grams per kg weight gain daily. Baby should be able to maintain his or her temperature, and mother should be confident. And all these screenings like ROP screening, everything should have completed. At least first check should have been completed before discharge, and immunization should be completed. All these things need to be done before planning discharge. And as well as counseling of the parents regarding what can we expect in follow-up, and how are we going to follow up the baby, where are we going to follow up the baby. And in the follow-up, one of the main prerequisite is multidisciplinary team. It is not just a single person, pediatrician or neonatologist. We need a team of members, and each one with a different expertise according to the needs of the baby. We will be referring the baby to each personnel. And yes, so as I already told, pre-discharge certain criteria has to be satisfied, and not only during follow-up, even before discharge, certain things has to be checked and examined in the baby, like medical examination. A baby with an ongoing illness cannot be discharged, then it might add on to the morbidities and baby might come back sick. And physical examination to look for any developmental dysplasia of hip which might be requiring any intervention, or hernia which might be requiring any intervention. Neurological examination, as previous speakers beautifully elaborated on the neurological examination. At term equivalent, we can do HNN-EMS with a neonatal neurological examination, or just you can do the angles. What is the tone of the baby? How is the posture of the baby? What is the popliteal angle of the baby? All those angles. So how do we check tone of the baby? We will be seeing in the subsequent slides. So all these things we can do. Tone, posture of the baby, how are the reflexes in the baby, how is the activity of the baby in general. All these things we can document in the discharge summary as well. And neuroimaging. This also one of the previous speakers elaborated, like ultrasound or MRI. For a preterm baby, we'll be doing within 72 hours, 1 week, and 1 month ultrasound. At term equivalent also we'll be doing ultrasound. Some units practice MRI at term equivalent to pick up any abnormalities. And ROP screening, yes, there are some criteria. Some babies are candidates for ROP screening, and we screen them for ROP at 3 weeks or 4 weeks before discharge. And hearing screening, it is mandatory. And most of the units screen for congenital hypothyroidism. And some of the units also screen for metabolic problems, so that we pick up the babies early. So we have already seen about neonatal neurological examination, AMSWITH, which will be discussed in the afternoon session as well, as already discussed. So in the follow-up, not only the pediatrician or neonatologist who is going to monitor growth, development, any ongoing illness, and the treatment which will be needed for the baby, but also there are other team members like child psychologist who will be who will play a crucial role in doing a formal developmental assessment and picking up any delays, and also referring the baby for appropriate intervention. And a pediatric neurologist who will be treating the tone abnormalities. If the baby has any seizures, we'll be giving medication for the same, and titrating the medications, all those things. And ophthalmologist, not only for ROP follow-up, these high-risk babies also can have other morbidities like squint, squint or decreased visual acuity, refractive errors. All these things can be picked up in follow-up. And next is otorhinolaryngologist, who will be picking up any hearing loss in the baby very early and referring the baby for appropriate intervention. A dietitian. So growth charts, growth we are going to monitor. If there is going to be any gross discrepancy or failure to thrive, appropriate dietary intervention will be done by them. A medical social worker who will be, even if the baby doesn't come for follow-up, they will help in tracing and making the parents to bring the baby for follow-up, and also helping in logistics with arranging different communication between different specialties and different personnel. And physiotherapist, when there are any tone abnormalities, physiotherapists might help in improvising this, and they will teach exercises as well as exercises which has to be followed in the home as well. And when the baby has any disability which is going to limit his or her functional activity and speech impairment, appropriate speech pathologist and occupational therapist should be involved. So it is not just one person, it is a multidisciplinary approach. And where are we going to do this developmental follow-up? It is very important. The parents need to know before discharge where they have to come, whether they have to come to NICU or just normal OPD. So most of the units have a developmental unit along with the routine OPD. So some of the units will have developmental OPD running in specific days like Monday, Wednesday, Friday. All this information like floor number, first floor room number 20, and Monday, Wednesday, Friday time between 8 a.m. to 4 p.m. All this information has to be documented in the summary as well as told to the parents. And registration, the parents need not come back for follow-up at 1 month or 3 months and then register their baby. This registration process can be very well done even before discharge of the baby. So even when the baby is in NICU or your Gangaru Mother Care ward or postnatal ward, your developmental follow-up registration can be done, and a developmental follow-up card. Many of the units will give a developmental follow-up card which will comprise of various information and schedules that has to be followed during the follow-up. And maintenance of records. This high-risk babies, whenever they are getting discharged from NICU, their name, contact number, address can be recorded in a separate high-risk register, so that the team can follow up even if the baby doesn't turn up for developmental checkup. So this also can be done. So the developmental unit, where it is, when it is functioning, all these things has to be told to the parents well ahead even before discharge. So this is a developmental tracker which is given for IRIS babies at discharge in our unit. So here registration number will be entered and date of birth, what is the EDD, what is the post-menstrual age at discharge, and what is the date given for follow-up, first follow-up. All these details will be entered. And some first 2 pages, there will be some details about socio-demographic profile and specific information which will be help in stratifying the baby as high-risk babies. These demographic informations like socio-economic history, all those are also important, because as previous speaker Nandini ma'am all told that even socio-economic status will play and demographic factors will play a role in the development of the baby. And some of the histories like intrauterine insults, any need for resuscitation, any details of mechanical ventilation, respiratory support, any hypoglycemia in the baby, and whether the baby had any HAE, what was the stage, any surgery for NEC, and whether the baby has ROP, what was the post-op duration of stay in hospital. All those things can be entered, so that on follow-up, if a different person, different physician is following up, he will know that this baby is more prone to develop adverse outcome, and he has to keep a keen watch when the baby is showing deviation from the normal development. So schedule for follow-up, it might the unit protocol might differ in different places. Whether you are going to put a baby less than 1.8 kg or less than 2 kg as high-risk baby, it depends on the unit protocol. If it is going to be a preterm baby, yes, we need to ask the baby parents to bring the baby for follow-up in 1 or 2 days, because we need to check the adaptation in the home environment. And frequent follow-up might be needed till the baby reaches 2.5 kg or 3 kgs. Afterwards, what we can do is we can combine the visits along with the immunization visit, like 1.5 months, 2.5 months, 3.5 months, we can combine, so that it will be easy for the parents to travel and come as well. And for all other conditions, maybe we can give 5 to 7 days after discharge, and we can ask them to come, and further visits can be planned according to the schedule for high-risk babies. So this sheet is also incorporated in the developmental follow-up card. So in this sheet, in different age, different postnatal age, we have given what are the assessment that has to be done in the baby. Like growth assessment will be done monthly in the first 3 months, thereafter every 3 monthly, and then CDC grading for it. Head control, what is a CDC grading? Whether the baby is doing good means baby will be grade 4 or grade 5, or whether there is any abnormality, whether the baby has not reached any complete head control or what. So this CDC grading can also be documented, and Hamilton angles for tone assessment, which we will be seeing later. And we use DDST, Denver screening test. At least once it has to be, baby has to be screened before 6 months of age, and all these components will be entered. So if we are checking at 3 months, then it will be entered whether it is normal or there is any caution or there is delay. Any associated problems that is present in the baby, like baby has DDH or baby has ROP, any other associated problems, that has to be documented here. And finally, the physician, whoever is seeing, will sign. So follow-up schedule for neurodevelopment, when the parents have to come for follow-up, 3 months, 6 months, 3 monthly follow-up till 1.5 years, and later at least 6 monthly follow-up till 5 to 6 years of age. And we all know that for less than 32 weeks and less than 1.5 kg baby, ROP screening has to be done. And what is the follow-up ROP visits? It will be done till 44 weeks of post-menstrual age also. So those schedule also, it will be given in the developmental follow-up card. And squint evaluation at 8 or 9 months, and refractive error checkup at 1.5 years, 2 years, all these things need to be done. And hearing checkup, speech and language assessment at 1 year, 2 year, and 3 years. Psychology assessment, some units use DASI, some units use Bailey assessment for a formal developmental assessment in the baby. That has to be put as well. So these are the papers we have in our development follow-up card, so that and we explain them what is given in the card also, for the parents to easily understand, so that they can mark the date and they can come on the specific time for each follow-up. And once it is done, suppose 4 months DDST has been done, it will be circled. 8 months behavioral audiometry is done, it will be circled. Squint evaluation is done, it will be circled. So this, whatever has been done appropriate for age, it will be circled, and so that we know that in follow-up, yes, baby is under regular checkup and it is undergoing all the checkups which is needed for that age. So coming to the main topic, follow-up. So what are the things we are going to follow? Nutrition. So nutrition, some simple histories we will be asking from the mother. So what is the mode of feeding? If it is going to be a preterm which is getting discharged, whether palade feeding or dad breastfeeding, what is the frequency of feeding, whether the baby is getting adequate feeding. The adequacy we will be checking by asking the mother whether baby is sleeping for some 3 to 4 hours after feeding, baby is sucking well for at least 15 to 20 minutes, baby is voiding some 8 to 10 times urine, all these things we'll be asking. And then complementary, once the baby crosses 6 months, what is the complementary feeding the mother has started, and what is the nature of food that they are giving, what is the frequency of food it has been given. And main thing is supplements. When we are discharging a preterm baby, baby will be on many supplements, right? So medication has to be stopped. All the medications has to be preferably stopped before discharge of the preterm baby. And if it is going to be, if we are stopping caffeine, we all know that baby has to stay for 5 to 7 days, at least to see that baby doesn't have any more desaturation or apnea. And baby might be on calcium, phosphorus supplementation. So whether to, so now the follow-up physician has a doubt. Okay, shall I stop the calcium phosphorus since the baby has reached term or baby has reached 34 weeks, or should I consider continuing calcium and phosphorus supplementation? Usually for osteopenia, this calcium phosphorus supplementation is started, and usually it can be stopped by term equivalent. However, we have to see what are the serum values and decide whether these things can be stopped. And we know that iron and vitamin D at 400 units at least should be continued till 1 year of age. So I'll come to this supplementation. So this is a preterm investigation checklist which we will be having in our NICU chart when the baby is in NICU. So ultrasound cranium, what was the fastest cranium report? What was the 7 days USG cranium report? What was it 28 days? And when the term ultrasound is posted, so when the baby has to undergo the term ultrasound. And then thyroid function test, what are the thyroid function test values, and caffeine when it was stopped, and fortifier when it was started and when it was stopped. And see, the important thing is what I told was hemoglobin, alkaline phosphorus, and calcium and phosphorus. So these trend, whatever we have done in NICU during the hospital stay of the baby also will be there. And the physician on follow-up can see what are the phosphorus and calcium value, and he can decide whether the baby's phosphorus, everything is normal, whether it can be titrated and stopped. That can be decided based upon this blood investigations. And ROP, what was the ROP findings in different checkups, and when is the next due date for ROP checkup. So hearing screening, whether it was done at all, whether MRI is planned for this baby, and what were the weight trend, etc. So these chart we keep in the NICU record only. But when the high-risk baby is getting discharged, what we can do is we can take photocopy of this preterm checklist and attach with the developmental follow-up card or the discharge summary, so that on follow-up, the pediatrician or neonatologist, whoever is seeing, will have an idea what checkups are pending and where he should refer the baby to, and what are the blood investigation of the baby is like. So all these things they will get an idea. Next is growth, appropriate growth charts, like Sir told, Fenton chart we can use, and we can see what is the growth trend when the baby is in NICU as well as in the follow-up. Any growth faltering should be picked up early and treated. Why growth is very important, nutrition is very important, means it has an implication on the development of the baby as well. So in this growth chart, this line is appearing faint. Okay, so this length, its circumference over different weeks have been marked. So this Fenton has till 50 weeks post-menstrual age. So what we can do is this photocopy is attached with the discharge summary, so that this on follow-up they can plot the weight and its circumference values as well, and they can see what is the trend of the its circumference. As Naveen sir told, sometimes it might show total faltering. That means that there is decrease in the egg growth, and sometimes weight also there may be faltering. Then we need to take appropriate intervention. So Fenton chart, Intergrowth chart, these are some of the standard charts with, which are used. Some units for less than 1.5 kg use Seren Crunch chart. Anything can be used, and the trend has to be seen during follow-up. During follow-up, that is more important. What is the trend in the weight increase and head circumference increase? And okay, after 40 weeks or for a term baby, let's say who is coming for follow-up, WHO charts, Z-score charts can be used to pick up either malnutrition or underweight. Ongoing illness, we all know that during follow-up, any ongoing illness like babies having superimposed bronchiolitis, or babies having some LRA infection, or baby is not gaining weight, some occult sepsis you are suspecting, all those things should be picked up by pediatrician so that we can avoid further insult and bad outcomes in the baby. And immunization schedule has to be, it is attached to the follow-up card, and this 1.5 months, 2.5 months, within 1.5 months, medical examination, proper growth assessment, neurological examination, and most importantly, hearing screening maximum should have been completed by 1 month to 1.5 months of age. And ROP, regular follow-up. Whenever the ophthalmologist has told ROP follow-up, 2 weeks or 3 weeks review, that has to be done. And after that, we can pair the developmental assessment or neurological examination along with the immunization schedule. The 3 months follow, we can pair it up with 3.5 months vaccination, so that parents need not come separately for immunization and for developmental follow-up. Hearing assessment. The most important thing we should remember is rule of 136, where the screening has to be completed before 1 month of age, and before 3 months. If the baby fails the initial screening, a comprehensive audiological assessment has to be done, and before 6 months, whether baby might be needing a aid or baby might be needing a cochlear implant, all those things has to be done before 6 months. Why it is so important? Because as all of the speakers told, the hearing has a major bearing on the language and communication skills. Totally, it can decrease language development and communication development if hearing is a problem. And we might think it has some other problem and be treating, but actually the issue is with the hearing. So OAE, all of you know, most commonly used in all the units for screening the baby. A microphone is kept in the ear, and response from the cochlea or the outer hair cells is noted. However, OAE can, for high-risk babies, it is preferable to use auditory brainstem response ABR than OAE, because OAE might miss retrocochlear or auditory neuropathy problems. So AAR can be used for high-risk babies. AAP also says that rather than going for OAE, go for AAR, automated auditory brainstem response, and it will give a result either as, this is automated, this is a simple screening test, not the comprehensive BERA or conventional auditory response, brainstem response. So it will give the result as pass or fail. So some go for two-step screening, like first OE they will do. If it fails, they will go for ABR. If both the things fail, then they will go for conventional ABR or diagnostic, or what we call as diagnostic ABR, which will take a longer time, and audiologist is needed. So all those things are there. And however, this two-step screening might be for normal babies, but for high-risk babies, AAP say directly go for AABR only. And as I already told, neonates who fail comprehensive evaluation before, who fail the hearing screening should be done comprehensive evaluation before 3 months, and appropriate intervention should be done before 6 months. So if we do for comprehensive audio, if the baby fails the screening, we go for diagnostic BERA. So it will give where is the problem. Problem is with the nucleus, or problem is with the cochlear nerves. So where is the level of problem, what is the extent of problem, that also will be picked up. Whether baby is having profound hearing loss, severe hearing loss, that also has to will be picked up, and appropriate intervention should be planned before 6 months of age. Some of the babies have are at high risk of developing even progressive hearing loss. Who are those babies? When the caregiver has concern, yes, my baby is not turning to sound. I feel, doctor, my baby is not turning to sound, and family history of childhood hearing loss is there, or baby has been in NICU for more than 5 days and received ototoxic medications, torch infections, or baby has craniofacial anomalies. All this puts the baby into high risk of developing hearing loss. loss, of having a congenital hearing loss also. So preterm babies, many a time when we do screening before 34 weeks of gestation, it might be baby might not pass. So for preterm babies, it is better to time the hearing screening by 34 weeks or after that to avoid false positive results. High risk babies, I told some high risk factors. No, so if the baby has all these high risk factors, then the screening alone is not enough. Testing will be done every 6 months till 3 years of age, because they have a high risk of developing progressive hearing loss as well. So just to sensitize you to something called a so low cost hearing screener, where this ministry, the Department of Biotechnology has implemented this in many centers, and it is thinking of scaling up in many more centers in India. So this so low cost hearing screener, no, your AABR OAE will be affected by noise, but this hearing screener which they have found out, it can be performed even in a noisy environment, and the waves also will be there, different decibels, we can check 35, 50, 70 decibel stimulus can be given, and we can check it, and it can be recorded. The main thing is it can be recorded and sent to an audiologist for an expert opinion, and minimal amount of electrodes are needed. So these are the advantages. It is being used in many centers for screening. Coming to ROP, it has been discussed in detail previously. Why at all it is important? Even if ROP is treated, significant percentage of babies have visual acuity very much lesser at 6 years of age. So we need to follow up these babies for refractive errors as well. So we screen the babies born below 1.5 kg or below 32 weeker for ROP, and in of case below 34 and below 1.75 kg. Even a baby more than 34 weeker will be screened for ROP if the baby has any risk factors. So all the findings will be documented, and intervention whatever has been done also should be documented. So this is a record, ROP record, which will be there in the development follow-up card as well. So here what zone, what stage, whether baby is having plus disease, what are the comments means, what is the intervention done, when does the ophthalmologist want the baby to come for follow-up, all these details will be entered. Follow-up is needed even if the baby is not having ROP, even if the baby is not treated for laser, because even other high-risk babies have high chance of developing refractive errors, strabismus, cataract, and retinal detachment. So follow-up interval according to the zone where it is involved, the follow-up interval might vary, and ophthalmologists might give a different follow-up interval accordingly. So now various just to sensitize you to this wide field retinal cameras or REDCam, where the image can be captured and it can be done even by a trained nurse or doctor or ophthalmic assistant, and can be sent to a retina expert, so that even a peripheral center, the ROP screen might not be missed. At appropriate time, it will be done, and the images can be captured and reviewed by a retinal expert. However, the cost and sensitivity is a problem with this method. So 9 months of age, we should have evaluated the baby for any screen to optic atrophy, cataract, vision, and so subjective visual assessment on follow-up will be done by whether the baby is able to fix the eye, whether the baby is able to follow any object. An objective visual assessment by 9 months using teller acuity code, all these things will be done. So now coming to the neurological assessment. So there are different HNME, everything was told by the previous speaker, and it will be discussed in detail in the afternoon as well. So we can do, commonly we do this for tone assessment, we will see these Hamilton angles, some of the angles, popliteal angle, adductor angle, whether it is normal for age. For 3 months, the angle should be this much. For 6 months, the angle should be this much. So there is a degree given for each month of age. So first 3 months, 3 to 6 months. So accordingly, whether the baby is following the same trend or the tone is decreased or increased, this can be made with the tone assessment. What is the posture of the baby? What is passive tone? How is the active tone of the baby? So this examination of passive tone and active tone I will be showing in the subsequent video. So I told you, adductor angle for 0 to 3 months, there's a specific angle 40 to 80. 4 to 6, it will be 70 to 100. As the tone relaxes and the baby matures, the angles also will vary. So primitive reflexes has to disappear at some point of time. We will be seeing whether primitive reflexes has disappeared, DTR is normal, whether head growth, which is more important, whether head growth is happening like what we desire, whether there is any asymmetry. baby is having hand preference, or baby is moving, baby is using one side of the body more than the other side, and reflexes are asymmetrical. So we'll be seeing how we will be assessing active tone and passive tone in this video. Next, let us check the passive tone and active tone of the baby. What do you mean by passive tone? Passive tone, baby is passive, that is silent. We make the baby's limbs in certain position and measure the angles. In active tone, we see baby's response to different types of maneuvers. Baby makes some active movements in active tone assessment. Checking the passive tone, the assessment of the active tone and passive tone, the baby should be in state 3 or state 4 without crying, yet in midline and yet along the line with the trunk. And for assessing the tone of the lower limbs, we should remove the diaper as well. First, so now that we have kept the head in midline, we are trying to check the passive tone of the upper limb using scarf sign and arm break coil. In scarf sign, we are able to see that the elbow is not reaching the midline, just short of midline it is reaching. Whenever we are assessing tone or any sign in one side of the body, we should check in the other side as well to see whether any asymmetry is present. So we are checking in the other side. For arm recoil, we are keeping the hand, the flexed posture for 5 seconds and extending it and leaving. We see that immediately baby is flexing. So this is an instantaneous arm coil which is normal for a term baby. We will do the same in the right side of the baby as well. Coming to passive tone of the lower limb, we are now trying to check the popliteal angle of the limb. So while checking the popliteal angle, make sure that pelvis rests on the table and you don't lift the pelvis from the table. And flex the thigh over the abdomen and extend the legs at knee. Check the angle in the legs, the thigh. We are checking the adductor angle where we keep the legs extended and try to spread the legs apart. So by visual inspection, angle comes to 80 to 90 degrees. So at the ideal way, we are checking using the goniometer. It comes to around 90 degrees, which was the same as the visual inspection. For checking the active tone, we need to perform the 180 degree maneuvers. So first we will check the tone of neck flexors. For that, we need to pull the baby from supine position to sitting posture. We can see that head is hanging back. And slowly when we try to make the baby to sit, there is some contraction in the neck. And baby himself try to flex the neck and momentarily keeps the neck along the line of the trunk and then the head falls forward. So this is normal for a term baby. We can also see that the back of the baby is almost straight and it is not so much bent. It means that tone is normal. Now moving on to assessment of neck extensors. We try to put the baby from sitting posture to supine posture. You can see that when we pull the baby slowly, the head okay, there is some problem with the video. Next, let us check the passive tone and active tone of the baby. It means that tone of the lower. We are checking the vertical suspension or axillary suspension of the baby. The baby, you can see that baby is trying to lift his legs and having some kicking movements. It means that tone of the lower limb is normal. Baby is not a fluffy baby. Another Another component of 180-degree flip maneuvers is ventral suspension of the baby. On ventrally suspending the baby, and see that he is trying to lift his head. Keeps head along, he tries to lift the head and keeps the head along the trunk momentarily for a few seconds. So which means that the tone is normal. Now putting the baby to prone posture. He is trying to lift his back. He is having movements of the lower leg. He is also trying to lift his head away from the ground. Let's move to reflexes. First, checking the primitive reflexes. The baby has a rooting reflex, and also baby was feeding well. To check a suck reflex, in exam we need to put the cloud finger inside the baby's mouth and see the strength of suck reflex in the baby. The grasp reflex, we are introducing our finger from the ulnar aspect of the hand, and the baby grasps the finger. We are trying to check the plantar grasp by applying pressure on the base of the toes. Automatically plantar grasp is elicited. We are now trying to check the placing reflex by stimulating the dorsum of one foot. The baby places the other foot over the table, and also by placing one foot over the table, okay. So we have seen the active tone assessment and passive tone assessment of the baby. So passive tone, we are seeing different angles, Hamilton angles, and we are seeing whether for that age it is normal. And primitive reflexes, we are eliciting. Primitive reflexes, they have to be present for certain age only. Moreover, if it is present beyond 3 months of age and follow-up, it might be abnormal. So all these things we need to check during the neurological examination, and if anything is abnormal, we need to start early intervention. Okay, so now neurological assessment is over. Coming to developmental assessment, yes, a recording of developmental history is very important. What happened after you discharge the baby, whether baby had any abnormal movements or whether baby had seizure-like episodes, whether baby is not having any egg control. Mother herself will come with the problem. My baby is not having proper egg control, and what are the any developmental delay? Mother herself is coming, or mother might say baby is having stiffness of legs and I'm having difficulty in putting diaper. So all this will give a clue even before a developmental assessment of the baby. And for high risk babies without any neurological abnormality, we will first do a screening test. Screening test depends on different units. Whichever the unit has expertise and is comfortable in, they can put that screening test. And as Naveen sir told, it is always a corrected age for neurological and developmental assessment. So from 40 weeks, we will correct the age. So baby, it is not just a postnatal age for neurological and developmental assessment. It is a corrected age. We correct it for the prematurity. If the baby is 28 weeks, the 3 months will be deducted, and corrected age will be taken for these milestones. So this developmental milestone chart is also attached in the follow-up card, so that parents, if they feel that, oh, 3 months my baby has to do all these things, but my baby is not doing, they will themselves come with the complaint. Oh, this milestone is given, but my baby is not able to do that milestone. As you all know, we will be in any history taking, we'll be taking what are the gross motor domains, what are the milestones, whether baby has reached, attained whatever is appropriate for the age, fine motor, language, and personal social. All these domains will be seen, and we will be calculating a developmental age, like how we do in our routine, like EMT, or after that also during practice we used to do. And if the baby is having delay in more than 2 domains, then it is called as global developmental delay. Baby requires intervention. So baby is not having any risk factors at all, just discharged from NICU but doesn't have any risk factors. Then if baby is following up with primary care physician or coming for immunization visit, they can use some basic screeners like developmental observation card, and they can put CC grading for head control, sitting, standing, and all. That is enough. So developmental observation card, social smile, whether it is achieved by 2 months, head control by head holding by complete head holding by 4 months, sitting alone by 8 months, and standing alone by 12 months. Whether at least these milestones are achieved. and we should find whether the baby, and most important is whether baby can see, hear or listen. So these are the CDC grading. So complete head control should be present by at least 4 months, completed 4 months. And grade 3, 4, 5, where the baby is in prone position, elevates arms, lifts the chest, holds the head steady while the mother is carrying the baby around, and head is balanced all the times. So this grade 3 and grade 4, 3, 4, 5 will imply that baby is having a normal. Head control is present and it is also normal. There is no lag in that. Similarly, for sitting also there are 5 grades. So standing also there are 5 CDC grades. Usually grade 3, 4 and 5 implies that milestone is normal for that age. If the baby is still in 0, 1, 2, even after reaching the 3 months or 6 months, then it means that it is abnormal and baby needs a formal evaluation. So another screening test commonly used is Trivandrum Development Screening Test, where between 0 to 3 years, 27 item assessment scale is used. So what we do is, suppose the baby 18 months, we draw a vertical line in the 18 months, and all the milestones in the left side should be passed by the baby. If it is not, then it implies there is a delay and baby requires some formal assessment. So this is 24 item scale for assessment between 3 to 6 years of age. At-risk babies, okay, we can also do DDST, which is very commonly done, and the time taken is around 10 minutes, 10 to 20 minutes, and it is a simple screening tool used for babies between 2 weeks and 6 years of age. So the DDST, we follow DDST too. Different units might follow other screening tests as well. So at least once baby has to, high-risk baby has to be screened before 6 months of age, and once in the next 6 months, and thereafter at least yearly till the baby reaches 6 to 8 years of age. So what does the DDST tells? Whether baby has passed or failed or no opportunity. That item was not given to the baby, or baby has not done the test at all. So DDST, this screening test requires some inexpensive materials only, not very costly, and there are test forms and reference manual for the same. So what we do in DDST is, so similarly, suppose we take a baby of 13 months, we draw a vertical line at 13 months. See, we draw a vertical line. What happens is, there is an unshaded part and shaded part. If the line is crossing the shaded part, and this milestone, if the baby is not able to perform, then it is caution. If the baby is performing all the intersecting milestones, then it is good. If the baby is not performing the milestone where the line crosses in the shaded part, then it is caution. If the baby doesn't perform something which is totally towards the left side of the line, then it is delay. If there is any 2 or more caution or 1 or more delay, then it is serious. We have to rescreen the baby in 1 week. If it is also showing the same, we have to go for formal development assessment. I'm not going into detail about the formal developmental assessment tools. This tool is more commonly used, and it gives a motor developmental index and quotient everywhere. But it requires standardized test materials, might cost around 30,000 also, and it requires standard size furniture, and the room should be in a prescribed format with soundproof and fitted with one-way mirror to perform all the activities which I mentioned in DASI. And not everyone can perform. Whoever is certified and has a formal training in DASI only can do, and they should have a proper developmental kit. So some of the examples of how we check fine motor and vision in infant. For a younger baby, we can give cubes, rattle, toys, and we can see what is the baby doing with the toy. Whether he is grasping, whether with both hands or single hand, whether there is a pincer grasp, whether the baby is putting the toy into the mouth, whether mouthing is present, all these things can be done. So this baby is having a bidextrous grasp, and also bringing the toy near the mouth. So this baby is around 5 months of age, and sometimes we can, for older baby, we can give cubes, and we can see whether what the baby is able to make, whether tower or train, or whether the baby, see for this baby, cubes are offered. So the baby is able to catch 2 cubes in one hand. He's also accepting third cube, but is not able to hold, and is having the taking another cube using another hand. So milestone comes to around 15 months. So this baby, tower of 2 cubes, 15 months, and able to bead, larger bead, baby is able to put in the thread. It is 2.5 to 3 years. So these are train means 2 years, and with the chimney 2.5 years. We'll be able to build a bridge using cubes by 3 years, and gate by 4 years of age. So according to whether baby is able to draw a vertical line, horizontal line, square, triangle, diamond, all these things can be assessed for fine motor activities. And books can be given whether baby is able to identify colors or objects, whether baby is able to turn the pages. And when a body part is told, whether baby is able to identify the body part. So another formal assessment tool is BSID 3. 4 is also now available. From birth to 3 years, all the components are seen in the BSID kit. The kit is even more costly and it requires a substantial time of around 1 hour at least to do a formal assessment. Language assessment will be done by LIST score tool by 9 months and 18 months of age. And give simple instruction, and by 1.5 years the baby should be able to give a ball, and 2 command instruction by 2 years and 3 command instructions by 4 years. All these things can be checked to assess whether hearing and whether baby's receptive part is proper. So learning problems, intelligence, cognition, behavioral assessment, all those things can go wrong, and any problems in those things also should be identified. So cognitive function should be properly assessed by 2 to 3 years, and learning disorders should be picked up by 4 to 5 years. And appropriate intervention, if there is any motor impairment, physiotherapy and medication. Physiotherapy for tone abnormalities, speech therapy if there is going to be any impairment. And then when the baby is having any problem, we have to go for early interventions. As madam told, the early support stimulation should start when the baby is in NICU by developmentally supportive care 24/7. And other thing is, if in screening in DASI we find anything abnormal, refer for early intervention immediately. So these are the operational guidelines given for District Early Intervention Center in Rashtriya Bal Suraksha Karyakram. All the participants can go through this RBSK 2014. Beautiful pictures they have given. How the speech therapy room should be there. What are the specifications of speech therapy room? Each room is like that. They have given beautifully the specifications, and all the assessments will be done in District Early Intervention Center. So anthropometry, developmental assessment, occupational therapy, behavioral modification, all these things will be done. They have design of each rooms have been given in detail, and roles and specifications of each staff like optometrist or a social worker, everything is given in detail. So this RBSK 2014 is a good learning material for you to go and go through. And see, speech therapy room, this much size mirror should be there, and one side mirror should be there, room should be there, it should be soundproof, and visual testing room should be like this. All the specifications have been given. So another thing is RBSK in 2019, journey of the first 1,000 days have come. So what most babies will do at this age, for 2 to 3 months, 3 to 6 months, like that, it is given till 1,000 days of life. So seeing this, whether parents can check whether the babies are able to do all these milestones, and what parents can do from their part. They can cuddle, talk, or play with their baby. They can talk, read, sing songs, and even a peripheral health worker can pick up if there is any abnormalities like this. So it is very simply given in diagram and in a pictorial representation. How do they engage the baby in play activities for a baby 2 to 3 months old, and what are the toys they can give for the baby. So take-home messages are: follow pastoral plan well ahead of discharge, and growth monitoring is very, very important. It is interdisciplinary approach. Not all the specialists will see the child one-to-one. There must be communication between the specialist as well. And the most important thing is catch them young when they have a problem and intervene early for better outcomes. Thank you. Thank you for patient listening. Thank you. I thank the organizers for giving me this opportunity. Thank you. Yes, sir. Can you hear me? Sir?
Hello, can you hear me now?
Yes, sir.
Sorry, madam. I think we had power cuts here 2 times.
Oh,
we were able to reconnect, and thank you very much for your detailed talk.
okay, sir.
It's very sad that we had a lot of breaks in between. I hope we will catch up some other day with you face to face, and we would be very happy to have you back again, madam.
Yes, sir. Thank you, sir.
Thank you very much, madam. I think
Thank you, sir.
any questions from the audience here?
So they've asked a sample pro forma for follow-up clinic for general pediatrician. Maybe whatever follow-up card we are having, I can share that, sir. And the Ministry Department of Bio. We get detailed information about how it was innovated, and it has been used in many centers, how they are trying to scale up this SOHM. And gross motor problems, function problems also can be done by 18 months. To 24 months according to the disability. These are the questions that are asked, sir.
Thank you, madam. Thank you very much. And thank you very much for your time on behalf of all the faculty and delegates here.
Thank you.
I'll catch up with you, madam. Thank you. Bye. So for the next 30 minutes, we'll break for lunch. I request all the delegates here to go to where we had breakfast in the morning. So please have your lunch and come back. I would request you to go for lunch first, otherwise it will queue up a lot and it will take a lot of time. The next half of the session is all hands-on, practical workshop. And those who are on virtual, it's a lunch break for you guys as well. And once you come back, we will show you the hands-on kind of practical side of Heinz, GM, and other videos where you can actively participate and interact. Thank you. 30 minutes, please. We'll reassemble at 2:30.
Hello?
You want colors?
Hello, everybody. Good afternoon and welcome back for the post lunch session. So hopefully we won't make you sleep here. It'll be a bit more of a interactive and kind of how the assessments are carried on. So without any more delay, let's welcome Dr. Sundar and Dr. Indra, two of the very good pediatric physiotherapists. So we are starting off with Dr. Indra.
Okay, good afternoon, everyone. My topic is about Hammersmith Infant Neurological Examination. If you all can download the Hein from the Google, you can download and see the videos and correlate how it is. So coming to the introduction, as we all know, Hammersmith Infant Neurological Examination is a simple scoreable neurological assessment designed for evaluating after neonatal period in infants between 2 to 24 months of age. In the morning session, you have learned about Hammersmith neonatal neurological examination. So now this examination is done in infants. So it includes 26 items that assesses different aspects of neurological function, such as cranial nerves, posture, movement, tone, and reflexes. So coming to the what parts have been assessed in this examination is the neurological exam that includes postures, cranial nerve function, reflexes, tone, and movements, which is scored. And the other two, the development of motor function and the state of behavior is just noticed. And the scoring process are each items are scored individually in 0, 1, 2, or 3. So coming to the overall scores is estimated by adding the sum up scores. Just a minute, we'll be back. Okay, I'll just tell you this. Yeah. Okay, so why should we use Hein in our clinical practice? Because Hein is easily performed and accessible to all clinicians, and it can be completed in 5 to 10 minutes. And it has a good inter-observer reliability, even in inexperienced staff. The optimality scores are based on the frequency distribution of the normal population according to the age, and has been used in different high and low risk populations for both preterm and term infants. So coming to why you need, like what you need in the high scoring, you need the scoring form, you need 2 rattles, a reflex hammer, and a pen and a pencil. So coming to the summary of what all scores are being examined are, as I already told you, the cranial nerve function, the posture, the movements, the tone, reflexes, and reactions. And the number of asymmetries also calculated, which is seen in the scorings. So let us look at scoring. The first component is the cranial nerve functioning. So how is it? Like we see the facial appearance, the eye movements, the auditory response, the visual response, the sucking and swallowing. So each of the item is scored upon the what baby is having. So when we see the facial appearance, if the baby is having expressionless and does not react to any stimuli, we score it as 0. So when baby is closes eyes but with a poor facial expression, we score it as 1. So each component has 0, 1, 3. So the lower scores are saying that the child is having difficulty in the neurological functioning. So administration, items need not to be administered in the order. We can go with the baby's flow, be gentle and playful. So before watching the video, I'll just tell you what to do with the assessment of cranial nerve function. First, we need to check the facial appearance at rest and when stimulated. And when we are looking for the eye movements and visual response, we need to see, we also have to correlate with how the postural control is. If the baby is having different movements like dystonia or something, the eye movements and the visual response will definitely be changing. And also we need to look for the auditory response. 2 rattles can be used on the either side. We are just checking here for the auditory response, but we are not checking for the visual tracking. So, and then for the sucking and swallowing, we can ask mothers, like how is the daily breastfeeding, or else how is the sucking for the bottle and a pacifier, or else we can check with the gloved finger. So now we'll look into the video, how do we assess the cranial nerve functioning. So if we look here, we are not checking for the visual tracking. We are checking for the auditory response. And then we are checking for the eye movements. Okay. So in the next component is the posture. Here we need to note for the asymmetry. So the first position is to see the baby in sitting position, and we have to look for the head orientation, the trunk orientation, and how the baby's trunk control is. And also for assessing the posture for arms, score 0 even if one arm meets the description and any note of asymmetries. So we have to look for the asymmetries and note down at the end of the scoring. So for hands, we need to score it separately. So coming to checking for the posture in legs, here also we have to see how the baby is in sitting position, in supine position, and in standing position. And each, if we look at the scores, it has been mentioned there, if the child is unable to sit straight unless knees markedly, so bent, you can look at the image there. So you can mark it as 0. And when looking at the feet, here also we need to check in supine and as well as in standing. And when coming to checking the assessing the movements, we need to see 2 components. One is quantifying and qualifying. How do we, the first one is watch infant lying in supine. We are not stimulating the baby here. We are just observing the baby and how the movements are. So if the score, if there are minimal movements, we will score it as 0. If there are sluggish and excessive movements, it is 1. And there are no scores for 2. And if the normal movements, it's 3. So when we qualify what kind of movements are those, so we need to see whether the baby is having, in the morning session, you got to know about the cramp synchronized movements and all. So we need to see whether the movement is cramp synchronized, whether the baby is having extensor spasms or ethetoid or very tremulous or myoclonic spasm, or whether the baby is having a dystonic movement. So in few babies might be showing the jerky and slight tremor. We may get confused between the 0 and 1. So we need to look at the quantifying the movement and as also with the qualifying the movements. We'll see the video. First. So here we are looking for the posture of the baby, for the upper trunk, the head in sitting position. Okay, so now we are checking for the head orientation in the vertical, if you can see, whether the baby is able to maintain the head orientation vertically or drooping it forward or backward. So if you see in this video, the movement is a voluntary movement. So the baby is trying for bidextrous grasp, but still the grasp is not there, but she's trying to reach the toy. So now the third component is assessment of tone. So we need to assess differently with hands and separately and the lower extremity separately. So we need to do both simultaneously. Suppose if you're doing a scarf sign, first we need to do it on the one side and immediately on the other side. And looking upon the angle, we need to score whether the baby is having 0, 1 or 3 scores. And in the morning session also you learned about the active and passive examination. You need to see about how the passive shoulder elevation is there with passive movement. It's not observation. We need to do a passive movement, doing the examination, whether you need to see whether there is a resistance and whether it is overcomeable or it's difficult to overcome the movement. And also when you're checking the pronation and supination, you need to assess the baby in full extension of the hand. It's not with the elbow flexion. With full extension of the hand, you need to pronate and supinate. And that's how you score in the hind. So coming to the tone in lower extremities, fast passive range of motion is to be done to assess the adductor angle, the popliteal angle, and the ankle dorsiflexion. So here the scores, if you see the angles are already mentioned, so it's very easy to score fast looking at the proforma. So you need to first do the hip adductors angle simultaneously again, even the popliteal angle, the ankle dorsiflexion, the pull to sit, and the ventral suspension. So when coming to popliteal angle, so many of us do mistake saying that the above angle is the popliteal angle, but you should not lift the baby's hip off the floor. You have to assess from the ground level to where the extremity is moving. So that angle, the second angle is the popliteal angle. So you make sure not to lift hips off the surface and do both the legs at once. So ensure measure angle between femur and tibia and not between the femur and vertical axis. So let's watch a video. This is how we examine the scarf sign immediately after one extremity to other. So if you see how to examine pronation and supination, it's in full elbow extension. If you see here, the hips are not off the floor. Okay, hope you are all clear about how to assess the tone in both upper extremities and lower extremities. I think that's enough. So next, coming to the assessment of reflexes and reaction. Yeah. No, we are not flexing at the abdomen. We have to just hold the lower extremities and take it off from the floor and not the hips off the floor.
Sometimes what happens is there would be an asymmetry. One popliteal angle will be much lesser than the other. So what you do is, you do an asymmetry score. Whenever you see an asymmetry, you give a score of 1. During the interpretation, I will be talking about what does that asymmetry really mean, right? So that is why we are doing it simultaneously. You do it on one side and then immediately you do it on the other side. Why do you do it? Is because you understand the differences. Okay, so when you understand the differences, you give an asymmetry score of 1. So and keep adding those asymmetry scores, and then that makes sense when you're finally doing an interpretation of the score.
Okay. Okay. So hope you're all clear about the examination till now. Any doubts? Yes, ma'am. There's only one video it's left. Yeah. So next, coming to how to assess reflexes and reaction. It is easy as shown in the proforma. You can just do arm protection, pull the infant by one arm from the supine position. It's not holding the baby from the abdomen. It's just we need to pull the infant from one arm and see how the arm protection is there. So we need to score whether it is 0, 1, or 3. So if the arms are fully flexed, we say that it could be the scores are 0. If arms are semi-flexed, it's 1. And when arms are fully extended, it's score 3. And we check for the tendon reflexes. Here we use the reflex hammer, and we see whether there is a clonus or an absent DTR, or whether it is easily elicited, or whether there is a brisk response. And when you're checking for the third item, that is vertical suspension, so here you will try to hold the infant near the axilla, under the axilla, making sure that the legs will not touch the floor. So here we need to notice whether there is a kicking response, or whether there is a kicking response symmetrically, or whether there is an asymmetrical response. Here we will try to identify whether the baby is having, whether the infant is having asymmetry in the posture or the movement. If there is an asymmetry in the scores, we would be ideally thinking about the clinical reasoning, saying that it could be a hemi. So the fourth component is the lateral tilting, as here described. Hold infant up vertically near to hips and tilt sideways towards the horizontally. So you can see in the video how it will be performed. And also the fourth one is how to do the forward parachute. Hold the infant up vertically and then quickly tilt forward and see for the response how the baby is doing it. It's next slide now. We'll watch the video of how to assess the assessment of reflexes and reactions. The last, yeah. So this is the arm protection reaction, how we see pulling the infant's one arm and see how the reaction is in the other arm. If you're looking, when you're doing the vertical suspension, look for the kicking movements, whether it is symmetrical or asymmetrical. So when you're doing the lateral tilting, you need to see the orientation between the body and also the head orientation. Okay. So the next scoring and the research work will be presented by Sundar.
Okay. That happened. Okay, just we will go into the scoring and interpretation of Hein. Why we need to, this is the basic fundamental question. Why are we doing Hammersmith Infant Neurological Examination? There are two possible problems and solution for why we do an Hammersmith Infant Neurological Examination. Next. It's not moving. So the first question is, the first problem is, now if you see the global understanding of when cerebral palsy was diagnosed, the average age of diagnosis is 12 to 24 months. That is something which we always consider as a very delayed diagnosis. Now, what would happen if there is a delayed diagnosis? If there is a delayed diagnosis, you will see worse long-term functional outcome, parental dissatisfaction, and high rates of mental health problems among parents. That is something which is really unavoidable. And second thing is, if you see, when the neural plasticity works the best, in the first 2 years of life. If you try to capture a child less than 2 years and start intervening them, you would be able to get more functional gains than intervening them after 2 years. Imagine that, no, I'm doing a diagnosis at 24 months, that is 2 years, and then start intervening is quite late. If you see the corticospinal tract development happens between 3 to 12 months. Now that is where we should be actually intervening children. You would see a lot of synaptic formation and synaptic pruning at that age. So that is why it is very important that you would start identifying, picking up babies at risk of cerebral palsy or giving a diagnosis of cerebral palsy at the age of 3 months would be a prudent thing. Now imagine this doesn't happen in an adult world. Now imagine if somebody gets a stroke. You don't tell them, no, let's wait for 1 year and then come back and then we would start intervening. That is what quietly we are doing it for all these babies. When they have a birth asphyxia or a birth injury, we are always going into a mode of wait and watch. Let's wait and watch and see how the baby is growing. And then let's start intervening when the baby starts showing a profound delay. That should not be the case. We should be picking up all these babies much earlier and start intervening at a point where there is a very good brain development. So what is the second problem? The second problem is 50% of the children who are graduates from neonatal intensive care unit. So you have a clear-cut neurological event, neurological history, but there are other 50% who do not have neurological history. They come at 6 months and 7 months, the family will come to you and say that, no, I feel that my baby is not growing well. I feel that my baby is holding the neck not well, or my baby is not rolling over. Then because there is no neurological event, we will say, okay, we will wait and see. That should not be the case, right? So, so the 50% are full health term. Many of the times when you go to the tier 2 and tier 3 cities, you may not even have a very good birth history record. So it becomes extremely challenging to know what has happened to the baby at birth. So entirely relying on a neurological event at birth may not be the prudent thing to do. So it's very important when a family walks into your clinic and then say about a developmental concern, we should find a way to assess that developmental concern and see whether this baby qualifies for an early intervention. So this is one of the profound paper that changed the entire way we start evaluating babies for early intervention, screening babies for very early intervention. If you have not read this paper, I would highly recommend you to read this paper because it gives you a very good protocol for doing an early diagnosis. So this particular algorithm is based on the paper. You see that less than 5 months and more than 5 months corrected age. Now, what are the tools that are available for us to screen the baby for early diagnosis? So Hein features among the MRI and general movements, which you have learned in the morning. What does this research paper say? The research paper says that we should be using general movements and Hein to identify babies at risk of cerebral palsy. If you're looking at baby at 3 months or 4 months, you should be able to conduct a general movement assessment, and then you should be able to conduct a Hein assessment and come to a conclusion that whether this baby qualifies for early intervention or this baby is at risk of cerebral palsy and should be enrolled for early intervention. There is no wait and watch approach. We will always say that if a family comes up with a concern, that concern is 100% genuine. We need to evaluate them. We should not reinforce them with wait and watch approach. And why it is important to screen them early? Because CP specific intervention is different from other developmental intervention. Even for example, if the therapy, the physiotherapy that is specific for cerebral palsy is quite different from a physiotherapy that is addressed to a child with Down syndrome or any other genetic syndromes. That is why it is very important to pick up these babies much earlier. One of the disclaimer is I do not do diagnosis personally. What I do is I use these screening tools to basically screen them and then refer them to a developmental pediatrician or a pediatric neurologist for a formal diagnosis. So when we look at this is a data. If you look at this data, these are the tools that are available for evaluation. It is invasive and non-invasive evaluation, investigation, and then physical examination. Look at Hein. Hein has 90% sensitivity and 90% specificity for picking up children at risk of cerebral palsy. Okay, so coming back to the global score. Remember, the global score for Hein is 78. And then the most important thing in a Hein summary, this is, you can download it. You go to Google and then do an Hammersmith Infant Neurological Examination. You will get a PDF. You can use the scoring form. It is free. So you look at the global score and the number of asymmetries. The section scores are not that important. I will also talk about the section scores. How do you do a little bit of an interpretation of section scores? But what is more important for qualifying for early intervention is the global score and number of asymmetries. Okay, so this is the frequency distribution of global score at 12 months and 18 months. If you look at 12 months, the average score is 73. What does that mean? If I have a typically growing baby, if I do a Hein at 12 months, they would eventually score at 73. If it is at 18 months, a typically growing baby will score at 74 out of 78. So that's the score that typically growing babies will do. So this is a frequency distribution for each segment, but look at the global score. The global score average is now 73. 73 for 12 months and 74 for 18 months. So the prognostic value of optimality score in preterm infants, the score of 64 and above in preterm infants predicts walking at 2 years. What an amazing thing it is. If I do a Hein for a preterm infant at 3 months of age, if they score 64, I can predict that this baby will walk at 2 years, right? And a score of 52 to 64, if a child scores between 52 to 64, they can sit independently. Probably they may not be walkers. If they score around less than 52, probably you can classify them as a severe motor impairment. Okay, how does Hein relate with brain injury? Now for PVL, if a child has a PVL, what are the scores you will see? You will see an increase in neck trunk extensor tone, abnormal arm protection, and forward parachute. If you look at only 3 things, of the hind, neck, trunk extensor tone, abnormal arm protection and forward parachute. If these 3 things are abnormal, these 3 items in hind can predict cerebral palsy. And for neonatal encephalopathy, low scores correlate with severe basal ganglia injury. If I see a child who has HIE, and then the scores are very low, probably they score less than 40. Probably I can predict that they may have a diffuse white matter lesion or a basal ganglia. A score less than 40 predicts difficulty sitting at 2 years. Now, less than 40 is a severe motor impairment. That's what we have discussed before. 60 to 67 predicts walking at 2 years. If the child scores fall between 60 to 67, it predicts walking at 2 years or no CP. Now, this is the
పడుకుంటారు ఎప్పుడైనా 1 కి 2 కి ఇంజెక్షన్స్ ఉంటాయి వేసుకుంటారని
it is a term in
కర్రీ వేసేది అంతా ఏం
at 3 months
ఫోటోథెరపీ పెడతారు అప్పుడు అడ్మిషన్ ఉంది జాండీస్ వీళ్ళు చేసేది ఇంజక్షన్లు ఏమీ లేవు వాళ్ళు ఏమన్నా కంప్లైంట్ ఇస్తే చూసుకోవడానికి అంటే వచ్చి పడుకుంటే చాలు నాకు
that baby is at risk of that means that baby has to be closely monitored. The baby has to be enrolled for early intervention. At 6 months, if the score is less than 59, the baby is at risk of 9 and 12 months less than 60.
ఇప్పుడు బేసిక్ చేసుకోవడానికి ఇంకా అమ్మాయి ఒప్పుకోవట్లేదు సరిగ్గా
Scores with risk of cerebral palsy. Scores less than 40 at any age. At any age, you score less than 40. That baby is going to have a very severe cerebral palsy. Now, why we need to know this? Because
నైట్ డ్యూటీలకి లేకుండా అయితే నేను ఒప్పుకోలేను అంటే నాకైతే కాదు ఆంటీ నైట్ డ్యూటీలు లేకుండా అయితే ఆర్డర్ పంపించేసిస్తాను అక్కడ చూసుకోండి నేను అక్కడ నుంచి వేరే వాళ్ళని పిలిపించుకుంటాను అయితే నాకు ఎట్లా అంటే అడ్మిషన్స్ ఉన్నప్పుడు సరిగ్గా కొద్ది రోజులు ఈ అమ్మాయి కొద్ది రోజులు ఉంటది ఓన్లీ అమ్మాయి అంటే నైట్ డ్యూటీ చెయ్యదు కదా మీకు ఓన్లీ డే డ్యూటీసే కావాలంటే కొద్ది రోజులు ఆ పక్క చేపించేస్తుంది ఆ పక్క అయితే ఎవరో ఒకరు ఉంటారు నాకు ఉండేది పిల్లలకి ఇద్దరే కదా నాకు అది ప్రాబ్లం అవుతుంది అమ్మాయి ఒక్కటే నెల రోజులు రావాలంటే అమ్మాయి రావాలి కదా సరే కొద్ది రోజులు ఆ పక్క చేసుకోవాలండి అయితే ఆ పక్క అయితే చాలా మంది ఉంటారు వర్క్ కూడా షేర్ అవుతుంది కదా
this is high and GMFCS.
నేను చెప్తాను నేను అట్లయితే ఆ పక్క 1 month చేయించేస్తాను ఆ పక్క చేసుకోమనండి 1 month తర్వాత
used for children with cerebral palsy.
నేను చూసి చెప్తాను అంత బాగుంటే వేసిస్తాను
grade 1 is independent walker, grade 5 is bounded to wheelchair. Classification system classifies the functional ability of children with cerebral palsy. Now, time can actually correlate with gross motor function. Generally, gross motor classification is not done before 2 years. If I do a hind at 3 months, I would be able to relate with gross motor function classification. This is CP distribution in hind. Can I really understand distribution, topographical distribution of cerebral palsy by looking at the hind scores? It's possible. Okay, look at this is normal. Children who are normal, they score more than 60 till 78. Now look at hemi, bi, and quadriplegia. Quadriplegia scores 1. That is why you see most of the quadriplegics they score around 40. They fall under the severe category when you look at hind. But what is the problem is you look at hemi and di, they always score at a very similar pattern. So trying to differentiate between hemi and di becomes a little dicey. What do you need to do is to differentiate them. What you need is you need the asymmetry score. You remember the asymmetry score which we have discussed? What you do is every time when you see an asymmetry, you give a score of 1 and count how many asymmetries are there. If the asymmetries are more than 5, that child is not going to be that child is going to be cerebral palsy. Imagine a baby comes at 3 months, it's extremely difficult to pick up an hemicerebral palsy. Why it is? Because you don't see much of a difference.
అంటే ఇటన్ని లేస్తే కనుక ఇది ఆఫ్ ఇది
If you see
ఆఫ్ చేసి తీసుకోవాలి అంటే వదిలేసి
it is easy to pick up and identify an hemicerebral palsy.
కనుక
Evaluate.
ఇక్కడ
Very specific to cerebral. You know, I can send them to an hand assessment for infants. Look at more.
లేదంటే నా పక్క అందరికి పంపిస్తాను అక్కడైతే
That's the study that was published. Identified an age of more than 5 infants with hemiplegia, developing infants, and hemi with diplegic. Now, if I see a child scoring 74, imagine. But if I look at the asymmetry score, the asymmetry score shows more than 5. When you say that, you should do a validated assessment to justify that no, this child is either normal or hemiplegic cerebral palsy.
ఇందులో చాలా ఒకటి ఉంటది అది బాడీలోకి పోయి కామలేదు ఉంది కదా కామలేదంటే కరిగిచ్చేసేస్తుంది ఏం ప్రాబ్లం లేదు హీట్ అంతే రాదు మీరు 2 గంటలకు ఒకసారి బిడ్డను లేపి బిడ్డ పడుతుంది కదా అని వదిలేయకూడదు 2 గంటలకు ఒకసారి బిడ్డను లేపి పాలు దాపించుకోవాలి అర్థమైందా పాలు ముందు కంటే ఇంకొంచెం ఎక్కువ ఇవ్వాలి లైట్ పెట్టాం కదా కొంచెం ఎక్కువ పాలు ఇవ్వాలి పాలు బాగా ఇస్తే బిడ్డ బాగా నిద్రపోతుంది బిడ్డ బాగా నిద్రపోయిందంటే లైట్ కింద ఎక్కువసేపు పెట్టుకోవచ్చు మనం పాలు సరిగ్గా వేయలేదంటే బిడ్డ ఊరికే లేస్తా ఉంటది మనం లైట్ కింద ఎక్కువ పెట్టలేము అర్థమైందా పాలు బాగా ఇవ్వాలి ఒకసారి బిడ్డకి తీసినారంటే 15 నిమిషాలు పాలు ఇచ్చి పట్టుకోబెట్టండి 2 గంటల సేపు బిడ్డ బాగుంటది లైట్ అర్థమైంది కదా 2 గంటలకు ఒకసారి లేపి పాలు తాపించుకోండి లేపి ఇయ్యాల అంతే ఇదే లైట్ నీకు మామూలుగా ఒకటే పెట్టేది కొంచెం ఎక్కువ ఉండి తొందరగా తగ్గాలని 2 లైట్లు పెట్టాం ఇది పెట్టినా ఇది పెట్టడం వల్ల ఏం ప్రాబ్లం ఏం కాదు 2 పెట్టింది ఏమైనా అయితే అనుకోద్ది ఏమీ కాదు కొంచెం తొందరగా తగ్గేకి 2 పెట్టినా ఆరోగ్యం ఏం బాగుంది సరేనా చల్లు సూదులు అంటే వేసేది ఏమి ఉండదు ఇదే లైట్ అర్థమైందా బిడ్డని పాలు బాగా తాపించుకోవాలి అంతే బాగా తాపించుకుంటే బాగా పడుకుంటది తొందరగా తగ్గుతుంది
How do we come back that false positive and false negatives? The only way to reduce false positives and false negatives is taking an integrated approach. You do a general movement assessment, fine, and a pediatric neurological examination. If you combine all these three,
current
baby with early. Right?
ఏమి ప్రాబ్లం కాదు మళ్ళీ మళ్ళీ వచ్చే జబ్బు కూడా కాదు
send them for early
భయపడాల్సిందేం లేదు
risk of cerebral palsy and enroll them for an early intervention. Wait for a formal diagnosis. You can wait for a formal diagnosis but not wait for a formal intervention. Intervention has to be done early even though your diagnosis is pending. So do we have Indian cohorts? Yes, we do have an Indian cohorts. There is a study by there is a study called as LEAP CP study. I don't know whether you are aware of it. You can go and check LEAP CP study. They have screened 749 babies with general movements and hind. Of that, 142 babies were identified as 142 babies were qualified for intervention using just general movements and then hind. They were enrolled for. Study results are not out. This is a landmark study in an Indian context. So, if you look at one of the other study that was published in 2018, hind and gene can be feasibly adapted in a community context in low. Right, and then there is also another study that was done in 2014. This study comes from Manipal. And then they have checked whether there is a inter-rater and inter-rater reliability of scores. And they have found a very good intra-rater and inter-rater reliability. There are 2 examiners, they do hind. Both examiners have a very common scoring. That is what intra-rater reliability is all about. Right, so the bottom line is use hind as a screening tool. If the child scores less than the cutoff points, the first thing we need to do is we need to enroll them into an early intervention, send them to a formal evaluation to a pediatric neurologist or a developmental pediatrician. Always use integrated approach for best results. Using Hein at 9 months can predict severity of cerebral palsy at 2 years. Now, why I need to know this? Because I can talk about prognosis with the family, because families will always ask a question: will my baby become all right at later? If a baby scores less than 40 in Hein, no way this baby is going to walk. Okay, so what do you need to know? It becomes easier for us to know, gauge the prognosis and then counsel the families. And predict motor growth patterns, predict need for an adaptive equipment. We talked about it. Help to use proactive measures like hip surveillance and bone mineral density for children with cerebral palsy. Thank you. Any questions?
Thank you for the excellent presentation. Can the optimality score be extended for neonates? Fine. So
this starts at 2 months to 24 months.
Yeah. So
okay, there is another evaluation tool, screening tool called as Hammersmith neonatal neurological examination. That is entirely different from this scoring. If you see this items and the other items, items are different. Most of the items are different between the two things. So we should not confuse between the two. This one only starts at 2 months. And it is a very valid tool. Hein is a very valid tool. I don't know whether same amount of research validity has been established for HNNE. That I'm not very sure. So I would always recommend at 2 months of age, we should be able to do a Hein and identify the score and see whether the child qualifies for early intervention or not. And before that, probably, we do not have a very valid tool to evaluate.
Thank you.
Anybody else? Okay. So, shall we quickly replay those videos from
We will now look at the videos.
these three? That is not.
Now, what are we looking at is we are looking at the head posture, the spine posture. You look at the legs, you look at the feet, right? Now you look at this baby's feet, toes, you look at the toes. What do you see in the toes? Toes are curled up, right? That gives a low scoring in Hein, right? Look at the spine. The spine is very curved. The spine is not straight. This baby is 8 months. Spine is curved. And you look at the head posture. Either it is wobbling forward, wobbling side. It is not, no, it's not in midline. So you look at that, right? So the head is not stable straight. The head is falling forward. What do you see with the hand posture? The hand posture is internally rotated. This is a very classical dystonic posture. And look at the toes again. Look at the toe. I made the baby stand and look at the toes again. It's just curled up. The toes are curled up, right? How does the baby reaching? Now you typically see a baby reaching, the typical babies would reach like this. They don't go like this. Baby reaches with lot of an internal rotation in the shoulder. So that is abnormal. So when I look at the quantity of movement, this is the quality of movement, not quantity, quality of movement, this is abnormal. Next one. This one. So if you look at arm protection, you're trying to lift the baby from one hand. What do you need to see in the other hand is the baby has to extend the arm and then take weight on the arm. If you see in this baby, the baby is having a very flexed arm. The baby is not able to extend the arm to protect that side of the body. The baby is not doing that. That is arm port. In vertical suspension, what you need to see is you need to see a symmetrical kicking on both the legs. If you don't see a symmetrical kicking, then you score in the hind pro forma accordingly. And then a lateral tilting. If you do a lateral tilting, what happens is the baby has to lift the head and then legs up. If you don't see head lifting and then legs up, then you would score less in the hind pro forma. And then forward parachute. In forward parachute, the baby has to extend the arms and try to keep it on the support surface. If the baby is not doing it, the baby does not have a parachute response. Thank you.
Okay. Fine. So thank you, Dr. Indra, and thank you, Dr. Sundar. So now we move on to the next aspect of screening children. You can do, like, some of them are done regularly for everybody and some for high risk follow-ups. So let's move on to our next session. Okay. So in the morning sessions, it has been quite clearly covered when and where to do the follow-up. So I will not repeat any of those. So we'll just look at a few things that you can quickly use in a busy pediatric OPD to screen. So one of them is the screening using this online app or even in the web browser, which Dr. Nandini Mundukar has gone through in the morning. This is a free thing. And you score and you get instant scoring results. So there's nothing else you need to do. You can even train your receptionists, nurses in your clinics to do it. So it is a very quick one and easy to use, or you can even ask the parents to keep doing it. So if the scores are low, you can refer on. Okay. So this is one of, and there are quite a few out there. Even these days, if you actually look at some of the EMRs, if you're using EMRs in your OPDs, they're embedded when they come for vaccination. So they're just like a tick box. So just ask them and just move on. So if you're going into EMRs, there's some in EMRs. This is one of the American Academy that has, so it's a readily available one. So all you need to do is put up a laminate, print it out, laminate and keep it in your OPDs and ask for the questions. So there are two of them based on the age. So when they come for the regular vaccinations, you can ask them, or even the nurse. If your nurses are doing it, you can ask your nurses to do it. The whole point is to try and pick up as early as possible. So from morning, you've been listening and hearing about neuroplasticity. So that is very, very important that we all really pick these things up early and intervene early. That is the key message that we want to really put across. So Tamil Nadu, they have the IAP, they have put this out. So again, you have the green, yellow, red boxes at the side. It's just about asking or just looking at what the children are doing. So there are some tools readily available out there. So please use them. And if any what difficulties or any uncertainty, you can even take videos and share or discuss and move forward from that. So these are all the basic things. The other important thing what we see these days, what is coming up day in and day out, which is becoming like another pandemic, you can say, is autism. So even with this, we see so many children presenting late only because they're being told by pediatricians or the doctors or whoever, saying as they grow, they will go get better. But again, as we've been talking about this neuroplasticity, we can do and we can see changes in these children. So again, from the when to do follow-up, when to do the thing, you would have seen 18 months and 24 months is when you have to do an MChat for all children presenting, because it's not just in high risk, it can be, especially autism can also be and it is quite rampant even in normal children. So at 18 months and 24 months, we have to screen everybody for MChat. And again, some of the EMRs I have seen already has them embedded, or even there are the online tools where all you have to do is ask questions, put in yes, no, and in the end, it will only give you a score, so that you don't even have to do the scoring at the end. But again, when you're doing it, you need to do it properly, because we see a lot of parents also coming in saying, we did MChat, but the scoring is so much. So how do you actually perform a MChat is what we are going to concentrate on this session. So I would now request our psychologist, Ms. Apurva, to come, and our special educator, Lakshmi. They will do this and show you how it is done and what are the difficulties, where you might be finding trouble. And again, all of you, if you have pen and paper or on your phones, as we go through the questions, as she starts asking, so it'll be like a role play here. So she's a mother and she's a psychologist or the nurse sitting in the clinic or whoever. So she's going to be asking questions, and all of you also, please, even whoever is watching this online also, please make a note. If you don't have pen and paper, even in your phones, on notes or wherever, so say yes or no. And then in the last, we will compare and see if there is any discrepancies on how you're scoring, how we are scoring, how it should be done. Okay. So now I hand over the mic to Ms.
Thank you, Dr. Gauri. Good afternoon, everyone. So before we start the role play, just a little bit about the modified checklist for autism in toddlers. In short, it's called MCHAT-R. It was developed by Diana Robbins, Deborah Fain, and Marianne Barton. This was the revised version. The first version was had 23 questions, and this one has 20 questions. They're very direct, clear questions that we can ask to the caregiver, to the parent. It's a yes and no. Every question has a yes and no response that the parent has to tell about the child. It is used for children between 16 and 30 months. It is recommended to screen children at 18 and 24 months. It's extremely reliable and validated. And tools it can be administered when children come for regular immunization. It can be administered by a head nurse, a senior nurse. It can be administered by a pediatrician. We are asked to do it as well for all the children who come. So we will be starting the role play now. For any questions, any clarifications, we'll do it at the end of the role play. So I am the psychologist, and Lakshmi here will be role playing the role of a parent. For some of you who want to do it parallelly with us, if you have a child in mind, or with the answers that Ms. Lakshmi gives, if you can search on Google MCHAT-R, a list of links are going to come up. The one that directly leads you to the MCHAT PDF is https
Pad Dallas, PADDALLAS.com. It's we'll just be posting the link on the chat box as well. Third or the fourth one. Yeah, that. Hello, ma'am. Hi. So, I am seeing the case history of your child. We will try to understand more about his behavior today. Your child's name is K and he's 2 years old. Am I right? Yes. So I'm going to ask you a few questions. You have to answer them as yes or no. Okay. Please think about the behaviors of your child and give me a yes or no answer. Okay. So if you point at something across the room, does your child look at it? What you're pointing at? Supposing there's a biscuit, supposing there's a toy, does your child look at it when you point? No. So I'm just going to write down my schools as well. Do you ever think your child is not able to listen? Do you think he might be deaf? Have you ever wondered?
No, because whenever we play his favorite song on the TV or on the phone, and if he's in another room, he just comes over. The only reason when we call his name, he does not come to the other room.
So he's able to listen to objects, he's able to listen to people singing on the TV.
Yes.
But if you call him, he's not looking.
Yes.
So that means that you don't think you've never thought that he might be hard of hearing. Does your child do pretend play? Like if there is a cup, they will try to drink, pretend act like they're drinking water.
So he does pretend to drink and eat, but it's only when I do it. So I show him how to do it, and then he does it.
Okay. On his own, have you ever seen him while playing?
No.
Maybe there's a car and he dashes the car, or he plays with an animal, pretending like it's jumping, making an animal sound.
No.
So only when you show it, he copies it.
Yes.
Does your child like to climb on things? It could be playground equipment, it could be furniture at home.
No.
Have you ever seen your child making odd finger movements near his eyes? Something that maybe a child of his age you will not be seeing regularly they do it, but it's a little bit odd, it's a little bit unusual.
I have a video. Can I share it with you?
Sure. moving on. The next question. So does your child point with one finger to ask for something?
No. So if he wants something, he pulls me and then takes my hand and makes me.
So you are saying that he will pull your hand, he may lead you.
Yes.
But does he use his own hand to point?
No.
Could be his favorite thing, it could be something that he likes.
No.
So he doesn't use his own hand to point. Does your child point to show something interesting? Something that's interesting for him. It could be an aeroplane in the sky, or it could be a truck on the road.
No. He will look, but he does not show it to us.
Is your child interested in other children?
Actually, because of this COVID situation, I'm not able to expose my child to any other children's around. Even in the apartment, it's very difficult to get a child around.
So supposing there are family members, there are cousins on the phone in a video call, does your child come? Does he see? Does he smile? Does he show interest by smiling or by touching the screen?
He does comes, looks, and then goes away.
Does your child show you things by bringing them to you?
He does get the things, but it's only like when he cannot open a box or when he want me to switch on his favorite toy. So that's when he gets the.
So it's only for help, maybe.
Yes.
But not to share an interest with
No.
you or something that is giving him happiness. That sharing is.
No, it's not that.
Does your child respond when you call his name?
Yes.
So you told me this earlier. When you, so just a clarification, you said he responds to when you call. So would that be always or?
Yes, most of the time he does respond.
Okay. How, in a day, if you call him 10 times, do you think he responds all the 10 times?
No.
Sometimes it happens that, like if you and me, somebody, even if we are engrossed in watching a video, if somebody calls, it's an instinct to respond. So do you think that consistency in responding to name is there?
No, if he's with his favorite toys, then no.
When you smile at your child, does he smile back at you?
No.
It's a blank expression?
Yes.
Or it's maybe looking away?
He does looks at me, then next moment he just turns around.
So right, okay, let's move on. Does your child get upset by everyday noises? It could be a cooker sound, it could be sometimes loud music.
No, he's okay with all the sounds.
Can your child walk?
Yes.
So when you look your child in the eye, when you're talking to him, playing with him, dressing him, does he look at you in your eye?
He does looks only when I tickle him or give him massage. It's the only time he looks. Otherwise, no.
So do you think he can, so he looks and looks away, or he looks and stays there with you? Can he maintain that eye contact with you?
No.
Does your child try to copy what you do?
I think
Does he copy?
I have a video. Just have a look at it.
Okay.
Good. If you're exciting and the noise, say hooray! Hooray! Hooray, mana? Hooray, hooray, hooray! Good. Hooray! 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 Good. Good, Kalyan. Kalyan, good boy. Good boy, Kalyan.
Just a few more questions left, ma'am. If you turn your head to look at something, does your child look at that object?
No.
Does your child try to get you to watch him? So for example, if he's done something good, he wants appreciation, so he looks at you.
No.
So if he does something that maybe he's proud of, how does he respond? Is there any kind of coming and sharing with you of that joy or that achievement?
No.
Does your child understand what you tell him to do? You give him a small instruction, put the book on the chair.
So as we follow daily routine, if I ask him, like if you're going out, then I'll ask him, go get your shoes, then he does. But if I say something new, which I have not done it, or we don't follow at home, then he doesn't.
So something that he's familiar with, he's able to do, but spontaneously following a new instruction is difficult.
Yes.
If something new happens, if there's something exciting, if he hears something new, sees something new, does he look at your face for your reaction?
I have a video, let's have a look.
Almost done. Your turn.
So clearly, I can understand from the video that if something exciting is happening, there's no response really. There's
Yeah.
no looking at you for your response. There's no pointing and looking at you. Hey, look, this is something new, something attractive, something musical, something that's giving light. Coming to the last question, ma'am. Does your child like movement activities? Singing, bouncing knees?
Yes, he likes to jump on the trampoline, likes to swing, slide. Yeah.
So let me score this, ma'am, and I'll get back to you.
Okay.
Thank you.
Thank you.
So our role play ended there. I hope some of you did it with us, and we can now move to the scoring and the answers. Do you want to tally your answers? Some of you here, some of you online.
If again online, you can put it in the chat box, and over here, if any of the answers is not matching to here, please tell us the questions which did not tally. So they've all tallied well. That will be wonderful. No, if they put it up, we will know. Okay. So shall we go through some of those questions? You want to bring them up, the questions? Maybe 10 we can go through again. So you want to read out the question? You want to do it one by one? Yeah. So go back to the first question slide. Right. Again, want to? No, you can't. Okay. So now what is it that we are kind of looking at here? Again, with autism, what are the features that we are trying to pick up? What is it that is lacking? Anybody can say what we are trying to look with this question? Okay. So we are all kind of trying to assess how much engagement the child is having, joint attention, sharing, those things. So when you point at something, is the child actually looking at your finger, seeing what you're pointing at? So that is what we are looking here. So again, this is quite a straightforward question. If you feel your child is deaf or not, quite a lot of the times the parents will say, no, the child can hear, but it depends upon what it is. Only if it is their favorite advertisement or music, something on the TV or some activity they like, they respond. Other times they don't. So this is all about pretend play. So again, what they were trying to elicit here is, what the parent here was saying is something about imitation. So only when the mother is doing it, the child copies. So that is imitation, and that is not pretend play. So that is something that you need to differentiate it from. So pretend plays, they do it spontaneously. So they look at something and just go and like, or while they're playing, they spontaneously do it. So climbing, gone to things. So this is like not just knowing that, okay, yeah, my child can climb on the sofa, he can do it. It is about being excessively doing it all the time. So they always want to keep climbing on chairs or tables or whatever they look. So they just want to keep climbing. So this is all about their repetitive behaviors is what we are trying to look over here. Okay, so unusual finger movements. I think in the video it was quite clear. So they take their hand and they try to kind of look at things. Again, even morning when Dr. Kirtika was going through, she also showed some of the videos that were kind of looking for that repetitive or kind of stimming kind of a thing that they are trying. Again, that is kind of a visual stimming that is going on. So again, pointing. So this is quite an important thing. So are they pointing with their finger? So when you ask a child, how does the child communicate to you if they want something? They say they ask for it. So you need to be more specific. How do they do it? Then they say the child comes and uses gestures, but what kind of gestures? So they hold the parent or they drag them somewhere. And after that, do they use the parent or the other person's hand to point at things, or do they use their own hand to point at things? So what is happening? So many a times they just use the parent's hand to point at things. So what are they actually doing here? So here what is happening is, it's the parent is actually not another person. They're just using them as a tool to get what they want. So it's all, whatever communication is happening here is mainly need-based communication is what we call. So it's only when they need something, they come to you. If they want something, so if they can't reach something, they just climb up over you and take it. So they're just using you as a tool to climb up, or they're using you to get something. So they're not actually looking at the other person as another person here. So again, this is like sharing of enjoyment. So they're all in their own world. So there's no kind of a communication happening with somebody else. So is your child interested in other children? So again, we every day now listen to it, like what Lakshmi was saying, that in the COVID situation, the child is not exposed. So if any other relative comes in, or any other child comes in, or you take the child somewhere, so does the child at least look, observe what is the child doing? So at this age, again, going back to the pointing thing, so point with one finger. So at 1.5 years of age, the child is not pointing in itself as a red flag. So when you're doing the screening test at 18 months, 24 months, they're not doing it, is quite a bit red flag. So again, so on the video thing, so some parents might say, okay, the children, especially with the exposure to a lot of screen time, they say when they look at children in videos on the mobiles or on the TVs, they get excited. So they are interested. That is not being interested. Again, there is no two-way communication happening there. It's just that the child is just intrigued by something going on there. So again, it's a video conversation or somebody coming in. Does the child observe or just look, okay, there's some noise, but not having that sustained attention and going back, or trying to look or watch what the child, what the other person is doing. So again, this is like sharing of their joy about what is happening. So are they just being happy by themselves, or are they sharing the joy? So does your child respond to you when you call his or her name? So again, these days, especially with being in the lockdown, it's just the parents and the child. And again, over here, one more thing to understand is something called generalization. So over here, children with the particular caregiver or the close people around them, they may respond or do things, but they won't be able to apply the same things around to others. So when the parents are calling, they might be responding, but when you call or when others call, they might not. So when the parents are saying, yes, they are actually responding to me, the other thing to again know here is, do they respond to anybody calling them, or is it just you or me? Many times you will find that when the mother calls, the child responds. Even when the father calls, the child is not responding. So that is again no. So this is where all you will actually find discrepancies when parents themselves do these things and come to your clinic and said, no, this is, you're not giving me the right scoring. They actually come and argue as well. So again, these are few things that you need to be aware while you're doing these things. So when you smile at your child, does he or she smile back? So again, what was demonstrated here is like, it's only during that little play that the parent or the caregiver is getting kind of that reciprocal interaction. But again, many of the other times the child is not at all interested, total lack of connection. So they might either briefly just look and watch away, or they're not smiling at all. So again, this is something what you're looking for with the noises is about the sensory issues. So how are they processing the noise? So are they hyper or hyposensitive? So again, having a bit of sensory issues is what we are picking up, because they can be part of the autism. So does your child walk is again just the gross motor. So again, so does your child look into your eye? So one important thing here is not just looking or reciprocating, it is also the quality of the eye contact. So while calling him or dressing or having bath or having a conversation playing, so they look at you and just for a brief moment and look away, or is the eye contact sustained? That is the other thing you need to make sure. So if it is not sustained, again, it is a no. So again, this is about imitation skills. Again, in the video, what you saw, you want to say something about the video? Apurva, how would you interpret it?
So when the mother was singing a rhyme, she was basically singing, if you're happy and you know, clap your hands. And the child took about half a second to understand, but he was able to imitate immediately. So that spontaneous imitation is what we look for. If they try and do it at a later time, then that's not something we consider as a yes, but immediate response. And after that, when the mother smiled, he even smiled back at her. So that interaction was seen in the video.
Yeah. So they, again, when you looked at the video prolonged, the child was actually copying and doing things. So again, what would you say with this question? When you turn your head to look at something, does your child look around to see what you're looking at? What are we looking at over here? So what we are trying to look here is for joint attention, is what we call joint attention. So again, what you are interested in, are you able to make the child also interested to look at it? So get the attention. So is the child along with you in the lines and looking at it? So does your child try to get you to watch him or her? So again, quite a lot of times the child is doing something, they do get excited when they do something, but they clap, they're happy to themselves and they just move on. But sometimes you do see that they do share their excitement with others. Again, this is all about sharing. So again, does your child understand when you tell him or her to do something? So when they were enacting this, what they were trying to say or segregate is, there is something that these children might have learned to do. It's a routine. So they know if they're going out, they have to wear a shoe. It is not something they have to understand what is being told and perform. That is what they were trying to kind of segregate. So is it something a learned task? So like a habitual thing, or is it something that the child is able to comprehend and respond? Like what Dr. Kirtika was saying earlier about one-step command. So at this age, you're looking if they are able to perform that one-step command. So it's all about looking at their receptive skills. So again, this is again to kind of see what is happening. So does the child kind of trying to look at you to see what your response is, if the child is kind of trying to kind of maybe validate what they are feeling and see if the parents or others around are also feeling the same thing here. Okay. So does your child like movement activities? So it's not just about liking. Again, this is again the repetitive behaviors, what we are looking for. Excessively, they just want to keep going. They can't wait for their turn. They want to go onto the swing. They don't want to come off. They create such a tantrum. They just want to jump all the time, or they ask you to make them bounce them all the time. So that is what we are looking for here. So now I would like Ms. Apurva to say why she's marked this red and how they score it.
So I hope your scores tally with what we've put up. I'll also explain. So the scoring is, there are 20 questions, except for item 2, 5, and 12. No is an at-risk response. Okay. And 2, 5, and 12, items number 2, 5, and 12, yes is an at-risk response. Okay. So this is how we kind of interpret it. So this is a screening tool to check whether they're at risk. So we, at the end of it, understand whether it's a low risk, a medium risk, or a high risk. So a score between 0 and 2, they will be at a low risk. This is when we need to tell them, keep following it up. Keep check on your developmental milestones. That is what we recommend. If we get a medium risk, then again, regularly strict follow-up. It could warrant a evaluation, a detailed evaluation. This is a screening tool, but there are diagnostic tools that we need to implement at this stage. And if it is a high risk, without question, early intervention has to begin as soon as possible. So yeah, we'll be happy to clarify any of the questions.
Anybody have any questions? Okay, so I hope at least whoever attended this will be doing a MChat at least 18 and 24 months. Okay, so that's it then. So next we'll be moving on to our case presentation. So let's move on to the last bit of our workshop today. So again, we've been looking at different aspects of development and different interventions. So again, this is just to show a little bit about how our team, so this is our team here from Aster. So we have a multidisciplinary team, and this is just to show a little glimpse about how we work and how a team together can actually make a difference. So a lot of the children, when we see them coming, they're already been to several centers, they keep going. So physiotherapy is in one corner of the place, speech and language therapy is in one part of the place, and neurologist is in one place. So there's a lot of movement happening. Again, it's not just the movement. Again, already they just having a child with a problem itself is such a big thing for the parents. So already they're in such a lot of stress. They want their child to get better, to do well, and again, moving around. So that itself has stress to them. It is a stress to the child. And again, all these stresses itself can be such a big barrier. So commuting, the time, the money that is all involved. And again, they come back and say, okay, we went there, but they're doing the same thing as this person is doing. So again, there is no kind of a connect or communication happening in between. So this is just to show how a multidisciplinary team works in the form of a case. Okay, so okay, so for those who don't know, I'm Dr. Gauri. I'm the child development physician working in Aster Hospital. So earlier you've seen Dr. Ravi Kamar. He's the pediatric neurologist there. So the case we are going to be discussing today is a 6.5 months male child who was born to a second-degree consanguineously married couple. So full-term normal delivery, baby cried immediately after birth, birth weight 2.5 kilos. There was no perinatal events of note. So this child started developing seizures around 5 months. And then around the same time, they started noticing regression of milestones. So as you all are aware, any form of regressions are red flags. So again, when you go into the family history, there is seizures. So when they come in, these are all only the positive factors that affect this case that have been highlighted. So when they come in, so over here, the child presented to Dr. Ravi Kumar because of the seizures. So he's managed the seizure bed, EEG, MRI, all the investigations done. At the same time, because there was regression in milestones, the child came and saw me as well. So he's been managing the seizures and seizure activity. And again, when the child is having ongoing seizure, that itself is a big stress. So any form of intervention will be quite difficult. So his role over here has been in management of the seizures and getting it under control with the right kind of investigation and management with the medications. So then when they came to me, so we've gone through the history. So again, one examination. So vision, fix and follow wasn't there. And I think this child had the hearing test and it was normal. So that I have not put up here. And auditory again, but still we are checking each time. So auditory response was good. There was low tone. This is 6.5-month child with still not having head control, and only cooing was present. So based on these findings, we were suspecting global developmental delay along with corticovisual impairment. So again, the fixing and following wasn't there. So we moved on to the next set of process, that are the assessments. So our pediatric physiotherapist, Dr. Indra, she is the one who did the NDT. So DASI was done by our psychologist, Ms. Apurva, and CVI by our optometrist here, Ms. Soumya, and you met Mr. Aditya Goyal in the morning's talk. So again, this child did warrant genetic testing. So we do have genetic testing services as well. But because of the constraints, the family could not go ahead with genetic testing because of the consanguinity and the family history. Ideally, we would have wanted it, but over here, we couldn't. So individually, we'll have to process and see what is possible. So so again, NDT will cover the gross, the physical aspect, gross motor aspects, and DASI will also give us about the indication of their motor age and mental age. So you can see how, even though the child was 6.5 months, the motor age was just 1.5 months and the mental age of 1 month. So next we planned our therapy sessions based on the requirements. So they had to have the physiotherapy and the early stimulation from our special educator and the visual stimulus that is happening with our optometrist. So now I hand over to Indra to kind of go through what she's been doing.
So first, when the baby came to OPD, physio OPD, so I'll be taking the history based upon. So when the baby comes to the physiotherapy OPD, I'll be checking for the neurodevelopmental approach. What works for the baby depending upon the guidelines that we do based upon the NDT approach. So looking at the guidelines of assessments that we do in NDT is we take history, which is already mapped from the previous assessment, and the parental concerns, which is the major thing. And then we will check for the examination of the functional skills based upon the age appropriate milestones. And then we will check for the examination of posture and movement. And then the systems review. So looking at the all aspects, I'll be talking about what is lagging in the baby and how to approach in that manner. So already what are the parental concerns are the reduced head control and regression of milestones, head control and rolling, and there is an absence of appropriate visual fixation and tracking. And we already know the history is already mapped, so not going much detail in about that. So coming to what age appropriate milestones, the second component of examination, that is mapping the developmental milestones, knowing what gross motor milestones that baby achieved. There is no head control, but it was regressed, and rollover, but it was not observed now. So when coming to the fine motor milestones, the baby can only retain the rattle if it is placed in his hands. So, and then there is we can say that there is a bidextrous rigid grasp, but there is no movement. When coming to the language, the baby only cooing was present. And when looking at the behavior, baby is awake, but has not showing any interest, because it could be because affecting due to the vision impairment. And he responds to sounds, but not visually tracking.
So over here, so there is no kind of reciprocal smile. So the baby is happy, active, smiling, but when looking at the face, there is no smile. So when the object is placed close by, there's no reaching, but if it is placed close to the hand, the baby grabs. So again, over here, it is very important to see kind of how one area, because the vision fixing is not there. Is that the one causing the other areas, what the lag in the other areas, or is it the problem with the fine motor? So it is, you need to kind of factor in everything. So one area of development is very much influencing the areas of development in the other areas.
So when examining the neurological examine, the tone, the reflexes, we also look about the postural analysis based upon all these 5 components. That is the alignment of the body, how the baby is doing the weight shifts, whether they are present or absent, how is the baby is able to take the base of support in supine lying, sitting, and during standing with support, and how the movement strategies are helping him to gain the milestones, and what is the postural control that is he's able to learn. So, and also at the end of the evaluation, I look about the systems review at each component, that is cardiorespiratory. If the baby is having any kind of cardiorespiratory issues, I have to manage thinking in another perspective that I should not be doing proning for a long time. When coming to vision, it is always said that vision and motor is directly proportional in gaining the milestones. So, and cardiovascular, the same, the positioning of the child matters, and the neuromuscular examination and musculoskeletal examination, I will definitely be doing it. So looking at the first initial evaluation, I took Hein as an initial evaluation, looking into the cranial nerve function, the posture, the movements, the tone, reflexes, and reactions. So here, in all of the scores, he gained only the low scores, and his total gross score, global score is 31 out of 78. So this was assessed at 6.5 months in the month of March. After that, I have planned an individualized intervention plan based upon the baby's milestones and the systems review. So I have to look upon all these aspects. The essential posture and movement components to start up is how to get the head orientation when the baby is towards the vertical position, and how I have to let the baby to use the base of support appropriately for any functional activity, and then how the baby is able to align the body during any of the milestones during rolling facilitation, and how the baby is able to control the pelvis and the posture, and also the trunk dissociation and the weight bearing side during the activities. So based upon these components, I have to plan my intervention. And as a physio, so we have to look upon how the body and structure and functioning is happening, the activity and participation in the baby, and the participation includes the contextual factors, that is environment and personal factors. So basically in the OPD, I look more upon the body structure and functions, and also the activity and participation. First, initially, I have to concentrate more on the body structure and function, that I have to normalize the tone or facilitate the tone, and then go for the activity and participation intervention plan, and then take help of the psychologist how to modify the contextual factors that are the environment and the personal factors that at home. So looking upon these are the 5 F words that we need to keep in our mind for the babies and the child's development. That is fitness based upon the body structure and function, the activity that is function, and then participation with the friends in future, and the family and fun and the contextual factors. So based upon those that ICF format, I made this intervention plan. So how to facilitate the normal movement pattern with the physical guidelines, so physical guidance. And after facilitating the movement patterns only, I can go for the activity and participation. So if now at present he has received 4 months of NDT therapy, and I'll be showing the videos next. So then I have planned for the child initiated movement, task specific training, and based upon the motor variability. And I took help of the child psychologist, how to help the baby in the parental education, and giving the mother new ideas how to approach for the play stimulation. So we look at first initial assessment when I did the pull to sit, there was complete head lag. So in this video, you can see after 4 months of therapy, okay, can we watch videos at the end? Yeah. Next slide.
So over here, so Soumya was working on the vision thing. She was working on the physical thing, and our other team members, she jointly, Apurva and Lakshmi were working on how to involve the family, how to look at their stress, how to get them to engage with the child for the early stimulation. So because environmental factors, what is happening around also matters a lot. So supporting the parents, their stress levels, because that impacts on the kind of therapy or how they engage with us or engage with the child. So that has a directly proportional effect on how the child responds as well. So everything needs to be, and again, what we do is once everybody has seen the child, we sit together among ourselves and the parent and give them a plan. So it's not like each time they go, okay, physiotherapist has given so many activities, the special educator has given me so many activities, the optometrist has given me so many activities, and there's so much of confusion happening. So we sit together and talk to the parent in a MDT approach. So that gives them a bit more clarity, because at the starting, already they're assimilating that the child has so many problems. On top of that, trying to figure their head around what to do next is also a big challenge. So that is how, and again, sometimes Indra tells us, okay, this child has this sensory issue. So when you're doing your session in your room, make sure there's not too much clutter or there is not too much noise. This child doesn't like touch. So when she's doing the sensory profile, so we incorporate and we discuss and see how to kind of help the child forward.
So after receiving 4 months of therapy, baby is able to do rolling facilitation on his own, and he's able to raise his head up to 90 degrees in proning position. And then he's able to try to reach for the toy because of help of a vision therapy also that helped him to track and fix the toy. And later, now he's trying to sit with support with good postural control in the upper trunk. So these were the milestones that he received after the therapy. So now we would like to see how the motor and the vision therapy both together will help in the gaining the milestones.
Good afternoon, everyone. I'm Soumya. I'm the optometrist in Aster New Kids. And so this child was referred to us for a vision evaluation for 2 major reasons. One is that the rest of the team members, that includes the developmental physician or the neurologist and even the physiotherapist, had all noted that he was not fixating or following any objects during their observations. And the other major thing here was the seizures disorder. So anything with both of these in combination, there was a suspect for cortical visual impairment, and that's why he was referred for a vision evaluation. So when a child is referred for a vision evaluation, there are 3 things that we do step-by-step process. So the first would be a developmental history. So apart from all the birth and developmental history that the rest of the team would have already mapped, we take visual milestone history. So that includes whether he is able to give eye contact, whether there is social smile, he recognizes the parents or the or familiar people, familiar objects, he responds to familiar objects, or even plays along with his hands in front of his eyes, like moves his. Every infant is supposed to be looking at his hands and smiling. So all those milestones will be asked for and mapped. And after this history part, we do an ocular evaluation to rule out what pathologies or ocular disorders are present. So the ocular evaluation starts from visual acuity and refraction. So the visual acuity and refraction, the fixation and following, and the anterior and posterior segment evaluation, and and how whether there is any evidence of strabismus. Okay, so and the third part is the CVI assessment, where we incorporate the CVI range and observe his visual behavior.
Yeah. So on your examination, was there any ocular abnormalities you found?
Yeah, I'll just say. So when we started with the ocular examination, we did the visual acuity and fixation, where he was able to only fixate at light and not look at any object or even track an object or anything. So he was only fixating at a torch light only. And next comes when we checked for the anterior and posterior segment evaluation and pupillary reflexes. So pupillary reflex was also normal, and the anterior and posterior segment, that is the cornea or the tear film and the conjunctiva or even the retina, were all normal. So there were no pathologies over there either. And the next was refraction. We did a cycloplegic refraction where we instilled cyclopentylate drops and checked for the refractive error, and there was no refractive error recorded either. And that means there was no required for the prescription of glasses. And next we checked for eye movements, that is pursuits and saccadic eye movements. These were not initiated. We checked that with whether he could follow light So that was very minimal, and there was and whenever there was an eye movement that was supposed to be elicited, the head was moving and not the eyes. So when you're tracking with an object, the baby was trying to move the head, but not the eyes. So that was one more point. And then the Hirschberg reflex test was done to check for strabismus or squint. So that was also central, showing no evidence of strabismus. So then we moved on to the CVI assessment. So the CVI assessment is done with 10 characteristics in mind. This is as prescribed by the Roman Lanzi method. So the first one would be color. We see what color there's a preference for. So in this case, there was a preference for yellow, and this child also always had a left head tilt. So that means he was always trying to fixate only with his right visual field. And the next one was the complexity. So this was, he could fixate and follow only in a dark room. So even when the lights are on and then you shine a torch, he could not fixate on it. So that means you'll have to cut down on the environmental factors. So yeah, the visual environment, so that he could look at a certain object. And the next one was movement. So whenever there was an object or or light, only when it was moving he could fixate and follow well. So a stationary object he could not do it. And visual latency, it was present. That means after a stimulus is produced in front of the kid, it took him some certain amount of seconds or certain amount of time to actually respond to that. Then was novelty. So this was reported by the history that he does not explore any new toys given or any new objects given to him. The next was reflexes. Menace reflex was tested where it was present. So that is a positive sign for us that, yeah. The next was distance vision. And he could not track light farther than 0.5 meter. So anything farther than that, he was not able to fixate or follow. Then there was light gazing. We check for light gazing, and usually what happens is when a bright light is shown to the eyes, there is a stress response. Either they close their eyes or they cover their eyes with the hands. But here, this child with CVI was not disturbed with these bright lights, and there was tendency to fixate these lights instead. So, and the next one was visually directed reach. There was no grasping of light or object or anything. So after the entire assessment of all this, we concluded that he has cortical visual impairment because he had no other ocular pathologies, and he had a history of seizures disorder, and he had all these, he had positively responded for all of these tests. So the other observations noted here were there was no photophobia, there was no eye contact, the head tilt was there to the left, and the mother reported that he smiles at home, but there was no observation of social smile during the assessment. And the mother also reports that he was very drowsy throughout the day. So our diagnosis was cortical visual impairment in the phase 1, where it was where phase 1 is of building visual behavior. There was no prescription of glasses required, and what was recommended is visual stimulation and intervention, which is so visual stimulation is always recommended to be very intense, at least in the initial stages. So 3 days of visual intervention was given at the CDC, and the rest of the days we had trained the parents to do it at home. So visual stimulation is done using a variety of patterns, black and white patterns, and lighted objects, and other forms of lights and lights and projections. So these children have respond very well to black and white patterns initially, and then they move on to preferred colors and then to all colors. So after this child came to a therapy for us for 1.5 months on a regular basis for 3 sessions a week. So after 18 sessions of therapy, the functional goals that we achieved were that the child grasps objects and reaches for toys now. Visual latency was minimized. There was no preference to color noted, so he was responding to all colors, and he was tracking people moving around him. Social smile was present, but it was not all the time. And eye contact was also slightly developing with the mother and with the grandmother or very familiar people like that. And the mother reported that he was awake and active for most hours in the day, and he was recognizing and smiling, as I said, with the eye contact to the familiar people. And therapy is now continuing. So we can also show a video. It's not
Videos
open.
will do it at the end. So
Okay.
if you remember what Professor Goel spoke in the morning, so it's all that classical. So even if you don't have all these objects, just a mother looking at the child with something bright, if they don't wear maybe some bright or shiny jewelry or something on, and just talking. So again, the complexity is minimized. There is that kind of trying to get the attention, some just minimal bright object. So, and you can see the child is first responding to the mother and grandmother than the other people. So again, if you put that talk into context and see how the therapy responds. So this is like an example for that. Yeah, so now we move on to our psychology.
Good evening, everyone. So while there was medical management, there was vision and physiotherapy going on. We have to focus on the environment, right? And the family becomes then a very integral part of what we do as a team. So a couple of things, what we talk to the family is parent-child interaction, right? We all know that that is required. The touch, the feel, the sound of the mother, of the father has to be there so that the environment is, the best environment is given so that the child picks up and benefits from all the therapy that is happening. To do that, in order to do that, we have to first address the mental health of the mother. So maternal mental health, paternal mental health, we look into that with a lot of detail. We try and understand what are the emotions they are feeling, how they are expressing those, whether the expression is acceptable, not acceptable. Sometimes the childbirth outcome is not what they had imagined. So they come in with a lot of guilt. They come in with a lot of distress. They don't know what to do. So we talk to them about their emotions and help them to have a catharsis, release it, so that then somehow some kind of cognition, some kind of thinking then pattern starts for the parent. We also work on giving them the skills and the tools to interact with their child. Like if a simple thing, the mother has to talk to the child, not all parents, somehow it moves to giving an instruction to the child, or it moves into telling the child what to do or asking the child what this is. But we really work on the interaction pattern, telling the mother, please sing rhymes, please interact in a positive, wholesome way. Lakshmi will guide us with what she did with activities as such to the mother. But this is in general what we work with the families, helping them cope with their emotions, start thinking about the current situation that they are in a problem solving manner. And then when we see those emotions get a little better, we automatically see that their interaction with the child is much better. The mother, in fact, now is guiding other parents. Okay, if you see an early red flag, start, please go to the doctor. So she's overcome that cycle of grief and that cycle of very negative emotions to building her coping skills and her coping mechanisms in order to help the child in the best way possible. So environmental changes and activities for the child, I now hand it over to Lakshmi.
Good evening, everyone. So, as Ms. Soumya spoke, that there was no social smile, and the visual was very low. He was not able to see. So I focused more on giving activities which he could hear. So I asked the mother to sing songs, sing more rhymes. While giving bath, she can sing something related to water, that she's pouring water on him. And also when she's feeding him, she can sing or speak something which she's feeding, or she can sing some rhymes which is related to feeding. So we focused more on the rhymes and talking to the child. And also we asked the parents to make a facial expression, even though he was not able to see, but still there will be there was a change later on. We observed the mother was when she used to show exaggerated expressions and moving her head side to side, being very close to the child and doing these activities help the child to improve a little bit.
So we had a good opportunity to redo the Dasi, and we saw a couple of months of progress in the child. He joined us when he was 6.5, and now he's 11. So we did see a bit of change. There's a long way to go. Therapy has to continue, and we'll continue to work as a team to see that the child gets the most benefits of all the therapies.
So again, just seeing a little change doesn't stop. So it is a constant process of re-evaluating, assessing, because as they grow up, there are more challenges faced. There could be other problems that come in. So these children are re-evaluated every 3 to 6 months, or even before we have discussion. Okay, if we find a pattern with all our therapists, okay, this is not working, this is the cause. So we have to sit and talk to the parents again, counsel them, and see and kind of try and work on the barriers that keep forming for the progress of this child. So it's a very constant and consistent process that goes on. So we are at Aster very lucky to have a team in one place. So, and again, involving the family, because over here, it's not just the child. We are always treating as pediatricians, you know how much it goes into managing parents rather than the child. So this is how a kind of holistic approach we take, and it is working.
Hi, it's been a very long day, and good to see that the people who started from morning are still here. Because sometimes you have a lot of people, but they're busy on WhatsApp or their own conversations. But you people have been very attentive, so it shows the quality of the audience as well. Thank you very much. Let's give a big round of applause for all of us, especially for the faculty. Thank you very much. So if you have any questions, please start off. Let me also see if there is any question on the virtual. Soumya, ikkade virtual alli nodama enaride. Any questions from your end, please? Dr. Swapna, you are a very busy neonatologist. What is your take-home message from here? Sorry to.
She would have escaped if she knew you were going to.
Sorry to not mark you. She's a very busy neonatologist in Madanpalli. You go anytime. She is busy. Please tell me, Ma, any take-home message from here?
Or anything that you face that you want to share, any problems you share, so we can see how we can work together. So we have
Not the technical part, though.
we have different models where people come and stay for therapy for a while and go back.
No, till now we were thinking that was the end. When we were seeing CP child, they will ask number of questions. Anywhere to consult, what is the next thing to be done? We didn't had this much knowledge previously. Now we came to know at least 6 months child, if they are delayed by 3 months or 4 months, at least little bit improvement will be there by all these therapies. And we can diagnose the baby early and we can refer to you. This is the thing we understood from this.
So our main aim is achieved.
Referral.
Good. Well done, team.
See, many times when patients leave the NICU, they think it's over. Actually, the real battle starts afterwards. When they're in NICU, you're doing the battle. At the most, they're going through emotional trauma, financial trauma. But the real challenge starts later. And many of them thinks, okay, I'll come out of NICU, baby will be fine. And also these routine things, no? Your father was also slow, your father spoke late, your grandfather spoke late, your grandfather walked late. All these things, there is still a lot of myth. So many times people don't want to do simple in autism. The commonest challenge I face is one is to convince their child is autistic. Hearing test. Okay. So hearing test, telling them to do a hearing test. As soon as you say hearing test, chayali atwa madabeko, you not even complete. Illa keltane. He hears, he can hear. Okay, I know he can hear, but this is the basic. See, many people don't do hearing test. It's a general rule. If you are thinking of a speech therapy as a speech and language therapist, you have to do the hearing screen. It may be even ideally better, or it may be ABR or some other thing as required, but hearing test has to be done. It may be mild loss, moderate loss, you don't know. The child may be lip reading, they're very good in that. So that's a basic rule. So it will help when pediatricians who have treated the family and who know the family well, emphasize why it is being done. When they come to us for the first time, when we give a list of MRI, BERA, EEG, they don't like it. So anyway, that's one good thing. Dr. Balu, huh? Sir, you're from anything from your end, sir? How was your day today? You want to say something?
Learn so many things, sir. Learn so many things about the follow-up. How we can follow up the baby. What is new physiotherapy, speech therapy? How we can do. There's a lot of things I learned today.
Okay.
2.5 years, I think. But how to tell them that? I mean, what are the words we have to tell to convince them to send to you? Like any, because I have 2.5-year-old child, our own family. Okay, really,
That is the worst.
really there is a delay. We know it. But how to convince them that they tell that baby is improving? We'll see. We can wait.
Yes,
These are the
again,
things will
even
happen.
when we don't intervene in these children, there will be improvements. They will improve, but not at the pace that they should be.
Yeah.
So probably talking to them about the neuroplasticity. So by 3 years, 80% brain development.
Is there any use to send at this time? 2.5 years.
Definitely.
2.5 years is
Especially
more.
till 5 years, still there's so much neuroplasticity, so many new connections happening. Up till 5.
But the
there is a
golden
lot of
period is
report.
last. No.
There is no last for referral. Even
Mm.
after 5, there is growth happening. But if you say, I spend 100 rupees after the 5 thing, I get response like worth maybe 20-30 rupees. But before 5 years, when you send them and I'm spending 100, so maybe I'm getting something worth around 50-60 rupees. So the results you see is much more when.
Okay, this is a common scenario. The first and foremost, if you look at the head circumference chart from WHO, the growth, head size grows up to 5 years, out of which almost 50% is in the first year, 25% in second year, another 25% from third to fifth year. So I show them the growth chart. Look, this is the head size, which basically is the brain growing. So this is the speed at which the brain is growing in the first year. So if they have come in the second year, I say you lost 50% of the time, but still you have another 50%. So you decide what do you want to do. The second thing I tell them is in the local colloquial way, If you invest 100 rupees today in the first year, you will get almost 90 rupees back. And if you're lucky, 100 rupees back. Second year, you invest 100, you will get only 70. And third to fifth year, you invest 100 rupees, you may get 10 rupees or you may get even 0. So you decide how you are going to spend your time. You can wait because your neighbor said, your relative said, these are common excuses. You can wait. If everything goes well, you will say the relative was good, everything was good. When it goes wrong, your relative will not come to your rescue. Remember that. You are going to struggle. As a doctor, I can only help you to a certain extent. I'm not a god. I cannot reverse the time. So you go and decide. It works sometime, but there are still thick-skinned people. They will just go. They'll say wait, and sometimes we may not know the other side. Family may be in a very dire circumstances financially, so they may not come because other reasons are there, not because they don't understand. But beyond that, as a doctor, we can't do anything.
The other thing I request you all is to support these families because this is a long-term problems and they need long-term interventions. So, and again, the results they see is very slow. It's not like a medication and things are improved. So you need to kind of support them, give them that moral support and push them to kind of have follow-ups and keep going. So that is also very important.
Okay, any other questions from the audience? We have Dr. Asha Benkappa, who is a very senior pediatrician from Indira Gandhi.
Now she's in
Oh, okay. No, she was in Indira Gandhi. Okay. Thank you, madam.
Okay.
Anybody else?
Shall we show some videos of how they change?
Okay, go on. Okay. Thank you everyone for participating. Let's finish off in the next few minutes with the videos.
This was before, is it? Yeah, he was just holding. So now you can see how much of the movement is there.
Go.
Oh. So before it was just fixing to light. Now it is an object. So
talk about special education or behavioral therapy and speech. So in this case, you can see the neck control is not perfect, but still we are doing both. The child is going for both physio as well as the vision therapy. Okay, I think that's it. Can I request all of you to come for a photo? I know you're all keen to go home. We'll have a group photograph, please. Thank you.